after some time. So I request the quiz master to kindly come of the first session, Dr. Shubhalakshmi to kindly come and start the quiz.
So, good morning, everyone. As told, this is EDPACON quiz, PG quiz 2025. And we have 8 teams with us. They have all joined. And we will be starting with our quiz. We have 3 rounds taken by each of our quiz masters. And may I request to please switch on to the first slide, previous slide, जो मैंने दिया था. Sir, आप भी अपना लगा दीजिए. हाँ, हाँ, हाँ. So, we have 3 quiz masters, myself, Dr. Shubhalakshmi, Dr. Aditya, and Dr. Bhatia sir. So round wise we will be telling you about the guidelines or the this thing, marking of the quiz. And first round will be, here it will be image based basically, and it will be 10 marks to the team for which the question is meant, and 5 marks will be given to the team for 1 pass is there, and 5 marks will be given to that team. So 1 pass, next team will get 5 marks if they have also answered it correctly. So, so Dr. Piyush is judge for the quiz. He has joined actually at the right time. So he will be marking the marks. So Dr. Piyush, first round will be having 10 marks for each question, and I will be passing the question to the one more team, and if they also answer it correctly, 5 marks will be given to them as well. Okay, so first we will have short introduction of the team, I think. Team, yes. Team Santosh will be team 1, team LHMC, team RML, team Max Patpargaj, team UCMS, Sabdajan, and Maharaja Agrasen, and you, Max Vaishali. So we have 8 teams with us, and we will be moving like this only. So first question for the team, Santosh. 48-year-old woman scheduled to receive a laparoscopic cholecystectomy underwent a pre-operative evaluation that disclosed conjugated hyperbilirubinemia. A laparoscopic exploration revealed a smooth liver with normal consistency and morphological feature but with a gross black appearance. What is the diagnosis according to this picture? 30 seconds will be given to the teams for this. Would you like to attempt? Yes? Mucormycosis. Team, huh? Wait, huh? Hemochromatosis, okay. What you want to tell? Dubin-Jones.
Dr. Pooja, please come. Dr. Pooja, please.
So we have got 2 answers. First is hemochromatosis, and second they have told is Dubin-Johnson's. So actually it is Dubin-Johnson syndrome. A cardinal feature of this is accumulation of dark, coarsely granular pigment in the lysosome of central lobular hepatocyte. As a result, the liver may be appearing grossly black in appearance, and the pigmentation is thought to be derived from epinephrine metabolites that are not excreted normally. The pigment may disappear during bouts of viral hepatitis only to reaccumulate slowly after the recovery. So here team 1 has not scored anything, but team B has scored 5 points. Yeah. So next question will be for team B. A 70-year-old female presented with sudden onset of pain in left flank, back and abdomen. On examination, she appeared in shock with cold extremities. Her abdomen was soft but tender, generally with guarding in the upper left quadrant. The CT abdomen was taken, which is shown in the figure. So what is the syndrome we are dealing with? There is no minus marking, so we can attempt.
Remember renal angiomyoma, leiomyoma.
Leiomyoma, okay. And team C, would you like
Angio.
to also attempt? Okay, so time given will be, would you like to attend?
VHL one.
Huh?
VHL.
VHL.
What happened?
Okay, so let us see what actually it is. I think team B, it was slightly closer, but it is angiomyolipoma that you told, renal angiomyolipoma. So I think we can give marks through them because they have actually attempted. And answer was also correct. The terminology actually was something different, but yes, there is a large retroperitoneal hematoma with active bleeding in the left renal tumor, which was measuring 9 into 7 into 6.5 centimeter in that picture. The tumor was largely fatty component with abnormal vascularity that we can see in this picture. Compatible with large angiomyolipoma. So hematoperitoneum was also seen in the picture, and it is actually known as Wunderlich syndrome. So this is the term what is known as, and the link triad is there, which is of acute flank pain, flank mask, and hypovolumic shock. That was seen in the case also. So 10 marks to team B. Now this question will be directly to team C. A 47-year-old man presented with recent onset diabetes and significant weight loss. Shown are the image of a rash he had and his CT abdomen. The probable diagnosis is. Team C, you will have to answer it, and team D can also attempt for the same.
Ma'am, a glucagonoma with a necrolytic erythema migrans.
Okay, and team D, would you like to also attempt? Would you like to attempt? Okay. So should I proceed? That is the thing, okay. So yes, it is correct. It is necrolytic migratory angioerythema, and it is because of glucagonoma. So it is a distinct migratory blistering skin rashes, often intensely itchy and painful, characterized by red erosive crusting patches that heal in one area while appearing in another, typically around the mouth, groin, and extremities, and is a key sign of rare glucagonoma syndrome. That is a pancreatic tumor because of which this skin lesion appears, but also seen in several other malabsorption and liver diseases due to nutritional deficiency. So they have got 10 marks, and team D also has got 5 marks. They have also answered the same. So we don't have to, okay, so only if they have answered incorrect, okay, fine.
Next team will get the answer only when the first team get wrong.
Okay, okay. So now the question passes, this question will be directed to team D. A 26-year-old man presented with a 5-month history of dry cough, night sweats, and unintentional weight loss of 18 kg. During this period, epigastric pain and postprandial vomiting had also developed. His BMI was 11. On examination, he was cachexic, abdominal distension, and diffuse tenderness to palpation was seen. Chest imaging and sputum studies, a diagnosis of pulmonary tuberculosis was made, and intravenous antituberculosis treatment of initiated on the basis of this chest X-ray and sputum finding. He continued to have prolonged postprandial vomiting even after the treatment given. CT of the abdomen was obtained, and the image is shown in the next slide. And what is the cause of this abdominal symptom? That is the question. So you can see the CT image of the abdomen here, and according to this we have to tell the cause of the abdominal pain in this patient. Team D, rest of the team don't have to answer actually, so if you will murmur amongst yourself, your answer will be disclosed. Team D, it is not your turn. Team D and team E have to answer actually. So first team D. Would you like to answer, team D? your time is about to finish. Superior mesenteric artery compression. Quickly, quickly. Or it, yes, time it is. Pass. Okay. Okay, okay. ठीक है. So, team, superior mesenteric artery syndrome. Okay. So, both of the team has answered that only. So, let us see. So, it is actually superior mesenteric artery syndrome. So, team D has got 10 marks for that. This is because of significant loss of mesenteric fat. The third part of the duodenum gets compressed between aorta and the superior mesenteric artery. This leads to gastric outlet obstruction and postprandial vomiting, which was continued in this patient as well. So now team E, this is direct question for you. A 13-year-old male patient weighing 31.7 kg with congenital Epstein's anomaly was referred for cardiac surgery. Due to atrial flutter, he was treated with drug 6 milligram per kg per day since the age of 7 years. So this is the drug. Picture you can see there also. At the time of admission, the patient was in NYHA class 3 due to congestive heart failure without any pulmonary syndrome. So most strikingly, he presented with a blue-gray face pigmentation that you can see in the picture. So what is the syndrome here in this picture? Team E and team F has to answer. Team E? Time is up actually, na? You will have to answer. Have you answered? Team E, pass. Huh? We are not getting you, na, what you are telling. Pass. Team F? Team F? Blue man syndrome. Team E, have you answered anything? No. They have not answered, na? Okay. So it is passed, and this is blue man syndrome actually, and it is due to amiodarone. So that drug X was amiodarone, which was given for a prolonged period, because of which this blue man syndrome was there. And typical picture, that face discoloration of the face was there in this picture. Next team, next question will be here. Team F got 5 marks. Okay. So team F, this is for you. Next question. A 60-year-old woman presented to the emergency with upper abdominal pain. She gave history of chronic constipation, recurrent abdominal pain, breathlessness on exertion for last 1 year. On examination, respiratory examination, normal. Abdomen was mildly distended, but no organomegaly was there. Mass lesion or ascites was not detected. CBC, LFT, KFT, everything was normal. ECG and echo finding was also normal. So what is, this was the chest X-ray and CT scan of the patient. So what is the most probable diagnosis according to this picture and the scenario? Team F. Team F and team G is to... So your time is up. If you want to answer. Team F?
Chilaiditi syndrome. Chilaiditi.
Chilaiditi. What, anyone else want to answer? No. So I think they are correct. So it is, I think Chilaiditi nahi hai, it is Chilaiditi syndrome. So anterior interposition of the colon to the liver, reaching the undersurface of the right hemidiaphragm with associated upper abdominal pain. So there was gas under diaphragm in this. So this is the next question for next team. A 22-year-old man presented with complaint of chronic large bowel type of diarrhea, no associated history of fever, abdominal distension, vomiting, hematemesis, melena or hematochezia was there. No significant finding on examination. Routine lab were suggestive of iron deficiency anemia, and stool occult blood was positive. Remaining lab investigations were within normal limit. So this is the picture of the colonoscopy you can see. So what is the diagnosis? There is rectal mucosal biopsy image as well. Mike, you have the mic? Please quickly you give the mic. हाँ, this is next mic उनको दे दीजिए पीछे. Answer it quickly.
Crohn's disease.
Okay. So anything else you want to add? They have added Crohn's disease. Crohn's disease. So it is not correct. So it is eosinophilic colitis because there was this different cobblestoning type of picture in the colon that was visible. So eosinophilic colitis, which present with heme positive stool and anemia. An endoscopic image show mucosal nodularity with central umbilication characteristic of nodular lymphoid hyperplasia. That was seen in that picture. Next question is for team, last team, I think, yes. So, a 45-year-old female present in the OPD with knee pain, and knee appears like this in the presentation. So, what is the diagnosis? Team 1 also can answer for this. Last team को mic दे दीजिए. Last team को mic दे दीजिए, mic. Yes, you want to attempt? Last team? You want to attempt? So there is no minus marking. You can quickly attempt. Yes. So team 1.
Lipidicorum. Necrobiosis lipidicorum.
Okay. And team 1? Team 1, would you like to answer? Time is up. Time is same for both the teams. Okay. So answer is erythema abignii. So it is not that. It is a dermatological condition, yes, but characterized by reticular pattern of erythema and hyperpigmentation resulted from repeated and prolonged exposure to direct heat or infrared radiation. So it is because of that. So occupational exposure and all can lead to these type of this thing. So I think with this, I have completed this round first of quiz EDPACON 2025, and now Dr. Piyush will be summarizing the scores for this round.
So after round 1, team Lady Harding is at 15 points, team RML is at 10 points, team Max Parparganj is at 10 points, and team Sabdarjung is at 15 points. Rest all has yet to open the count.
So with this, we will be moving on to the next round, and for which I would like to invite Dr. Aditya. He will be taking the next round. Okay, Dr. Rupali has also joined, so welcome, Dr. Rupali.
So very good morning to all the respected physicians gathered here, and a good morning to all the teams. So we'll be starting the second round of the quiz. So I'll just briefly go through the rules. Again, the questions carry 10 marks, but they'll have two parts. Part A, 5 marks, and part B will have 5 marks. The question to which the team is given will have 30 seconds to answer once the question is fully read, and only one attempt is allowed. And the answers have to be very precise. And if the team fails to answer, then it will move on to the second team, which will get 2.5 marks for each part answered correctly. Okay, and no further passing is there. In between the questions, I have some bonus questions for which no marks are given, but lots of points of appreciation. These are open to everybody in the hall. Okay, so I think we can start with the first question. So question 1 to team A. So we have a 40-year-old male smoker who has presented with low-grade intermittent fever, cough, and intermittent moderate hemoptysis for 1 year. He has a history of associated weight loss around 5 kgs. He has been treated on clinical radiological basis with ATT for 6 months without any improvement. He had a past history of dental caries requiring tooth extraction 2 years ago. Now he came to the emergency with bouts of massive hemoptysis, and subsequent bronchoscopy revealed a mucus plug and purulent discharge with yellowish granules in the right lower lobe bronchus, which was suctioned. Histopathology revealed gram-positive bacteria showing Splendor-Hopley phenomena. The first part is what is the likely diagnosis and what is the drug of choice for this disease. 30 seconds to answer and no negative marking. 5 marks per part.
So the likely diagnosis could be Mycobacterium abscessicus and
Okay, and part B?
so carbapenems and
Okay, so that is the incorrect answer. The answer question goes to team B.
Sir, actinomycetes.
Actinomycetes for part A. Okay, and what is the treatment for actinomycetes?
Stevogluconate.
Sorry?
Stevogluconate.
Stevogluconate. Okay. So part A is correct. So the likely diagnosis is pulmonary actinomycosis. But the drug of choice is high dose IV penicillin G. So 2.5 marks to team B. So we have a bonus question for this. So what is the name of the yellow granules that were found during bronchoscopy? Anyone can answer? So right, they are called sulfur granules. And what is Splendor-Hopley phenomena? Right. So sulfur granules, and there are eosinophilic immune complex formation which are radiating intensely. These are found in various microorganisms, but among the bacteria, they are more commonly seen in actinomyces and nocardia. Okay. So question 2 for team B. So we have a 30-year-old male with a history of alcohol abuse who was admitted to the cardiac unit with progressive shortness of breath, lower extremity edema, tachycardia, which developed gradually over several days. There was no history of any drug abuse or prior cardiac events. On examination, he was severely malnourished. Peripheral neuropathy with loss of ankle reflexes was seen. He was tachycardic, pulse was 130 with bounding pulses, warm extremities, a BP of 100 by 44 millimeter mercury, respiratory rate of 24, pulse oximetry showed 98% saturation on room air. Labs revealed hyponatremia, compensated metabolic acidosis with bicarb of 14 and a lactic acidosis with lactate of 9. Echo showed LV dysfunction with ejection fraction of 50%, and you have excluded sepsis. So the first part is what is the diagnosis and what is the most specific next step in management?
Sir, beriberi and thiamine, IV thiamine.
Okay, which type of beriberi? Wet beriberi. Okay, so the answer is correct. So the diagnosis, wet beriberi, and the next most specific step in management is IV thiamine. Okay, so it's a high output cardiac failure. So now, question to team C. So we have a 56-year-old man who presents with gradually progressive weakness of the right hand for 5 months. He reports difficulty in buttoning his shirts and occasional fasciculations in the arm. Examination shows wasted first dorsal interosseous, spasticity in the lower limbs, brisk knee reflexes, and bilateral extensor plantar responses. Sensory examination is normal. MRI C-spine is normal. Nerve conduction studies show normal sensory nerve action potentials with reduced compound motor action potential. EMG shows fibrillation potential and positive sharp waves in the multiple segments. What is a single diagnosis which best explains this condition, and name one specific pharmacological therapy used in this condition? Your answer?
so this is a case of amyotrophic arteriosclerosis, and
Okay.
the drug used is Revuzol.
Okay. So good. Both the answers are correct. Any other drug you know of for ALS recently approved by FDA? Okay. So still we'll be giving points. So the answer is ALS. So there is simultaneous upper and lower motor neuron involvement with signs of muscle wasting, fasciculation as lower motor neuron, and spasticity and brisk knee reflexes as upper motor neuron, and Raluzole and Edaravone. Okay, this is other drug. So now coming to the bonus question. Everybody knows the famous Stephen Hawking, but do you know this?
Lou Gehrig.
Okay, so this individual is Lou Gehrig, after which the disease has also been named. So 10 points to team C. Right, so we'll move on to team D. Okay. So direct question to team D. So we have a 56-year-old woman who presented the OPD. She reported seeing halos of around lights through both the eyes for a few weeks. She had no history of ocular trauma or prior refractive surgery. Her best corrected visual acuity was 20 by 20 bilaterally. And the patient is a known case of CAD with reduced ejection fraction, with atrial fibrillation, with controlled ventricular rate, and has been taking antiplatelets, ARNI, and antiarrhythmics and anticoagulants. Drugs for the same for the past 2 years. What is the ocular diagnosis demonstrated in this patient, and what is the drug of choice most likely culprit for this disorder?
Cornea verticillata, amiodarone.
Okay. Very good. So both the answers are correct. So we have vortex keratopathy or corneal verticillata, and the drug likely is amiodarone. Okay, so 10 points. Next, coming to team E. So your direct question is, in 19th century, colonial expeditions into dense equatorial forests, they were frequently disrupted by a mysterious relapsing illness that incapacitated a large number of personnel, the illness X. To counter this, the officers began issuing daily rations of a locally sourced bitter compound, substance Y, which was dissolved into groundwater and later mixed with sweetened carbonated beverages to improve the compliance among troops, later becoming a very popular drink, substance Z, which is used even nowadays. Identify the illness X and identify the substance Y. Anybody keeping time? 30 seconds to answer.
The substance Y can be cocoa.
Cocoa. Okay.
Quinine. We would like to go with malaria and quinine as our final answer.
So, I think only one attempt was allowed. So, what would you like to go with for the, for part B, you've already answered cocoa. For part A? Any marks will be given for the second? Okay. So, first we'll pass and we'll take the answers from the other team.
Oh, illness is malaria
Okay.
and substance is quinine.
Okay. So, illness is correct, it is malaria, and the substance is quinine. Okay. So, 2.5 marks to? 5 marks to team F6, team 6. Okay. So, bonus question. We have bonus question. So, identify the beverage Z which is used nowadays. Yes, sir. Sir is right. It is tonic water. Gin and tonic. So, coming to question 6 for team E. F, sorry. So, you are sitting in the OPD and reviewing the chest X-ray of a 95-year-old woman who has come with mild cough and exertional shortness of breath. While looking at the X-ray, you notice a psychic abnormality, which is shown. On questioning the patient, she mentions that she had undergone some procedure, procedure X, for a lung disease, disease Y, around the 1950s, as a part of the treatment approach used at that time. Identify the procedure X and the disease Y.
Procedure pneumectomy.
Pneumectomy, okay, and the disease?
Disease COPD.
COPD, okay, so both the answers are incorrect, so we'll move on to the other team. This, second last.
Lymphangiomyomatosis.
Okay, and the procedure is? Okay, so both teams have answered incorrectly. Anyone from the audience? Any senior faculty? This is a very old procedure which was used earlier for pulmonary tuberculosis. This is known as plombage, in which ping pong sized balls were inserted into the upper cavity of the lungs with the thought that it would cut off the air supply of the acid fast bacilli and will cause? Okay, so TB you could have guessed. Okay, so moving on to next team, Maharaj Agar Sen. So your direct question is, so 52-year-old woman with a 10-year history of diabetes and nephropathy on irregular follow-up and not on hemodialysis has presented progressive bone pain involving the hands and forearms for several months. He also complains of difficulty in gripping objects and generalized edema. There is no history of trauma. On examination, he appears pale. Musculoskeletal examination reveals tenderness over small bones of hand without overt deformity, and no joint swelling is noted. The lab parameters and X-ray is given. Identify the bony abnormality and what is the underlying associated pathophysiological process.
So the bony deformity abnormality is osteitis fibro.
Brown's tumor, osteitis fibrosa cystica.
Okay.
And underlying pathological processes, hyperparathyroidism.
Okay, could you be more specific regarding?
Secondary hyperparathyroidism.
Okay, right, correct. So the bony abnormality is Brown tumor. So it is a high bone turnover disease, and the underlying mechanism is secondary hyperparathyroidism due to CKD. Okay. So direct question to the next team. Last. Yes, this is the direct question for them. Full marks. So last team, direct question for you. So your a 40-year-old man presented to the emergency department with shortness of breath, chest pain, and reported pre-syncopal episode. On questioning, he reports increased lethargy, weakness, pallor, and an occasional blue hue to his hands over the past 2 weeks. He has a past medical history of hypertension, unprovoked pulmonary embolism, SLE, unresponsive to first-line treatment, for which he has recently started new medication. He gives a drug history of using prednisolone, methotrexate, dapsone, and hydroxychloroquine. Initial bedside observation reveal that the patient is afebrile. He has a heart rate of 85, blood pressure of 155/90, respiratory rate of 18, and a saturation of 85% on 8 liter via face mask. ECG shows a normal sinus rhythm, and his chest X-ray was unremarkable. The ABG is given. The first question is, what is the likely cause of his condition, and which specific management will you initiate for this case?
Methemoglobinemia.
Okay, and what is the specific management?
Hyperbaric oxygen.
Okay, so we'll pass the question to team 1. For part this is for part B.
Hyperbaric oxygen chamber can be used, or
only one attempt is allowed, sorry. So the part A was correct, it was acquired methemoglobinemia, and the specific management is intravenous methylene blue. So 5 marks to team. Okay. We have a bonus question for this question. So what can you identify the offending agent causing methemoglobinemia? No. One answer. Methotrexate. You said dapsone. So the correct answer is dapsone. So dapsone causes oxidative stress by generating hydroxylamine metabolites that oxidize hemoglobin iron from Fe2 plus to Fe3 plus, forming methemoglobin. So with this, I think we conclude all the rounds.
After the round 2, the scores are Team A at still 0, Team B, Lady Harding at 27.5, Team C, ABBMS and RML at 20 points, Max Patparganj at 20 points, UCMS still to open the account, Safdarjung Hospital at 20 points, Maharaja Agrasen at 10 points, and Vishali at 5 points. So we move to the last round.
Well, very good morning. मेरे वाले में थोड़ा सा स्टाइल चेंज है. इट इज़ MCQ बेस्ड. पहली बात, एक ही जो टीम है वही देगी. सही करोगे 10 मार्क्स, ना करने पे 0 और गलत पे -5 भी है. कोई पास नहीं है क्योंकि मल्टीपल चॉइस क्वेश्चन है. -5 भी है. तो बी वेरी कॉशियस. ओके, आई ट्राई टू कवर ऑल द टॉपिक्स. टीम 1 कौन सी है? Yeah. सारे क्वेश्चन नीट के हैं. इनमें से कोई टकर जाए तो लॉटरी निकल जाएगी आपकी. या इट्स अ ब्यूटीफुल क्वेश्चन. हाँ, टाइम 30 सेकेंड. मेरे तो इतने सवाल है, 20 मिनट सेकंड में हो जाएगा यार. हाँ जी, क्विकली.
सर एस्बेस्टोसिस.
है?
एस्बेस्टोसिस.
Asbestosis. Well, it's the most common wrong answer. मुझे पता है यही आएगा आंसर. I knew. इसलिए मैंने ऑप्शन रखे. चलो, बाकी लोग ट्राई करेंगे. कोई नंबर नहीं मिलेगा लेकिन ट्राई कर सकते हैं. Let me see who answers. सर, not for consultant, only for PGs. आप तो एनसाइक्लोपीडिया है नहीं आप तो. हाँ जी, anybody can answer. जल्दी जल्दी. अच्छा चलिए ऐसे कर, हाथ खड़े करो. Who says B, Bombay? C, D, E. The right answer is shocking. Answer E है, रेडॉन. आई एम श्योर. लगा शॉक बड़ी जोर का? आंसर रेडॉन. ओके, ये नीट का सवाल है. शॉर्ट डिस्कशन. रेडॉन इज ए नेचुरली अकरिंग रेडियोएक्टिव गैस फॉर्म बाय डिके ऑफ यूरेनियम इन द सॉइल एंड रॉक. ये लाइन बड़ी सरप्राइजिंगली है और आपको जान के हैरानी होगी. यूरेनियम पूरी दुनिया में है लेकिन इसकी कंसंट्रेशन इतनी कम है, नॉट एबल टू डिटेक्ट. It seep into home and building through crack floors. And how radon causes lung cancer? एक radioactive particle निकालेगा, alpha radiation, and that lead to lung DNA damage. तो क्या सीखा? Radon. ये आप पहली बार सुन रहे होगे, पहली बार. Yes or no? Yeah. Purpose is all of coming here. ये recent report थी, अखबार में थी, बिल्कुल recent. I think पिछले महीने की है कि everybody was surprised कि बेस्ट मिलकर यूरेनियम कहाँ से आ गया है. So this is just to reimpose, yes, it is true. Team B, question 2. Only for, हाँ जी, टॉक्सिकोलॉजी का सवाल है, नीट का सवाल है ये भी. आंसर खाली अपनी टीम देगी लेकिन बाकी लोग भी सोचेंगे. क्या?
Say E, none of the
है?
above. E, none of the above.
None of the above. Sure. तो क्या इलाज है इसका?
Glucagon.
Well, the answer is correct. The none of the above is the answer. This team get 10 mark. Antidote is glucagon. Why? It bypasses the beta receptors. It directly stimulates adenylyl cyclase, increasing CMP, which improve heart rate, contractility, and cardiac output. Works even when beta receptors are completely blocked. Now, एक open question, anybody can answer without any marks. जब ये ग्लूकागॉन लगाते हैं, व्हाट द अर्लियर साइड इफेक्ट कौन सा है? इमीडिएट साइड इफेक्ट कौन सा है? इमीडिएट साइड, नो मार्क्स फॉर एनीबडी कैन आंसर. ओनली PGs, नॉट फॉर कंसल्टेंट. ऑल माई क्वेश्चन आर ओनली फॉर पोस्ट ग्रेजुएट. एनीबडी क्विकली. आंसर है वॉमिटिंग. तो हर किताब में लिखा है बी रेडी विद अ सक्शन. ओके, टीम क्वेश्चन 3, टीम 3. या quickly. Okay. Time is over. Time is over. Anybody? चलो, open for all. मार्क्स नहीं मिलेंगे. Who's कितने लोग A वाले हैं? Only post graduate. B वाले कितने हैं? C वाले कितने हैं? D वाले कितने हैं? और E वाले? E में कोई नहीं है. Well, the right answer is E. Right answer E. ये क्या है? Short discussion. When we say malignant rheumatoid arthritis, fulminant systemic rapid progressive form of RA, this is due to vasculitis. And the most common is peripheral nerve, mononeuritis multiplex, एंड स्किन के अंदर लेग अल्सर्स होते हैं, ठीक है। वेल याद रहे वी हैव डिफरेंट टाइप ऑफ मेलिग्नेंट हाइपरटेंशन में अलग होता है, मेलिग्नेंट स्किन अल्सर होगा, सो डिफरेंट टाइप दिस समथिंग डिफरेंट मेलिग्नेंट आर ए वेस्कुलाइटिस। टीम 4 एसिड बेस डिस्टर्बेंस का सवाल है। ऐसी कौन सी कंडीशन है जहां पे मेटाबॉलिक एस्ट्रोसिस और अल्कोसिस इकट्ठे होते हैं एक ही पेशेंट में एक ही बार में? मोस्ट लाइकली सीन इन विच कंडीशन? हाँ जी, क्विकली। वेल टाइम इज ओवर। तो कितने लोग, ओनली पीजीज, कितने लोग ए वाले हैं, बी वाले, सी वाले, डी वाले, ई वाले? द राइट आंसर इज CRF। CRF में ड्यू टू दैट कैन लीड टू मेटाबॉलिक एसिडोसिस और वॉमिटिंग की वजह से, CRF में वॉमिटिंग बड़ी होती है, दैट कैन लीड टू alkalosis. So, short discussion. Cause of combined metabolic acidosis and alkalosis, gastroenteritis, the most common cause. Diarrhea, vomiting. Diarrhea lead to acidosis and CRF and vomiting. लैब में एक रिपोर्ट में क्या मिलेंगी? pH, CO2, bicarb are normal. The only clue is anion gap is increased. Okay. अब डायरिया में what are the cause of metabolic acidosis in diarrhea? What is the mechanism? No marks. क्या reason है? Why metabolic acidosis occur in diarrhea? There is loss of bicarbonate. Loss of alkali lead to acidosis. Next question, team 5. Baxdrostat is the use for which of the following condition? ये latest questions हैं सारे, नई ड्रग है। लेजर पॉइंटर है, लेजर पॉइंटर, यस, क्विकली। वेल द टाइम इज ओवर। कितने लोग ए वाले हैं? ओपन नाउ। क्या? यस यस, सी, फियोक्रोमोसाइटोमा। सॉरी, इज रॉन्ग आंसर, इज रॉन्ग आंसर। कितने लोग ए वाले हैं? कितने बी वाले हैं? कितने सी वाले, डी वाले, ई वाले? द राइट आंसर इज कोन सिंड्रोम। वेल बिफोर वी कम टू द आंसर, लेट अस सी ए क्विक डिस्कशन। आई विश आई हैड ए लेजर पॉइंटर। चलो यहां देखेंगे नीचे, किस है? आ जाएगा? ओके, कैसे आएगा यार? ओके ओके, ठीक है। वेल वी ऑफ दिस बेसिक बायोकेमिस्ट्री। यहाँ पे हमारे पास CY11B2 है। यहाँ पे दिस इज ब्लॉक बाई का अपना ये ड्रग जो हमारी ये 3 जगह पे ये ब्लॉक करती है। अल्टीमेटली एल्डोस्टेरोन का मेटाबॉलिज्म ये नहीं बनेगी। तो दिस इज वन ड्रग विच इज लुकिंग राइट एट द फॉर्मेशन ऑफ एल्डोस्टेरोन इन कंट्रास्ट टू स्पाइरोनोलैक्टोन और ये एपिलेरोन, ये आर ब्लॉकिंग द रिसेप्टर्स। दिस वन विच इज रियली रिमूविंग, बीमारी की जड़ को काट रही है। और यहाँ पर एक और है ड्रग का एंजाइम, दिस सो कॉल का 11B1। तो देखें क्या है। सो नाउ वी हैव द न्यू ड्रग्स, एल्डोस्टेरोन सिंथेस इनहिबिटर। टिल नाउ व्हाट यू हैड ऑल रिसेप्टर ब्लॉकर्स। तो ये नई ड्रग है बैक्डोस्टैट, ये CY11B2। B2 को हाईली सेलेक्टिव फॉर एल्डोस्टेरोन के लिए है। तो वी यूज फॉर रेजिस्टेंट हाइपरटेंशन एंड प्राइमरी हाइपर एल्डोस्टेरोन, दैट इज कॉन सिंड्रोम। ओके, अब यहाँ पर एक और है ऑसिलोस्टैट, ये कि ये 11B2 और B1 दोनों को करती है। तो दैट्स वाई इट इनहिबिट कॉर्टिसोल ऑल्सो, एल्डोस्टेरोन ऑल्सो, राइट हो। और इसको कुशिंग सिंड्रोम के लिए अप्रूवल आई है। नाउ द क्लिनिकल यूजेस ऑफ बैक्डोस्टैट, प्राइमरी रेजिस्टेंट हाइपरटेंशन एंड कोन सिंड्रोम। Now, extra question only for postgraduate. Consultant के लिए नहीं है. Edema feet is not a feature of primary hyperaldosteronism, but is a very, very important feature of secondary hyperaldosteronism. Tell me any cause of secondary hyperaldosteronism without edema feet. Secondary hyperaldosteronism without edema feet. कोई मार्क्स नहीं है इसके, सिर्फ बोनस का क्वेश्चन. हाँ जी, एनीबॉडी कैन आंसर. डायबिटिक, डायूरेटिक यूज. वेल, डायूरेटिक यूज के अंदर और कोई बढ़िया सा कोई डिजीज बताओ, कोई बढ़िया सी. Anyway, we will appreciate your answer. Anybody can ask I. The answer is gastroenteritis, Bartter syndrome and Gentleman syndrome. Bartter syndrome resemble like what? किस ड्रग का resemble करता है ये? Bartter syndrome, furosemide, और Gentleman syndrome, thiazide. ठीक है जी. Okay. Question 6. Hepatology. बायोकेमिकल रैप, ये नीट का क्वेश्चन है ये वाला, लेकिन थोड़ा आसान है. क्विकली. या टाइम ओवर. बाकी लोग करेंगे. कितने लोग ए वाले हैं, कितने लोग बी वाले, कितने लोग सी वाले, कितने डी, कितने ई वाले. The right answer is A, hepatitis A. एक होती है बायोकेमिकल लैब्स और एक होती है क्लिनिकल लैब्स. ये दोनों टाइप ए हेपेटाइटिस में होते हैं. टाइप बी इज द मोस्ट कॉमन रॉन्ग आंसर. तो दिस टीम गेट नो मार्क्स. वेल, 7 कार्डियोलॉजी, ये नई ड्रग है, नीट का सवाल है. Yeah. Team 7. No? चलो जी, टाइम ओवर. हाँ, बोलना चाहे. हाँ बोलो, एक मिनट में.
HOCM, ऑप्शन ए HOCM.
HOCM, आपको टीम 7 ही है यानी. Well, the right answer is HOCM. HOCM is right answer. The team get 10 marks. Little bit of mavacamten is a cardiac myosin inhibitor. It directly targets the cause of HOCM by reducing excessive myosin active interaction. It decreases hypercontractility and left ventricle outflow. Now, open question. कौन सी ड्रग इसमें contraindicated है? Which drug should not be given in a case of HOCM? Common, very simple question. Contraindicated. Digoxin, diuretics, they are contraindicated. The last question, last team. Which of the following may be needed when we are treating a case of pernicious anemia with vitamin B12 and folic acid? Beautiful question. हाँ जी, क्विकली. लास्ट टीम 8 कौन सी है? या
Allopurinol.
Allopurinol is the most common wrong answer. I knew ये आंसर आएगा. Well, let's now ये आंसर -5. बाकियों के लिए ओपन, no mark. Who says B, C, D, E? The right answer is B, Bombay aspirin. Why? When we are giving B12 folic acid, of course, सेल का RBC काउंट बढ़ेगी, प्लेटलेट काउंट भी बढ़ती है. The platelet count can go up to 5, 6, 7, 8 lakhs तक जा सकती है. So it can, of course, increase platelet can lead to any clotting phenomena. So that's why low dose aspirin is given. So we have to keep a close watch on platelet count. अब एक सवाल और, only for PGs. Which electrolyte imbalance can happen when we are treating this case? Which electrolyte? Raise the hand. Open question, no marks. Last point. हाँ जी. Yeah. Hypokalemia. Well, the right answer is hypokalemia. Give a big hand to him. ये हाइपोकैलेमिया कैसे आता है? अगर आप जो का हैरिसन की टेबल पढ़ेंगे 18, 19, 20, 21, 22, इन सब में एक टेबल बनी हुई है कॉज ऑफ हाइपोकैलेमिया, उसमें एक नाम है B12 फॉलिक एसिड ट्रीटमेंट. डिस्क्रिप्शन में कुछ नहीं है. बट इफ यू रीड 14, 15, 16 एंड 17 एडिशन ऑफ हैरिसन, टेबल वही के वही है, लेकिन एक लाइन लिखी है व्हेन वी आर ट्रीटिंग ए केस ऑफ पनीशर एनीमिया विद B12 इट लीड टू हाइपोकैलेमिया, फुल स्टॉप. बट इफ यू रीड 10, 11, 12 एंड 13 एडिशन ऑफ हैरिसन, उसमें ये टेबल है, ये लाइन भी है, लेकिन एक लाइन और भी लिखते हैं व्हेन वी आर ट्रीटिंग ए केस ऑफ पनीशर एनीमिया विद B12 फॉलिक एसिड इट लीड टू हाइपोकैलेमिया. द रीजन बीइंग large number of cells are being formed, potassium being an intercellular ion, it enters the cell and lead to hypokalemia, full stop. फिर आगे लिखता है, but why it doesn't happen with when we are treating other deficiency like iron deficiency? Reason not known. ये है 10, 11, 12, 13 एडिशन में. तो दिस ऑल फ्रॉम माई साइड. अब एक चीज एक सवाल और, ओपन क्वेश्चन, एनीबॉडी, ओनली फॉर पोस्ट ग्रेजुएट, ओनली फॉर पोस्ट ग्रेजुएट, नो मार्क्स. Most common lung cancer in India. Most common lung cancer in India. Who says A? हाथ खड़ा. A, जल्दी से. B, C. कहाँ ले? हाथ तो खड़े करो. A वाले कितने हैं? B वाले, C वाले, D वाले. The right answer is none of the above, secondaries. Very simple. Lung cancer primary नहीं कहा. Well, एक मैसेज और. आप सबके लिए एक मैसेज है. अभी आप पीजी कर रहे हो, आप साथ साथ ही MRCP भी कर लो. अभी घर बैठे बैठे हो जाएगी, करा मैं दूंगा. MRCP इज ए वर्ल्ड रिकग्नाइज्ड पोस्ट ग्रेजुएट डिग्री ऑफ यूके, MD नहीं है. और MRCP करके यू कैन गो टू यूके विद, वहीं पर सुपर स्पेशलिटी भी करो, विद सुपर कर लो. और अभी और MRCP करके तनख्वाह ट्रिपल मिलती है एज कम्पेयर टू MD वाली. ये बात को नहीं पता होगी. और MD का MRCP से आपकी अप्रोच बदल जाएगी. ये सलाह है, करा मैं दूंगा. ओके.
This round, team Lady Harding is leading at 37.5 points, and there is a tiebreaker between 4 teams: Team ABVIMS and RML Hospital, Team Patparganj, Team Safdarjung Hospital, and Team Maharaja Agrisan. All 4 teams at 20 points. So we will have tiebreaker round. Dr. Subbalakshmi.
Yes, so 4 teams we are having tie. So 4 teams, who are the 4 teams?
Team RML, Team Max Patparganj, and Safdarjung, and Maharaja Agrisan.
They all 4 teams should come forward so that we can have the round quickly.
Maharaja Agrisan can come here. और वो मैक्स पटड़गंज, यू आल्सो कम इन दिस फर्स्ट टीम. हाँ,
अब ऑन कर
दीजिए.
So 4 teams are in the front. So I will read out the question.
And 3 in the front, 3 in the front, and 1 is at the this fourth.
This one, yes. So you will have to write the answer. You can take a pen and paper. You have to write the answer because first, second में फिर पता नहीं चलता. So
write clearly, huh?
हाँ, you can write the answer. So 4 teams who are playing the tie. Just ask the पहले collect कर लें. हाँ.
Collect the
Have you written the answer? Please give
Sir,
the
sheet
sheet.
अपना नाम भी लिखेंगे.
सर नाम
हाँ,
देखना सर
team
नाम
लिख दीजिए team. Team का नाम.
जल्दी करो बेटा.
हाँ. So this one. And next question I will be just displaying. You can just write the answer for that question as well. So next question. Identify the sign in this picture. And write in your page along with the team's name and then submit it.
Time is up.
चारों टीम से हो गए कलेक्ट. RML, you can just give the. Yes. So answer has been collected, Dr. Shah? Yes. Okay. So for this, first I will discuss for this. It is this you can see Playboy bunny sign. So in emergency, the ultrasound has been widely used as non-invasive tool for the examination and to investigate for the congestive heart failure. It will help us in doing so. So this was the Playboy bunny sign given for that. And for first, it was National Leprosy Eradication Program. That logo was used for, this was the logo which was used for National Leprosy Eradication Program. So is that tie now over or still it is continuing? Still continuing?
So one team is excluded, Maharaja has said, because they have not identified the sign correctly. They have done family planning, so they can be excluded.
Acha, okay.
And rest three teams have answered the same. And leprosy eradication program and rabbit ear sign all have written. Rabbit sign and rabbit ear sign.
Rabbit ear sign, I don't think
Would
it
you like
is.
to give the points for rabbit ear sign?
I think.
All three are rabbit ear sign.
I think it is Playboy bunny sign. It is not rabbit ears. Yes.
All the three are one
So only one answer was correct. So acha. So let us see if I have yes. So identify. This is the next question for all the three. Identify the disease and sign. Rest of the three teams identify the disease and sign. So there is two questions for this. Disease as well as the sign. All three teams have done? All the three, yes. So the answer was Poppy sign, and it is the bulging of bicep muscle in the upper arm, typically seen with a complete rupture of long head of bicep tendon. They have, all three are correct. So now it moves on to Dr. Aditya for the rest of this thing.
Quizmasters are also having the tiebreakers.
Yes, tiebreaker. So I think students are well prepared with the.
So can we load my PowerPoint presentation? Yeah.
Next one. Three teams can come forward. Three teams who are.
I would like to say writing.
I think sir, writing is correct. I have two parts of each question. Okay. We'll have to
Two
answer.
parts of each question and both the parts are to be reflected.
Thank you. This we have covered. Okay, so we'll start with the tiebreaker question. So you have a 40-year-old man who received. Okay. So we have a 40-year-old man who received a liver transplant 17 months ago for alcohol-associated cirrhosis. He was discharged from the hospital 3 weeks ago after admission for high-dose IV steroids to treat biopsy-proven rejection. He remains on a steroid taper as well as mycophenolate mofetil and tacrolimus. He now presents to the emergency room with dyspnea, cough, and a fever of 101.3 degree Fahrenheit. Initial saturation on arrival is 89% room air. He quickly progresses to respiratory failures requiring intubation. Chest X-ray demonstrates bilateral pulmonary infiltrates. A BAL is done and GMS stain for BAL specimen is shown, showing small cystic forms and inflammatory infiltrate. So the first question is identify the organism and what is the preferred drug for treatment of the same.
Correct answer 10 marks, minus 5 for incorrect.
5 for each.
5.
And negative also.
Yes, 5 marks for each correct answer, negative 5 for wrong answer. So, shall I reveal the answers? So, the organism is Pneumocystis jirovecii and the drug is Septran. Okay. So one more question. So, we have a 46-year-old man who presents to the emergency department with a 2-week history of diarrhea, nausea, abdominal pain, and weakness. He reported a weight loss of 8 kg in the preceding 2 months and was sexually active. Results of laboratory study show a serum creatinine level of 2.4, ELISA for HIV was positive, and the CD4 cell count was 2 cells per cubic milliliter. Despite fluid resuscitation, the patient's renal function worsened and renal biopsy was performed. The image is shown. Which microorganism is responsible for the condition and what would you treat the patient with? Kindly submit your answers. Okay. So now the answer is the microorganism responsible is Cryptococcus and the treatment of choice is liposomal amphotericin B and flucytosine.
Next PPG has not attempted. So they are out.
0 marks.
Team Safadang has given answer 1 for CMB and second is
so negative.
Negative minus 5 हो गया.
Minus 10. Minus 10, 2 wrong answer.
2.5 for each. ठीक है.
Okay.
Minus 5. दोनों ऐसे पे लगते हैं. हाँ दोनों करते हैं. आधा RML है. Given have first HIV and second is AKT. हो गई minus 5. AIT लिखा है. उनका ही minus 5 हो गया.
अरे मैं नेगेटिव मार्किंग को अनाउंस किया था बेटा. अच्छा.
सभी बराबर हो गए.
सर डॉक्टर भाटिया ने टेका नाउ.
अरे यार. चलो. लिखो आंसर लिखो फटाफट. चलो. डीके के पेशेंट को ट्रीट कर रहे हो आप. ग्लूकोज जाता है और पोटेशियम को लेके जाता है, सबको पता है. Which other electrolyte also goes as a co-transport with glucose into the cell? रख द आंसर. Which other electrolyte also go as a co-transport in the cell? लिखा? क्या लिखा? जल्दी जल्दी बताओ यार। बोल हैं? ओके, आपने क्या लिखा है? आपने क्या लिखा? ये फॉस्फेट हो जाएंगे। चलो वो रहेंगे। चलो एक और सवाल, ईसीजी के अंदर सूडो पी पल्मोनेल किस कंडीशन में मिलता है? किस कंडीशन में? सूडो पी पल्मोनेल इन ईसीजी इज सीन इन विच कंडीशन? क्विकली। नहीं, इसमें नहीं है वैसे भी यार, हम तो आई कैन आस्क 100 क्वेश्चंस। जल्दी जल्दी। सूडो पी पल्मोनेल क्या लिखा? क्या लिखा है? ओके, आपने? ऐसे बोल दे यार। नहीं नहीं, दोनों गलत हैं। अरे हाइपोकैलीमिया, हाइपोकैलीमिया में वो होता है। चल चलो एक और सवाल। सूडो लिखो लोग, सूडो प्रोलंगेशन ऑफ क्यूटी इंटरवल इज इन विच कंडीशन? हाँ है, सही है, ऐसे खड़े करो। सूडो प्रोलंगेशन ऑफ क्यूटी इंटरवल इज सीन इन विच कंडीशन? जल्दी से, फटाफट। है ब्रेडिकार्डिया? नो, रॉन्ग आंसर। हाइपोकैलीमिया द राइट आंसर। बस खत्म। ओके, आंसर दे दूं आपको। वाई वी कॉल इट सूडो? क्योंकि इसमें टी वेव होती नहीं है, तो एक्चुअल में यू वेव होती है। वो क्यू यू होता है, तब वी कॉल इट सूडो। दैट्स ऑल। थैंक यू वेरी मच।
So team winner is the Lady Harding Medical College, and second is the close runner-up are the Safdarjung Hospital, and very close were the ABVMS and RMR Hospital.
So I thank you very much, quiz masters, and Dr. Aditya sir is always there, Dr. Mukesh Bhatia sir, Dr. Shubha, for the interesting quiz. I think we are getting late, just a straight short time.
Yes,
so we just conclude, and I would like to request Dr. Anirudh to felicitate our judges and the quiz masters outside the hall at the felicitation point. And I now request Dr. Naresh Jain sir for the formal welcome address to this conference. Dr. Naresh Jain sir.
सबसे अच्छी बात है, एक भी बंदा नहीं हिला ड्यूरिंग क्विज, सबके सब बैठे रहे। थैंक यू वेरी मच फॉर द पेशेंस। ओ क्या बात।
So it was an excellent quiz, and I must congratulate the quiz masters.
Sir, I think before we just wait for a minute.
I would request कि सब लोग यहीं बैठ जाएं अभी 5-7 मिनट.
Just so I request the audience to play the national anthem first.
Silence, silence, silence.
गण मन अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा, विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा, तव शुभ नामे जागे, तव शुभ आशीष मागे, गाहे तव जय गाथा, जन गण मंगलदायक जय हे भारत भाग्य विधाता, जय जय हे
Thank you.
थैंक यू फॉर एवरीथिंग। मेरी क्विज वालों को भी रिक्वेस्ट है कि अभी जाएंगे नहीं। क्विज मास्टर्स ओ भाई, हमने आपका सब कुछ बड़े प्यार से सुना है, आप भी थोड़ी देर बैठ के हमारा भी सुन के जाएं। हमने आपका बड़े अच्छे से सुना है सब कुछ, तो आप भी हमारा थोड़ा सुन के जाएं, खाली करके ना जाएं हॉल। 15 मिनट बाद करेंगे हम आप लोगों की सेरेमनी, 15-20 मिनट बाद करेंगे। अच्छा, चलो आपको छुट्टी है, बाकियों को भेज दो अंदर। सो डॉक्टर NP सिंह, डॉक्टर Ajay, Dr. Anil Mota, Dr. Rajiv Gupta, Dr. Grover, and all other dignitaries sitting here. Today, this is the 26th annual EDPA conference. I think my heart goes to the real pioneers, Madam Saroj Prakash, Dr. Ashok, Dr. Gera, Dr. Ashok Grover, Dr. Gera, Dr. Saroj Prakash. I think you were the guys who set the ball rolling many years back. I would call you visionaries. And I think conference has gone on very well. It has become a mega event, and it is an honor to be the scientific chairman for the conference this year. I hope we are able to give you a good, food for thought during the sessions. We like to keep them brief. We like to keep them in time. And if there are any questions left, you can ask even on the lunch or tea break. With that, I think we'll set the ball rolling, and we'll start the session. First session is by Lily. So, Dr. Ashok Grover, you are the master of ceremonies. Aajo, sambhalo stage.
Console, please. One of you, please come here.
May I request the judges of the PG program to kindly come on the side of the stage for their felicitation. Dr. Ashok, could you kindly escort all the judges to my left-hand side for their felicitation, please? We will be felicitating the judges on the left-hand side of the main stage. I would request everyone to kindly join me here. Thank you.
A very good morning to all of you, and I welcome you to this 26th EDPACON. And I think the package for today morning is the obesity masterclass. And I'm sure that all of us are struggling to treat obesity in various forms. And now obesity is no longer viewed as a simple lifestyle issue, and it is actually recognized globally as a chronic relapsing multifactorial disease. And India is facing a silent epidemic with rising obesity across all age groups, across cities, and even in the rural areas we find that obesity is showing its issues. And this particular session, or this masterclass, is designed basically to bring some clarity, consensus, and practicality to how we diagnose, how we understand, and how we treat obesity in real life clinical situations. And over the next 1.5 hours or so, through our chairpersons and 4 august speakers, we will be covering the various spectrum of obesity. And to chair the session now, I would invite the chairpersons, Dr. Rajiv Gupta, Dr. N.P. Singh, and Dr. R.M. Chabra. You know all the chairpersons very well. All of them, they are very distinguished faculties and the regular features in our EDPA conferences. And I'll request them to start the session, but I'll also request the speakers to maintain time because we are already behind schedule by 45 minutes. And I'll also request the audience to pass on the questions so that we can take them up during panel discussions. Over to the chairpersons.
Today, and a very important session, and we'll be listening to 3 stalwarts of East Delhi. The first speaker is Dr. Ajay Kumar Gupta, one of the most youngest stalwarts of East Delhi. He's at the Max Specialty Hospital, and he's got several degrees to his credit, apart from the MD, FRCP, FICP, and so many, lots of them. I really congratulate you. Yeah, you could manage all them.
Thank you, sir.
So, another important aspect of this is that he used to be once upon a time a very obese person. And
still am.
He is an example how he has changed himself and how he's become more smart and more healthy.
Thank you, sir.
So, you'll be talking on the obesity trends in India.
Yes, sir. So, like sir said, I was dragged into the EDPA executive. I was a part of EDPA since 2006, but Dr. Vijay Arora just called me, "Aaja chal, kaam hai tere se." And that's how I was put in the EDPA executive. And till then, since then, no looking back. And जैसे कहते हैं ना कि सभी बड़ों का साथ और हाथ मेरे ऊपर रहा और तभी मैं यहाँ तक पहुँचा हूँ सर. तो सर ने जो कहा ना कि डिग्रीज और वो सब बड़े लोगों का हाथ और साथ था और अभी भी है. So, being the first speaker and role number 1, so I'll just be taking care about the definition of obesity. So in the era nowadays, we are talking about obesity in India. So these are my disclaimers. And what sir said, what Dr. Grover said, obesity is not a lifestyle choice now. It is like a disease. So we define obesity as a chronic progressive disease which is characterized by excess accumulation of body fat. And why this is important? Because it is a potential risk to our body and it is a potential risk to our health. So just to present an overview of global prevalence, we have nearly 2.5 billion adults who are aged above 18 and 2.11 billion people aged above 25 years all over the world who are having obesity. And out of these, 1 billion were males and 1.11 billion were females. So it is not that only males are obese or only females are obese. It's a nearly equal distribution among the males and females. And if we just talk about the global prevalence out of the whole world, the 8 countries if we talk about, out of which we are one of them, like China, India, USA, Brazil, Russia, Mexico, Indonesia and Egypt. They account for more than half of the global population who are living with overweight and obesity. And if we just talk about the Southeast Asia and the South Asian prevalence, we have the obesity peak of the males at around 35 to 39 years and obesity peak for females at the age of 45 to 49 years. And this is the graph. I'll not go in the detail, we'll just discuss in the discussion time. And if we just classify, this is the classification what we follow in India, that overweight is BMI more than 23 to 24.9. Then we have the class 1 obesity with the BMI of 25 to 29.9 and the class 2 obesity of more than 30. But nowadays, there was a question that it is not only the BMI which matters, it is the waist-hip ratio also which matters, and it is the metabolic profile and the co-complications of obesity which also matters. So now there is one more classification which we call it as the stage 1 and the stage 2. Though this slide will not show this, but this is just for your information that this is the new stages of classification which has been endorsed by the ICMR also. And the stage 1 says that the person has to be obese or overweight of more than 23 BMI without any other complications, then it is stage 1. And if the person is having BMI of more than 23 plus any complication, whether it is the waist-hip ratio increase or any other metabolic complication like diabetes or lipid profile or even bronchial asthma, respiratory distress, so that is stage 2. And it is more important to treat stage 2 than the stage 1. And this is the overall prevalence that more than 100 million people in India, they are struggling with obesity. And the Global Data Observatory, it showed that the obesity and overweight prevalence was nearly same in the urban and the rural group. And if we just talk about the stage-wise prevalence, the state-wise prevalence of, there was a 23% of women population and 22.1% of male population who were overweight. And if we talk about the obesity, 40% of women and 12% of male were abdominally obese in the country. And these were the projected trends. And this trend showed that if we just see this trend of magenta color of the women, this is slowly and slowly increasing, and the percentage is increasing, and so much so that by the year 2035, nearly 50% of the population will be obese. So now the thing says that we know what is the population who are obese, we know what are the patients whom we are to treat. So what is lacking or what is the barrier? So there are some patient barriers, like we have been discussing the inertia of treatment for insulin. So we have the patient barriers, we have the physician barriers. If we talk about the patient factors, first of all, lack of recognition. So we see in our OPDs that there is a lack of recognition of obesity as a chronic and relapsing disease in the patients themselves. A misbelief, अरे डॉक्टर साहब वो तो मैंने बहुत ज़्यादा खा लिया था इसलिए हो गया, अभी मैं थोड़ा सा खाना ठीक करूँगा तो ठीक हो जाएगा. And misinformation, अरे साहब ये तो हमारे बाप दादा भी ऐसे ही थे, आज तक कुछ नहीं हुआ उनको, ठीक ठाक 90 साल की उम्र में मरे. So there are these misbeliefs and misinformations which we encounter in our day-to-day OPDs. Then environmental factors, like I said, cultural and familial influence. अरे डॉक्टर साहब अब लड़का है, थोड़ा बहुत मोटा तो रहेगा ही, उसमें क्या दिक्कत है. The attitudes, means the attitude of not changing the knowledge and behaviors of the individuals towards the obesity. Then what in India which matters a lot is the cost of treatment. अरे डॉक्टर साहब 10,000 रुपये का इंजेक्शन है, कौन लगाएगा, खाली मोटापा घटाने के लिए, कोई दिक्कत तो है नहीं मुझे. So these are the treatment responses when we give about the cost. Then comorbidities and medications. डॉक्टर साहब कितनी दवाई खाएंगे, शुगर की अलग खा रहे हैं, BP की अलग खा रहे हैं, इसकी अलग खा रहे हैं, तब इसकी अलग से और लेनी पड़ेगी. So there are very many beliefs. In the other speakers' talk, we'll be understanding how to break those beliefs and how to counsel your patients. Then we have the physician factors. Means we generally have packed OPDs, so we have a lack of time during the general consultations to explain about the obesity and the treatment about the obesity. Then there is an insufficient training. Means we ourselves are not trained how to talk about the obesity, how to start a talk. Means just ऐसे तो अपन बोल नहीं सकते, हाँ भाई आप मोटे हो अजय, आपको कल से इंजेक्शन लगाना है, हफ्ते में एक इंजेक्शन लगाना है, लगा के मेरे पास 1 महीने बाद आओ. So you will have to train your own self and understand the potential of the patient's understanding. Then only you will be able to open the dialogues. Then lack of the formal diagnosis of obesity. Many of us, they are lacking. Means what is the stage 1, stage 2 obesity, what is the class 1, class 2 obesity. So that knowledge is important. So that's what we are here for. And if we talk about the Indian assessment of people with obesity, only 2/3 of the people with obesity will consider themselves to be obese or having extreme obesity, or they will have an insight of treatment. And it is seen that out of 8, only 1 person with obesity will be considered, will consider their health as overall poor and try to treat. So just to summarize my talk, these are the key takeaways: that globally over 2 billion adults are affected by obesity and overweight, and with the countries like India, China and USA, they contribute to nearly half of the global burden. And in India, more than 100 billion people, they struggle with obesity, with higher prevalence seen among the women. And abdominal obesity is especially widespread, affecting nearly 40% of the women and 12% of the male. And overweight prevalence in children under 5 has risen sharply from 1.9 to 4. And India, we talk about, there are various patients and physician related factors and barriers for the weight management. And this is what we will be discussing. This was just an overview of the obesity. And I rest my talk here. I thank you for the patient hearing. Yes, sir. Yes, sir. You are very right, sir. This has been kept as the benchmark. Obesity as the benchmark was 25 in this study, sir. Yes, sir.
Can we have the discussion afterwards? Yeah. So, may I call the second speaker, Dr.
Thank you, Ajay, for a wonderful exposition of the prevalence of obesity. I always feel that it will keep on increasing despite of Lilly's or whether despite of anyone else. As far as we are growing, our now we, instead of BMI, is there any other component which is used, which is BLO, roundness index, BRO. Sorry. So I have a proud privilege to invite one of my teacher. I call all my students as teacher. So Rajiv Bansal. Rajiv is a graduate from MC, and he is one of the very tallest figure in EDPA. He has been recently awarded with a very prestigious fellowship of American College of Physicians, and he's going to talk to us on science of obesity and cross connect with type 2 diabetes mellitus. Very important talk. Over to you.
Thank you, sir. Thank you, chairpersons, and I'm really honored, sir. All my teachers are here. One of my biggest teacher is here, sitting here. I'm honored, and all seniors, Dr. Rajiv Gupta, Dr. Grover, Dr. Ajay is a very good colleague, friend, and accomplished. So I'll be talking. Ajay has already mentioned about the obesity, the prevalence of obesity. It's becoming an epidemic now, and I'll be talking about science of obesity and cross connect with type 2 diabetes. We generally used to think that it's a very simple thing between the imbalance between the energy intake and energy expenditure, but I think it is much more complex. So these are my disclaimers and disclosures. So there is a complex science behind obesity. It is not just energy intake and energy expenditure imbalance. We see a lot of people who are eating, but still they are not obese. A lot of people like Dr. Singh, Dr. Mota, they are all lean, and there are a lot of people who do not eat much, but they are obese, like me and like others. So it's a very complex science. It's not simple. And in last few years, we have started to realize this complex science a little bit, and that is why we can now say that some people are obese and some people are lean. So it's a complex interplay of neuronal and hormonal communications, which are responsible for that certain people they are obese and certain people they are still lean. And the most interesting part in this is the brain. And in the brain, this is very interesting. The hypothalamus is one part which is responsible for all this complex interplay. If you see this prefrontal cortex, which is responsible for executive functions, for self-regulation and inhibitory control. Like when you decide not to eat, this is the prefrontal cortex, or when you want to regulate, this is the prefrontal cortex which comes into play. Then there's a part in the mesolimbic system which is responsible for hedonic eating. Hedonic eating, you are eating without any appetite, eating just for pleasure, like sweets. Like I have a sweet tooth, so I can eat sweets without any appetite. So I have a pleasure for sweets. This is called hedonic eating. And this part is responsible for this, mesolimbic system is responsible for this liking and craving. Then another part is responsible of hypothalamus is responsible for homeostatic eating, which is very important for satiety. Whenever you eat and after a certain stage you feel that you are full, so that because of the stimulation of the satiety center in the hypothalamus. Also appetite, how much appetite is there, so that is also by the hypothalamus, and energy expenditure. So it is a complex, interplay of all these centers, which ultimately results in whether the person is obese or a person is non-obese. If you see the hormones which are responsible for decrease in hunger or satiety, then we have come to know certain molecules, satiety hormones from the intestines, which are GIP-1, CCK, oxynomedullatin, pancreatic Y-peptide, GIP. These are all satiety hormones. When you stimulate these hormones, you will have satiety. Leptin from adipose tissue, another satiety hormone. When leptin levels are high, you will feel more satiety. Pancreas, amylin, and insulin. Similarly, there are hunger hormones. When these hunger hormones are stimulated, you will feel more hungry. And the most important of this hormone is ghrelin, which is secreted by the stomach. Whenever you feel hungry, the ghrelin levels goes high, and you start eating. So you can see by these molecules, you can see the future of research, in obesity management. Because right now we are addressing only certain molecules to manage obesity amongst all these molecules. So the future is bright. So you can have a lot of research on these molecules, and you can manage obesity. Now talking about this, if you talk about the very important organ, adipocyte. Adipocyte is very important, and adipocyte dysfunction is a key driver of related complications. So in healthy individuals, this is the normal adipocyte, and in obese individuals, the adipocyte increases and also becomes dysfunctional. And this dysfunctional adipocyte leads in excess of lipids at the various levels, like epicardial tissue, pericardial, hepatic, pancreas, renal system, intramuscular, and also in the retroperitoneum, omental, mesenteric, so leading to ectopic fat deposition as well as visceral fat deposition. So this is the increased adipocyte size and dysfunctional adipocyte which leads to all this imbalance. And this enlarged and dysfunctional adipocyte leads to local and systemic inflammation, because this secretes a lot of inflammatory factors, inflammatory cells like IL-6, TNF-alpha, MCP-1, which leads ultimately to inflammation and insulin resistance, and which ultimately leads to diabetes and other chronic metabolic diseases. So this excess adiposity is the key component of obesity disease. Various organizations have defined obesity. Dr. Ajay has already mentioned. If you see ACE, American Association of Clinical Endocrinology, this labeled obesity as an adiposity-based chronic disease, or ABCD. If you see about SAFES, South Asian Federation of Endocrine Societies, they also declares obesity is a chronic, relapsing, multifaceted, multisystemic endocrine disease which needs timely and sustained attention at clinical as well as public health level. Also, our Endocrine Society of India labeled obesity as a chronic, relapsing, progressive disease defined by excess adiposity that may impair health. So, there are many factors which contribute to obesity. The factors can be genetic. We see families, there are so many genetic genes which are responsible for obesity now, we know that. And there are families where all family members are obese. Then environmental factors, we all know that in certain parts of the world, the obesity is more prevalent. And when we go more towards the temperate regions or the tropical, the obesity is less. Socio-cultural factors, the eating habits, the social habits, also responsible for obesity. Physiological, very important, how much physical activity is there. We know that now the physical activity is going down, the more sedentary lifestyle is there, so that is also responsible for obesity. Behavioral factors, hedonic eating, eating just for, when you have craving for certain foods, so you keep on eating. There is almost a food epidemic in India. Every third or fourth commercial building has restaurants, lot of pubs and lot of, eating places. So it is almost like a food epidemic in India now. Everywhere you see food stalls. So maintaining weight loss is very challenging because whenever you lose weight, there are compensatory mechanisms which come into play and tries to regain weight. There is a very, interesting study regarding this. This was study done in Australia. Following weight reduction, the most is regained over time. If you see here, almost 10 kgs of weight loss was there in 8 to 10 weeks. But by 1 year, when the lifestyle intervention and other interventions were stopped, the weight was regained. And almost the time course of weight regain following loss is by 5 years. By 5 years, almost 79% of the weight was regained. So in spite of the best of the efforts, when you lose weight by the conventional methods, you regain weight after some time. The hormonal changes after weight gain, they persist for some time, for say around 1 year, 12 months. But after that, again, the previous hormone levels, they come back, and there is, increase in the weight gain. So the increased drive to eat and decreased energy expenditure resulting from weight reduction, it creates a perfect physiological storm for weight regain. Once you lose weight, there is a decreased energy expenditure. The body tries to, because the energy expenditure is less, so there is a weight gain. So that is the body's defense mechanism to regain weight. What are the complications related with obesity? We all know that obesity is the root cause of almost every disease now. And when we address obesity, we are basically treating so many chronic metabolic disorders. There are 3 M's of obesity: metabolic, mental, and mechanical. Obesity, the mental causes or mental manifestations are knowledge, expectations, self-image, mood, anxiety, attention, sleep, personality, addiction, psychotic, and cognition. Mechanical, osteoarthritis, very common. Then chronic pains, reflux, OSA. There's a big role of obesity in OSA, causation of OSA. Hyperventilation, urinary incontinence. There is a list of, these disorders. We all know that. Metabolic disorders, we deal in day in and day out. Nutritional deficiencies, type 2 diabetes is one of the most common diseases. Hypertension, then certain cancers, polycystic ovary disease, PCOD. So these are the very common things which we come across every day because of obesity. So what are the treatment guidelines and recommendations for obesity? Now, guidelines recommend that obesity should be treated to therapeutic goals. If you see the European guidelines, they recommend developing therapeutic goals based on severity and stage of disease while considering the prevention of further weight gain and obesity-related complications. The American guidelines, they also say that weight loss should be individualized based on medical history and presence of comorbidities and complications. So according to their ADA and ESD consensus, patients with type 2 diabetes, when you induce weight loss, the 5 to 10% weight loss yields metabolic improvement, and 10 to 15% or more may have a disease modifying effect and may lead to remission. We all know that. We know the studies backing this, that 15% of weight loss can induce diabetes remission. People with type 2 diabetes can especially benefit from early aggressive treatment, and damage caused by type 2 diabetes presents early compared to the ongoing and lifelong benefits of early aggressive management. So we should be aggressive. Whenever we see a patient, obese patients walking into the clinic, even without diabetes or any other disease, we should motivate the patient for weight loss because we can foresee the complications in the future. So the recommendations on screening, diagnosis, and assessment, this is 2023 Obesity Management Association algorithm. The assess for the presence of obesity by determining the following parameters like BMI, 18 to 24, 18.5 to 24.9 is normal, 25 to 9 is overweight, and more than 30 is obesity. And these parameters are little strict for Indian guidelines, almost 1 to 2 kg per meter square, lesser in Indian population. Waist circumference for Asian population, cutoff is 90 for men and 80 for females. The common recommendations are that thoroughly assess the overweight obesity patients with medical history, physical examination, and relevant lab tests. And routine tests should be done like fasting glucose, HbA1c, lipids, TSH, urine albumin, uric acid, and vitamin D. So reversing obesity or reducing obesity may improve or prevent significant obesity-related complications. If you reduce 0 to 5% of weight, you can treat hypertension, hyperglycemia is addressed, just 1 minute, 5 to 10% urinary stress incontinence, PCOS, dyslipidemia, MSLD. MSLD is 5 to 10% and you can manage MSLD. 10 to 15% you can reverse diabetes, you can treat MASH, OSA, GERD, knee osteoarthritis. More than 50% you have cardiovascular benefits, cardiovascular mortality benefits, and HFpEF. So what is the cross connect between obesity and type 2 diabetes? It is the adipocyte, dysfunctional adipocyte, which leads to excess of fat at the level of pancreas, liver, muscular, skeletal muscle, and resulting in increase in the inflammatory markers, resulting into increased insulin resistance, and ultimately resulting into diabetes. This is a patient X, 2020. Patient was, just 1 second. The patient was, at that time was non-diabetic, but weight was high, blood pressure was high. And in 2025, the patient became diabetic. The weight increased from 110 to 120. And you can see that if we would have acted at this level, 2020, we could have prevented diabetes and other complications. So these are the patients which we have to target, and we can really give them real benefits. So addressing excess body weight as early as possible can provide more clinical benefit than focusing exclusively on glycemic control. Glycemic control is out. We have to treat the patient holistically. So all complications along with obesity leads to type 2 diabetes. So message,
Rajiv,
type 2 diabetes,
I have the
obesity are chronic, and we
prerogative of asking you to stop.
Thank you, sir.
Thank
Successful weight management is the keystone and key message from my side. Thank you, sir.
Thank you, Rajiv. Thank you. It was an excellent talk, but a bit lengthy.
of metabolic disorder compared to the Caucasian who had a, despite same BMI, had a less fat percentage in the body. So Indian thin fats phenotype is what is challenging to us. And Dr. Bansal has adequately explained that obesity is a disease. That's why we, American called it adiposity-based chronic disease. So obesity is adiposity-based chronic inflammatory disease, major cause of risk factor. So I would not take much time because of we are lagging behind and we all know what obesity is. I just want to say that the BMI does not suffice in defining obesity. We need to look into the other parameters which are important for Indian subcontinent or Southeast Asian are, one is a important waist-hip ratio, another is waist-height ratio, and third important thing is neck circumference. We are not routinely doing them, but I think it is time that we start measuring it. So I will briefly tell you what are the ways to measure it. The neck circumference is measured just below the Adam's apple, one finger below the Adam's apple in a circumferential manner, in a straight line, and we should put one finger in it and then measure it. And 16 inches in a male and 17 inches in a female is a cutoff. If it is more than that, then there is excess of neck fat, which is an independent risk factor for overweight and obesity. Second thing is waist-hip ratio. Where to measure waist is very important. Waist is measured at a midpoint between the lowest point of the chest, ribs, and the anterior superior iliac crest, and it is measured circumferentially. And hip is measured at the greater trochanter, which is the maximum circumference. So waist-hip ratio is one of the important risk factor for obesity. So neck circumference, waist-hip ratio, and waist-height ratio are important parameter. As we have learned it amply that overweight in Indian setting, according to the Endocrinological Society of India, overweight is 23 to 24.9, class 1 obesity is 25 to 29.9, and class 2 obesity is more than 30. WHO and IDF suggest measuring waist circumference in the horizontal plane midway between lowest ribs and iliac crest. The waist circumference in a male is more than 90 centimeter, which is high, and female around 80 centimeter. 80 centimeter is just 32 inches. I think it is too less. So according to this standard, all Indian women are obese. And there have been studies done in Kerala, lot of data by Dr. V. Mohan, in which the normal BMI adiposity is as high as 30% in Kerala women. So we have lot of normal BMI obesity, which is challenge. And why do we look at normal BMI obesity? We look at these parameters because we have seen that despite having a normal BMI, there are girls who are prone for PCOS. There is associated hypertension and dyslipidemia. There is associated OSA. So despite having a normal BMI, we do have a metabolic disease. That means it is the body composition which is important. It is the other parameters which are like waist-hip ratio, the neck circumference, or waist-height ratio, which are also contributing to increased metabolic risk. If waist circumference is more than 102 in a man and more than 88 in women, it is associated with higher cardiometabolic risk. And a waist circumference of more than 94 in a man and 80 in a woman increases metabolic risk factor. Waist-hip ratio, as I told you, waist-hip ratio is measured at, waist is measured between mid-axillary line and iliac crest, and hip is measured at the widest circumference over greater trochanter. And the waist-hip ratio, which is normal, is 0.8 or lower in a woman, and 0.9 or lower in a man, and high is 0.86 in a woman and 1 or higher in a man. These are this is the tale of two friends, as I was explaining the Dr. YY paradox, which is very famous. One Dr. Y from Southeast Asian and another Dr. Y from Caucasian origin. Both of them had different metabolic risk factors. So this is tale of two friends. One is Arjun with a BMI of 35. Another is Aman with a BMI of 35. So both of them had risk factors, similar BMI, but one was in Edmonton obesity scaling system stage 1, another was in stage 2. So obesity is not only about the measurement, it is about the other obesity related risk factors. Like obesity related risk factors could be elevated blood pressure, mild sleep apnea, functional limitation or comorbidities. So this is Edmonton scaling system in which it is not only the BMI, it is 4 parameters, which is medical, mental, functional, and the personal or physical health of the patient. So stage 0 is in the Edmonton obesity staging system when there are no risk factors, there is no mental health issue, there is no physical health issues, there is no mechanical health issues. To stage 4 where there is end stage disease and one needs to do bariatric surgery or some definite form of management to get the patient out from end stage disease. So Edmonton obesity staging system tells us that it is not only about the BMI, it is about the mental, mechanical, physical and disease related well-being of the patient, by which we define the obesity of the patient. So if there is a high EOSS, then we have to take aggressive measure to reduce obesity. If there is a lower EOSS grade, then we can go gradual about the management of the patient. So defining patient on EOSS scale, which is mechanical, mental, medical and functional well-being of the patient is important. Then another thing which we are learning, I think many of us have that scale in our clinics, is body fat percentage analysis. So this is also one of the important thing. It is not about the total weight, it is how our body is, whether it has more fat or more muscle mass. So there are different ways by which we can calculate the body composition. The gold standard is MRI-based analysis of the body, but it is difficult and money consuming. So simplest is the body fat percentage analysis by using bioelectrical impedance. This is like a simple weighing scale, which by ways of current in the water and by the ways of the physiology that fat has more water content compared to muscle, tells us how the body composition is. So it can tell us whether the body has more fat mass or it has how much of muscle mass does it have. It is a simple machine, can be used easily on OPD basis and can analyze our body fat percentage. So a body fat percentage of more than 25% in a man and 30% in the woman suggests that there is more fat in the body and person could be obese. This is according to Endocrinological Society of India. Then other tests like hand grip meter, hand grip test, capacity of patient to stand unaided, also are measurements tools which can tell us whether the patient is overweight or obese or has a normal body structure. So body fat percentage is required to be done in most of the patient to analyze whether they are obese or they are overweight or they have normal body weight. So to summarize, we know that obesity is a multifactorial disease which is influenced by genetic, environmental measures. Accurate diagnosis, not only BMI, but also start using waist circumference, neck circumference, waist to height ratio, body composition analysis, and other scales like Edmonton obesity Scoring system is a very good scale, which you can see on internet, and you can see your patient falling into the category and accordingly manage the patient. The diagnosis of obesity starts in antenatal period. So tell women to take care of her calorie intake while she is pregnant. To childhood, adolescent, because if person is obese in childhood, there are 50 to 80% of the child turning into obese. So more stress has to be laden on the childhood and on the infantile and on the perinatal period of obesity, so that we can have healthy adults. So I would thank.
Thank you, Dr. Meenakshi, for the excellent presentation. Kindly stay here for the panel discussion. Now over to Dr. Grover.
I think we are thankful that you have finished before time. And after having diagnosed obesity by different methods and having gone through all the other intricacies, now I invite Dr. Anil Mota, who is going to tell us about the management of obesity. I don't think that Dr. Mota needs any introduction. He is a very dear friend to all of us, and he's an absolutely lovable personality. But just to give you a little brief, that he's currently practicing as senior consultant in Max Hospital, and I request him to give his talk.
I'm highly obliged, sir. All my loved friends, seniors and colleagues are here on the stage, so I'm more enlightened also and really, really thankful. I'm not going to talk about what has already been spoken by our competent, learned people. I have to only speak about 3 or 4 things. And what my teacher used to tell us, that what the mind doesn't know, the eyes will never see. This holds true for us. When we go to our clinics and if we don't know what we have to diagnose, then we are probably going to misdiagnose, overdiagnose or underdiagnose. So I am here to only speak about the guidelines and how we manage obesity. The rest has already been wonderfully spoken about the pathophysiology. And we know we had huge guidelines starting from 2013 till a few weeks back, till 2025. There were so many guidelines published till date, but our brain did not register the story in the past 10 years. But now things are better. Okay, so what are the recommendations for individualized management? So we have got, first thing is that whenever we talk to any person who is obese, what they will tell us is that they are healthy. They will never say they are obese. But our duty is to tell them that we have to counsel you, and we must counsel them properly and with due regard to their privacy. We can't just go on talking in clinics in front of everybody, whether it's a lady, it's a gent or a child. We must be very sure that we provide adequate privacy. Dr. Meenakshi told us about the various anthropometric measurements. We need to give them a good chamber where they can talk and where you can see them privacy. Please let us be sure that we don't make a mess of their diagnosis. Second, people with diabetes and obesity and overweight, we have to talk about weight management, we know that. And we have to tell them what are the various available options. That is important because once they know about it, they will probably manage if we counsel them well. So what Dr. Mohan, whom I consider my guru, he always says, motivate, educate, and you should not get tired out. So we have to motivate and educate them and see that they follow them. So 10% weight loss improves most of the story about diabetes and cardiovascular outcomes. And that's what we have to hammer it to them. And it has to be individualized. One size doesn't fit all. We know there are various structural, chemical and socioeconomic factors, cultural factors that lead to obesity. Our nutrition eating habits has been already talked about. But most important is insecurity and cognitive behavior regarding satiety and eating. And lifestyle changes, nutrition, exercise are the primary methods of treatment. There is no method that will, unless we talk to them about having a hypocaloric diet, reduce calories and free calories. Second is about we must give them counseling. What is recommended is that we must give 1 to 2 counseling sessions per month. And then probably in 5 to 6 months he's going to understand us. And second thing is that we have to give them a lifestyle management program. How to go for a hypocaloric diet, then how to go for activity pattern, and then how to monitor the weight. So that has to be hammered to them. And we have to tell them that we have to go for at least 300 minutes of walk per week, and no 2 days should be taken off. Less than 1 day off in a week, then only the weight program is going to work. There's a lot of talk about very, very low caloric diets. We have to tell them that all these diets, like Atkins diet, they are good, but they cannot be given to everybody. It's only in a few people whom we can monitor them well, can we give them very low calorie diets. Then obesity indicators are to define, and ESI practical guidelines Dr. Meenakshi has already talked about. So first thing is weight management. That means pharmacotherapy, that means lifestyle and nutrition. Second is about drugs, that is pharmacotherapy. And third is about bariatric surgery. And these guidelines have already been told them that it's a chronic progressive disease. Now, how do you talk to them about loss of weight? At least 10% gives us a good effect, and more than 15% sends us into a reverse for diabetes. And then we have to make them understand that you lose it, you will regain it, as Dr. Meenakshi again said. You will regain it if you don't maintain it. So then there are recommendations of metabolic surgery. We have the Institute of Bariatric Management has told us about that. But one thing is the diagnosis improve the outcomes, and earlier the better. They must shed at least 5% of the weight. And beyond 5 to 10%, they are all going to get good effects of glycemic control. They will have OSA improvement, urinary incontinence. So we need 10 to 15% of weight loss. Treatment of obesity depends upon BMI, though truth is that we many times forget about BMI. But remember, lifestyle modifications have to be enforced in all. Number second, pharmacotherapy in those people who have a BMI of more than 27 can be recommended, but anybody having a BMI above 30, we can give pharmacotherapy, must encourage them to understand pharmacotherapy, and we'll come to that shortly. And more than 40 pharmacotherapy with bariatric surgery is recommended. So bariatric surgery as such is recommended only number one in people above BMI of 35 who have got adiposity related complications, and above 40, yes, it is without thought that you can go for this, about bariatric surgery. So lifestyle, as I told you about going for a hypocaloric diet and at least 300 minutes activity per week. Second is lifestyle modification will produce genuine weight loss in people over a short term, but we have to make them understand that you will regain in case you don't maintain this story. And pharmacological therapy, we must know that we have to think about the patient, we have to think about his pocket, we have to think about his level of intellect, so that he's able to monitor himself well. We cannot just write a prescription then see that he can't afford it. So the pharmacotherapy is about either GLP-1 agonist or a dual agonist. And recently, last week, there was a publication about the triple agonist, and that came around, I think, 5 days back. So we have got tirzepatide, which has been again approved, and it will start in dose. We start around 2.5 once weekly, then after 1 month go to 5, and then we can build up to 15. It's a dual agonist and it's a good one. Then semaglutide, we can start with 0.25, this is sort of injectable, and go up to 1.7 milligrams subcutaneously and hike it over every week. Orlistat, I don't know how many of us are losing, but it's good for those people who are having a fatty diet. Before each meal, you can give them a 60 to 120 milligram dose. And what has not been written in the slide is about the newer drug, that's the triple agonist, retatrutide. You will not believe it, the last, when I read it last week, it showed that if you give retatrutide, the person is going to lose up to 30 kilograms of weight. And 85% people got benefit of reduction of knee pain. Their knee pain vanished. So that is the beauty of the triple agonist. And metabolic and bariatric surgery is recommended. We know there are different methods, the band, the sleeve gastrectomy, and then the Roux-en-Y bypass means diversion. The problem with each is that you can either, the band can slip and it can recur, and about sleeve is okay, good, nutrition does not suffer, but they can get symptoms of reflux. Roux-en-Y can cause dumping syndrome and loose stools. So different bariatric surgery. One surgery does not fit all. It has to be left to the bariatric surgeon depending on the person. And outcomes are wonderful. With sleeve, I would talk about the Roux-en-Y. The Roux-en-Y gives us the best outcome. Means weight loss around 30%, and more important is the resolution of diabetes around 40% with Roux-en-Y. Problem is dumping syndrome. That is a problem. Summary is obesity is a management. In management involves permission from the patient, assessment, advice in person with good counseling, goal setting, and making them understand that I am with you. You have to go and we have to counsel, motivate, assess, and then make them understand it will recur. BMI, or even what Dr. Meenakshi and Dr. Rajiv told us about the different ways of assessment and complications, guide treatment via lifestyle medication and or surgery. Lifestyle change alone are definitely important and are the cornerstone of therapy. Pharmacology and surgical options, I told you, depend upon the BMI and the effectiveness and understanding of the patient. We have to set individual goals. There is no one size fits all. So we have to counsel them. We may need colleagues like a psychological advisor, a nutritionist. We should do it a whole in one. Not that I order and you will follow. Nobody follows any orders. People understand only if they are counseled well. And then they get motivated by their own improvement. So these are the 4 methods of treatment: lifestyle, medical nutrition therapy, pharmacotherapy, and finally is metabolic surgery. Thank you.
Thank you, Dr. Mota. I think, again, I thank you for finishing well before time. So if there are any questions from the audience, from the you want to ask from the panelists, you can please pass them on. Well, there are a couple of questions which I'd like to ask and get your feedback. Dr. Ajay Gupta, so what are the biggest drivers of obesity in a young Indian today? Because Meenakshi has also pointed out, and all of us know, that it is actually the younger population who are obese, and it is mentioned that even in the intrauterine stage, you can find that this child may become obese later in life with all the factors. So what is your comment on this?
Sir, genetic, epigenetic factors plus the increase of the GDMs in the intrauterine stage, and then in the young and adolescent stage, sir, nowadays we find that everybody, or rather most of the children, they are confined in the homes with their tablets and mobiles, and the lifestyle changes which have occurred, and processed food with the more of calorie rich food, that has increased the chances of obesity. आज पार्टी है, चलो बर्गर खा लेते हैं, आज केक काट लेते हैं, पेस्ट्री खा लेते हैं. So these are the appreciation things which children get nowadays. Chocolates. So what Dr. Bansal said, hedonic eating. After you have had your full meal, without exercise, having a hedonic eating, high calorigenous food, that increases the extra calories in the body and stored in the form of fat. So that is day by day increasing the chances of obesity and obesity in the children and adolescent age. So that's why I said that maximum of the obesity in India in males is from 35 to 40 years of age, and in the females it is post-menopausal age also, which also contributes to the obesity, and that's why the females have the peak at around 45 to 49 years of age.
Okay. So one issue is that all along we have been saying that you eat less and move more, right?
That was one of the fundamentals which
yes,
we have been talking about here
till now. So I would seek the comment of all the panelists that with all the presentation which you have made, so what should be our approach when we talk to a patient who is obese and where we are going to manage him in the clinically?
Like if we talk about the management, sir, like Dr. Mota has presented, there are 3 verticals of management. One is the behavioral therapy, then the oral medications, and third is the surgery, sir. So in all managements, the behavioral therapy, the adjustment to the diet and exercise, that is the one. And then second is the medical therapy, and third goes the surgeries. So this is the therapeutic approach for obesity which we can talk about.
So actually what, Dr. Mota, please.
No, exactly, Dr. Ajay already said. See, one thing is there that we have to really counsel first. If we don't tell him that obesity is a disease and you are going to die of it, and we have to make him understand. If he understands, then probably the rest two are going to work. And as he again said about medical nutrition therapy going on a hypocaloric diet, at least 500 calories to restrict per day about what he is taking. So the target is around 1 kilogram per month that he should lose till he becomes the ideal body weight. And ideal body weight, we all know about the males and females, 50 kilogram plus 2.5 or whatever, 5 feet. So he has to understand these stories. So counseling is the basic story. And the risk of not understanding, not following our advice, if we make him understand, and it is not going to happen in one day, sir. It will take us weeks, as this has been recommended, 16 counseling sessions over the coming 3 months. Then people understand. If he understands, probably he's going to follow. And then more importantly, what our friend said, is that we have to make him understand that once you lose, you have to maintain. Otherwise, you'll go back to that, what you were. Whether you do it by lifestyle medical or medical nutrition, or you go by pharmacotherapy, you will go back. So it is counseling and motivation. That is my story.
So I think one basic thing which we wish to drive to the patient's mind is that it is not the weight, it is not the obesity, it is a disease you are dealing with, and weight reduction is just one of the components. All other components of therapy which have been already elaborated by the esteemed speakers.
Sorry, if I could add one thing.
Please.
Based on people's customary eating habits and emphasizing on them, like we can encourage intermittent fasting, which is helping to lose weight, asking the people to have an early dinner and have an intermittent fast for around 14 hours may help. Secondly, switching their eating habits from a wheat-based or rice-based diet to a millet-based diet can help. So these are the additional things. And one more thing which we generally do not emphasize on our patient is we tell them to walk regularly, do aerobic activities. But it has been shown that if we do a muscle strengthening exercise, the body BMR actually increases. Once we start losing weight, the BMR actually goes down. And to increase a basal metabolic rate, if we tell them to do strength training exercise along with regular walking, it helps in increasing the BMR, so they lose weight faster. So telling them, even if they are housewife or not able to do much of exercise, telling them to do some elastic bands or some weightlifting of around 2 kgs, 3 kgs, whatever they can do at homes. So strength training exercise along with aerobic physical activity, which is at least 150 minutes per week, may help in reducing weight
Dr.
faster.
NPC wants to make a comment, I think.
Just wanted to add something. One is in 2026, BMI will be replaced by BRI, Body's Roundness Index, and simply, I think what Meenakshi provided, you just have to measure the weight circumference along with the height, and then you'll get a value which should be less than 3.5 or so. That's very simple formula. Now probably in 26 we'll have. Second is, I think all of us agree that as we age, and I'm also now 67, our activity reduces, our that hedonic activity increases, and our requirement reduces. So we all become obese and Meenakshi is one such example. She was my student. She had a BMI of probably 90. Now you can ask her. Now the third important thing is the behavior, as everyone has stressed. Now I recently had my CGM done. I'm not diabetic, but there was a program which is known as Heal Diabetes, and as a part of promotional activity, I had done that. Now that has various components, including your stress at night, including your sleep at night, including your sugar surges, just simply changing the type of diet which you are eating from, more of a, just a carbohydrate to more of a protein diet will give you a satiety, which will last much longer than a typical, dal chawal where you get a sugar urge after 2 hours and then you eat a chocolate. So that has been proved by the CGM and other activities. So a very complex thing, and I'm very happy that the person who's sponsoring Lily's guy is so lean and thin that he doesn't require. Amit is so lean and thin, and Heminder Makkar. And I think we should make all of them as panelists, and Dr. Dubey, Dr. Ravinder and others, and ask them what do they do, including Smita, you also, and to ask them simply what do they do to ensure that we don't get overweight. Thank you.
Dr. Chavda.
Dr. Meenakshi, in the junk food era, what about the age of the screening of the in the school? What is the age of the screening? When you want to screen in the young population in the school?
I think
what is the advantage?
Yeah, it should start as early as possible. So there is no age. It's not that you should start screening at 12. There are obese children who are obese and overweight at 6 also. So we have that growth chart in which if the body weight is above 90th percentile, then they are overweight. So this should start from birth only. If the birth weight is more than 3.5 kg, the chances they will develop obesity in adolescent and childhood and later in life are much higher. So it should start antenatally only. So there is no age. Plus these shops which are now, I think there is some circular which has come that in the school these junk food shops should be stopped. The cold drink, momos and all the junk food, instead they should provide healthy food. So I think healthy eating has to come from schools only. The schools have to be encouraged.
Education in the young population. Education
in the young population, see, they are so anti-crackers. Because it's been told to them, it has been fed into their mind that burning cracker is very bad for the environment. So I think this kind of thing should be encouraged from teachers from very beginning, from the primary school. And Swiggy and Zomato, I think government should ban them. Particularly, they should be defining hours that beyond this they would not deliver. So these things should be taken care by.
If I may add something here.
Please.
Sir, I think the whole scenario has changed in last 3 decades. Nuclear families, people, community living is not there. So the activities have gone down. The food habits have changed totally. So the pregnant females, they are obese now. Previously, they used to be lean and thin and they used to become pregnant. Now they are already obese. So the whole scenario has changed. So we have to, address right at the grassroots level. We have to, change the eating habits. We have to increase the physical activity. Physical activity has suddenly gone down. Nobody is encouraging.
Actually, in the last 2
I think
decades,
eating it is very difficult to stop. But we can increase the physical activity. We can encourage sports, in children.
So in the last 2 decades, with the change of, after COVID, that's one area, and also in the last two decades when the virtual world has, taken.
Everything is available online. Previously, we used to go to the markets and, we used to at least walk.
The kind of word you used, food epidemic, like everything is available in the middle of the night, that's, I think, playing havoc on the health of the people.
बैन करना बहुत मुश्किल है मैम. जैसे स्मोकिंग है बैन नहीं कर सकते. तो बैन करना बहुत मुश्किल होता है. लेकिन एजुकेशन इज वेरी वेरी इम्पोर्टेंट.
Dr. Meenakshi, you talked about diagnosis of obesity beyond BMI. Right. So what is this metabolically obese and normal weight individuals? Can you throw some light on this?
Yeah. So despite normal weight, you can have improper distribution of fat. Like if you do a body composition analysis, the fat percentage of more than 35% in a man and more than 40% in a woman with a normal BMI is metabolically unhealthy. So this is metabolically obese. So even if you have a normal BMI, you can be metabolically obese, and this can predispose to a PCOS. There are so many young girls coming and saying that the child is normal weight, still she is having PCOS. The child is normal weight, still they are having MESELD and hypertension and dyslipidemia. So this is because of metabolic scenario which is associated with the normal BMI. That's why these parameters come into position, which is the body composition analysis, the waist height ratio or waist hip ratio, and neck circumference also.
Absolutely right. Actually, this holds true for Indians particularly, that we are having this distribution, abnormal distribution of fat, and we are all prone to insulin resistance and metabolic syndrome. Many of us may be having a normal body weight, but still metabolically we are into that phase. And actually, importance is to recognize those people who have a family history of diabetes, who have premature cardiovascular disease, GTM, PCOS, who are in sedentary lifestyle, and also in those people where you incidentally diagnosed NAFLD, so there you think that probably you are dealing with these issues.
We call them lean and NFLD, but they are actually not lean. They have improper distribution of the fat. So there also weight loss is important and fat distribution is important. So if you make their fat convert into mass,
there are a few other things, like if you find that people who have got fasting blood sugar of more than 100, people who are pre-diabetics with HbA1c between 5.7 and 6.4, the TG levels are more than 150, HDL levels are low, and BP also is 130, 85 or in the borderline. So, and elevated ALP levels, etc. So these are some of those people who may not technically be called as obese, but they have metabolic abnormalities. So I think these, if we are talking of prevention, then this is that set of people who need to be looked into.
See what we talk about this thin fat Indian. The story came from, when it was analyzed that we had a thrifty gene. As Asians, we have thrifty genes. Means our forefathers, means foremothers, most of them would be famished. They would not eat well during pregnancy. And over a period of time, our gene structure changed that we became thrifty genes. Means we are thin from outside, metabolically we are obese. So that was thrifty gene concept. And then was thrifty phenotype concept, that we look thin but we are not thin. And this thrifty genotype and phenotype together is the cause of getting a fat Indian who is metabolically fat but maybe looking thin.
I think we would like to have some questions from the audience because we are
already
running short of time.
So we can close the session. I think yes,
just a little this thing, like when most of the obese patients are coming to our clinic, it is very difficult to tell them that you are fat. So what I do in my clinic, I tell them that you are okay, you are looking good, but you have increased your weight just a bit. थोड़ा सा वजन बढ़ा हुआ है और इस वजन के बढ़ने से अभी कुछ नहीं होगा, कुछ साल के बाद आपको डायबिटीज़ भी हो सकती है, ब्लड प्रेशर भी हो सकता है, और इसको कम करने का तरीका ये है कि you work double and eat half. You work double, eat half. And secondly, as you raised the question about the children, अगर हम बच्चों को सुबह बचपन में खाने से रोक देंगे तो फिर वो कब खाएंगे? When are they going to eat in life? When they will become in their 40s, they won't be eating anything because. So what we have to do, we have to make them exercise more, less of cell phones and iPads, more of exercises, you see. So ask them, and unfortunately in today's scenario, children have no place to go to exercise. When I was a young girl, I used to play so much. Now children, I see my children, they played less and their children are playing even lesser, unless and until they are not in some other countries where they have lot of playgrounds. So that is very important. Thank you.
Thank you. I think I'll request Dr. Rajiv Gupta to make a final comment and we close this session.
Well, I think prevention starts from the preconceptional stage. What is important that today we should advise all our people who are wanting to have pregnancies that they should be normal weight before they go in for a pregnancy. So preconceptional counseling should be brought in our clinics in a big way, and we should tell all our doctors that they should start this concept of preconceptual counseling. That will probably prevent all these PCOs and GDMs and everything in the next generation?
I wish to thank my chairpersons, my speakers, and the audience for their patient listening and wonderful presentations and discussions. I think this will continue. Obesity Masterclass is going to continue, and Dr. Naresh Dang is going to take up the next part of this. Thank you very much.
So I would like to thank Dr. Ashok Grover sir for an excellent moderation. And I think it's not that just applause, just sitting. You have to stand and applause for them. And that actually would incite us to get move. And this is the theme of this Obesity Masterclass. Yes.
So friends, you will appreciate that we had an excellent session on obesity, and we will talk more about obesity. But there are one or two very important things about obesity which I want to highlight. So our esteemed speakers have spoken so much, but there is one thing that I want all of you to go back with a message. Please find out the why of the obesity before you treat it. Single most important question is find out the why of the obesity before you treat it, because if you do not know the why, you will never be able to treat it. So go into the history, find out the reason for the obesity. If you have found out the why, what, how can follow, you can go and read that in the book, not an issue. But why will come from good history taking. Be empathetic to your patient, ask him, assess the patient, assess the root cause of the obesity, assess the mental status, the psychological issues, the trauma, the stress, what other psychological issues, what job is he or she doing, whether he's going for 40-kilometer distance job, going early in the morning, coming, and find solutions within those parameters. That is the only way you can treat obesity, because you will have to individualize, you will have to cut your history, take your history according to each patient and reach the why, number one. Number two, use the weighing machine as a mirror. Every day, जैसे शीशा सुबह देखते हैं, weighing scale को daily देखें, so that you can monitor your weight every day. And Dr. Rajiv Gupta was talking about the womb, so 1000-day hypothesis is there. कि patient जब pregnant होती है क्या खाती है, what is the weight of the child. Do you know in last 40 years the children who are newborns who are now born are 250 grams heavier than what they were 30 years back. So all these things are very important, and we now start our journey for next session, in which we will see why obesity is a chronic disease and how to manage it with specific drugs. And our first session is by Pankaj. Pankaj, can we have you here? Yeah. So may I also call the chairpersons for the meeting, and chairpersons are, कौन है chairperson? Okay. So we have Dr. Vandana Garg from Max Vaishali, Dr. B.K. Tiwari, senior physician, and Dr. Mukesh Mehra, senior director at Medicine Max PPG. So Vandana ji, Dr. Tiwari, and Dr. Mehra, and Dr. Pankaj Chaudhary. Let's start.
So I think without wasting time, we can start, because I think everybody knows each other. So there are three sessions in this symposium, and finally wrap up by Dr. Naresh Dang sir. So, as Dr. Rightly said, that everything has been discussed, so I would not take much of your time so that we can have some ample time for panel. So this has already been said by Dr. Ajay.
May we have silence in the hall, please? May we have silence in the hall, please?
Yeah.
Silence, silence, silence.
Yeah.
Thank you.
Okay. So this has already been said that 4 in 10 women affected by abdominal obesity in India, and this is the state-wise prevalence, and you can see in Kerala, Punjab, Delhi, and Tamil Nadu are actually, and this has already been discussed. And Dr. Rajiv Bansal has rightly said about the neuronal and hormonal communications, moderate food intake, and energy expenditure, and adipocyte dysfunction is a key driver of related complications. As you see that normal adipocytes, if they becomes, necrotic or they become ectopic, all the issues actually arise and they release a lot of inflammatory cells in the body. So there are definitions is there, this excess adiposity, and American Association of Clinical Endocrinology, this adiposity-based chronic disease, that is ABCD, SAFE's has own definition. ESI, Endocrine Society of India, said that obesity is a chronic, relapsing, progressive disease defined by excessive adiposity that may impair health. So this is maintaining weight loss is challenging. Definitely Dr. Rajiv has already said that there are compensating mechanism which actually favors weight regain. So there are a lot of guidelines are being there, and there are Indian guidelines, that is Endocrine Society of India, clinical practice guidelines, the evaluation of management obesity, and they said that obesity is a chronic relapsing progressive disease defined by excessive adiposity that may impair health. And body mass index have already been defined. So this is the very interesting obesity indicators used for defined obesity, and this is the utility of Edmonton obesity staging system, as Dr. Meenakshi Jain has already pointed out, from stage 0 to stage 4. Stage 0, there are no apparent obesity-related risk factors, and stage 4 is severe disabilities from obesity-related chronic diseases. And stage 0, definitely primordial, and known to me, Dr. Rajiv Gupta has rightly pointed out, the primordial prevention of obesity in womb itself. Then stage 2, primary, secondary, and tertiary, and management defines upon what is that Edmonton stage, from identification of risk factors to identification of correction of risk factors, to behavioral therapy, medical therapy, bariatric surgery, and so on. So guidelines recommends that obesity should not be treated as a therapeutic goals. There are a lot of protocols are there. There are lifestyle modifications, there are pharmacotherapy, there are surgery, bariatric surgery, and this is the lifestyle therapy, like the 2 components, diet and physical activity. As rightly pointed out many of the delegates, that physical activity is very important. So advise at least 60 minutes of physical activity, aerobic and resistance exercises daily, or 300 minutes of activity per week. So how many of you are actually doing it? This is most important. And I think most of the people are here in busy practitioners, and they may not time out of it that this much exercise has been done. So it is very easily said that done, right? So if you want to access your patients, definitely we should follow this first. Dr. Dang, am I clear, sir? So the following weight reduction, most of the regained over time, Dr. Rajiv Bansal has said. So a lot of repeated slides, I won't go in details. So these hormonal changes are already there. So pharmacotherapy for obesity management, this is the approach, that how you approach to the pharmacology of therapy of obesity. So not many drugs are not available. So we were using orlistat, which was being introduced in 1999. Then in 2021, we had semaglutide, oral as well as injectable, and there is tirzepatide as well, is not available. So you have to choose the patient and which patients actually fit into which particular drug that actually been discussed in the coming lectures. So metabolic and bariatric surgery, Dr. Mota has already said that there are 2 types of bariatric surgery. One is restrictive and one is well absorptive. And this is the slide that he has shown that Roux-en-Y actually is the best bariatric surgery which is available, which actually has the total percentage weight loss 30%, resolution of hypertension 40%, resolution of type 2 diabetes 40%, and resolution of sleep apnea up to 50%. Just to summarize, obesity is a complex chronic disease requiring personalized management to address serious implication challenges. Recognition of obesity is classified as chronic disease by leading health authorities like WHO and AMAs. Prevalence, the global obesity epidemic is escalating with staggering rates in countries like US and India. Obesity results from complex interplay of genetic, environmental, sociocultural, and behavioral factors, leading to severe metabolic, biomedical, and psychosocial health issues. Comprehensive obesity management strategies including personalized lifestyle changes, targeted pharmacotherapy, and surgical interventions tailored to individual patient needs. And sustaining weight loss is notoriously difficult due to the body's natural tendency to regain weight, necessitating ongoing support and innovative solutions. And definitely we'll discuss all these issues in my future, in my coming speakers, and we'll have a panel by Dr. Tang. And I think thank you, and we will definitely take home some certain points when we finish this obesity symposia or masterclass on obesity, that what are the pointers that we have that we should follow us and take our patients to take these steps. Dr. Tang, sir.
Thank you. So Dr. Pankaj has very vividly told us that obesity is a disease. Why do we say obesity is a disease? Obesity is actually the window through which more than 200, actually 230 to 40 diseases enter our body. Obesity affects everything from your hair to the toenail. Every cell of the body is affected. The mitochondria are affected. The metabolic function is affected. It is part of the metabolic syndrome, and even if obesity was just alone, there were no complications of obesity, it would still hamper our health by mechanical reasons, by even decreasing the longevity. So obesity on its own is a chronic disease, and once it's a disease, it must be treated. So they say diagnose obesity, put it as a diagnosis on your prescription paper and treat it. Treatment does not always mean pharmacotherapy. Treatment means counseling, exercise, diet counseling. Everyone must get that. In addition, if you feel they need therapy, then give them the relevant therapies. 50 years back, we had no therapy for obesity. 70 years back, we had no therapy for hypertension, or 80 years back. Now we have therapies for hypertension, for diabetes, and similarly now we have therapies for obesity. So diagnose it and treat it according to each patient's requirement. And that is where our next lecture starts. I will call Dr. Himanshu. He's an eminent endocrinologist. He also works with us in Max Healthcare, and he's going to speak on tirzepatide, the dual agonist, GLP and GIP agonist.
Welcome, Dr. Professor Himanshu. I'll be speaking regarding tirzepatide, a novel GIP and GLP-1 receptor agonist. I think you'll be talking about the treatment part. Dr. Himanshu is DM endocrinology, is also fellow in NASH and metabolism, Harvard. He's also got the postgraduate training in growth and pediatric endocrinology from Georgia. He's basically presently a senior consultant endocrinologist at Max Patparganj. He's a former professor and had Rajiv Gandhi Super Specialty Hospital, and he's got a lot of publication, more than 50. He's also area of interest is obesity, growth disorders, adrenal disorders, and received so many awards and recognitions also. So please go ahead with your presentation.
Thank you, sir, for those kind words of introduction. And my topic today is pretty straightforward. So we already discussed a lot about management of obesity, and I would be discussing about the newest शस्त्र जो है हमारे पास इस बीमारी से लड़ने के लिए, the newest thing that we have in our armamentarium, and that is tirzepatide, right? So it is a novel GIP and GLP-1 receptor agonist. The advantage being that GIP was the one molecule that was not being targeted as of now, and it has more impact on basically your fat cells. So the sick adiposopathy that we consider as a part of diabetes and obese patients for now, we have a drug that targets that also. So this is my disclaimer. I'm sponsored by Lilly. So, and this is a contracted speaker for Lilly for this session. And so first thing was, we already had GLP-1, right? GLP-1, if everybody remembers, first GLP-1 came in around 2006. Byetta was its name, exenatide. And there was never such a hullabaloo about GLPs in past 10, 12 years before SEMA came into the picture, and the weight loss became very prominent picture. So even with the initial GLPs, there was some weight loss, but the quantum and degree of weight loss started improving with the newer molecules. So with liraglutide, there was some around 8 to 10% weight loss. With exenatide, there was some around 5 to 6%. And this was because of the mechanism of action of the drug. So it works at 3 sites. It improves your, at CNS, it improves satiety, but that also leads to increased nausea. In pancreas, it improves insulin secretion and reduces glucagon, and the stomach delayed gastric emptying effect again adds on to the nausea and vomiting part. Now, the second part that was missing, because incretin hormones are not just GLP, we have other incretin hormones also. So to compensate for that, we had the GIP activity. For the remaining mechanism was taken care of that. And what GIP actually does in nervous system, it is actually associated with decreased nausea. And beyond the effect on pancreas and stomach that GLP has, the impact on adipose tissue becomes very important. There is increased insulin sensitivity, lipid buffering capacity, increased blood flow to the adipose tissue, increased storage capacity, and overall it leads to reduced pro-inflammatory immune cell infiltration. So the inflammation that we talk about within the sick fat is also reduced once you start getting the lower amount of fat. So the number of fat cells is actually set at birth, and it's actually the size that increases with time. So Mounjaro, that is the name that tirzepatide is available as a single molecule that activates both GIP and GLP. It has receptor activity GIP that is similar to native GIP, while the GLP is actually lower compared to the native GLP. Still, it adds on to the available GLP hormones. So the main mechanism of action is actually based on GIP, and GLP-1 is an add-on mechanism. The mean half-life is around 5 days that enables a once weekly dosing. Another important factor is that as with most GLP and as with most OHAs that we use, there is no dosage requirement reduction when your patient develops a hepatic or a renal impairment. So the mechanism of action is basically based on 4 parts in our body. We want to work upon glycemic control for our patients. For our obese patients, we want weight reduction, improvement in the adiposopathy, there is improvement in lipid metabolism, and the cardiorenal effect, the cardiorenal protection that we need and is now the need of the hour for most of our patients is also an add-on mechanism. So I'll be giving the basic insight from the trials that have come. I know it is going to become a bit boring, so I'm going to try and make it a bit more simplified. So the first thing I'm going to be discussing is about the glycemic control. And in bodies, glycemic control depends on 3 major factors. That is the beta cell function, insulin sensitivity, and glucagon control. Now, this was from the SURPASS clinical trials. These were the initial efficacy trials. And at the end of 40 weeks in most of our patients, there was a significant reduction in A1C as compared to semaglutide, placebo, insulin degludec, glargine, and whenever the patient was added on to a baseline insulin therapy also. So with a significant A1C reduction, especially for those who had higher, we could achieve an A1C reduction up to 2.5%. Now this was in add-on to the drugs that the patients were already taking. On insulin sensitivity and insulin mechanism of action, there was a significant improvement, and at the end, what we were looking for was a change in insulin secretion. So the euglycemic clamp was done, and we were looking for a change from baseline to 28 weeks, how much was the insulin sensitivity, and the beta cell function. So take a look, the first stage function actually improved by somewhere around 150%. And there was a similar improved by 80% in the second stage insulin secretion. Now the first phase is the one that is actually lost in diabetes, most of our patients. So it represents a significant change in the treatment paradigm that we have been using for most of our patients. Now, insulin sensitivity also improved. The M value that was used in the euglycemic clamp improved from 35% to 63%, and the glucose infusion rate actually reduced. The glucagon response to induced hypoglycemia was still present. So the blunting of glucagon response that is seen with sulfonylureas was actually absent with GIP and GLP-1s. So to summarize, in patients in type 2 diabetes, Mounjaro actually improves both beta cell function and insulin sensitivity. And what was very important to see was this was weight reduction independent, right? So whenever you are getting a weight reduction, your insulin sensitivity and beta cells function tends to improve. But the improvement with Mounjaro was actually way beyond the weight loss that it provided. It demonstrated a better A1C reduction than semaglutide, reduction in glucagon AUC as compared to semaglutide, and the intact glucagon response to induce hypoglycemia changes was present, which is another factor to ensure that your patients do not go into hypoglycemia. Now let's talk about the second part, that is the weight reduction. Now, weight reduction is where most of our patients do accept taking Monjaro, right? As Dr. Ajay Gupta initially in his presentation said, they have a lot of excuses. Sir, it is costly, it's an injection, right? And once you start talking about weight loss, कि नहीं वजन कम हो जाएगा इससे. Most of my 50% of the patient, those excuses go away. Sir, weight loss हो जाएगा? हाँ ठीक है ले लेंगे. अगला सवाल आता है कितने दिन लेना है, right? So that part needs to be managed, and weight reduction is where the forte of this molecule lies. So we had OHAs, we had cardiovascular drugs such as SGLT2 also, but weight loss was something that was elusive. The quantum weight loss we want for our patients, where we start getting cardiorenal benefits, is around 15%, and that was something that was lacking in most of the molecules that we are using. So at the end of 72 weeks, even with 5 mg, which is the lowest maintenance dose, there was a 16% reduction on average. Now, doesn't say that there was not a higher or a lower, it's an average reduction. So you will have some percentage of patients who responds less to GLP as with semaglutide, and there is a population. So as Sir said, there is a patient that has lost 30%. I have a patient who's come down from 161 to 103. That's around a 40% reduction in weight with this molecule, and that goes into the category of bariatric surgeries actually. Body composition analysis, has been already talked about, is now going to be the gold standards to measure the fat mass. And there was a significant reduction in fat mass. And what happens, so there is no molecule, no drug that actually ensures only fat is lost. You're going to lose some muscle, right? But if your fat loss in comparison percentage-wise is way more as compared to the muscle mass, so at the end you may see actually that the percentage muscle mass has actually improved as compared to the weight, and that is what was seen in Monjaro patients. So baseline mean, again, so fat mass was actually dropped and the mean fat-free mass percentage actually improved. Now this was something very important, right? When we sleep, our metabolic rate goes down, right? Especially in patients with OSA, we start getting those early morning awakenings and all, and then you have daytime somnolence. And the primary objective was to actually measure the sleeping metabolic rate, and we are going to be assessing it at around 18 weeks. Now, most of these patients, what was actually needed to be that they needed to be on stable body weight, because change in body weight is again going to be impacting the metabolic rate. So the sleep reduction, weight loss induced reduction in metabolic rate and the 24-hour sedentary energy expenditure actually did not attenuate. So the weight loss induced reduction in sleeping metabolic rate that occurs actually did not change with tirzepatide. So all in all, there was reduction in food cravings from baseline, and there was no reduction in the sleeping metabolic rate. Now coming to lipid metabolism again remains one of the key pillars of management in our diabetics and obese patients. And with the lowering levels of target LDL, we need to keep on finding other measures, right? So initially when I started my MBBS, the target LDL used to be somewhere around 120. Then for diabetics, it came down to 100, then 70, now 55. And with the recent, if you have had a look at the recent European Society of Cardiology guidelines, they start talking about less than 30 for very high risk patients. So LDL is going to be, I think, Dr. J.P. Sani is supposed to come here, and in one of his talks, if it goes 0, that's the best, right? But that remains to be seen. So lipid metabolism again, so any drug that adds on to that armamentarium is going to give us a good result. So there was a reduction in triglycerides, HDL cholesterol remained stable, LDL was reduced by 7 to 8 milligram deciliter, and VLDL cholesterol. So while the reduction was small, it was statistically and clinically significant. Now coming to the last part of my talk, that is the cardiorenal effect, and that is where again this drug provides a lot of results. The CVOT has just come up, right? And so we all know about the changes from pulse rate and blood pressure, and there was no increased risk of MACE, right? So while the hazard ratio was 0.8, unfortunately the confidence interval was more than 1, so 0.57 to 1. So we cannot say it was statistically significant. With weight loss, definitely there is going to be improvement in cardiovascular health, but there was no increase in MACE. So even with the SURPASS 1 to 5 trials, we are not talking about CVOT because they are not letting me as of now. There is a reduction in CVOT, the recent CVOT that's yet to be published, but the data has come up, the SURPASS CVOT trial. So key takeaways, again, mechanism actions, well known, and these are, so when a patient complains of nausea and decreased appetite, do tell them that's not a side effect, right? They keep on asking whether it's a side effect, whether it's a side effect. No, it's not a side effect. It's a mechanism of action of the drug. So you get a molecule that activates two naturally occurring hormones, GIP and GLP, leading to reduction in appetite, food intake, and the third part that was missing with just GLP, that is increased fat utilization. It reduces both the hedonic and your homeostatic eating. So the pleasure eating that was talked about earlier and the usual food intake. It is reduced and it decreases the feeling of hunger, all of which leads to an improvement in body mass, better A1C results, better results over time in our patients with glycemic control, better results with health-wise. I have had 75-year-old patients who have lost 10 kg and improved. Thank you all for a patient listening. I think I am on time. Right.
Thank you, Dr. Himanshu, for the wonderful talk and completing in time. So our next speaker is Dr. Anupam Biswas. He's a senior consultant endocrinology from in Fortis, Noida. Is recipient of many awards and published many papers in national and international journals.
So good morning, everyone. Before starting the topic, surmounting obesity with tirzepatide, just a small trivia. Just a couple of weeks back, WHO has recommended these anti-obesity medications along with diet and lifestyle, and it can be used long-term in patients with obesity to avoid the complications because of the consequences of obesity. So, tirzepatide, novel mechanism of action, it has already been spoken about. GIP, again, the action and the mechanisms are far more complex than what it is understood till now. In fact, if you look at GIP, you have a molecule tirzepatide which is causing agonism at GIP, which is leading to weight loss. There is another molecule which is coming up, maritide, which is a GIP antagonist once a month, that is also leading to weight loss. So the paradox is that at the same GIP, agonism and antagonism is leading to weight loss, probably agonism because of increased overstimulation of the receptors and receptor desensitization. It is leading to weight loss. So GIP is a nutrient stimulated hormone. It was discovered before GLP-1, but it has of late gained popularity because of this dual agonism, tirzepatide, GIP and GLP-1 agonism. So tirzepatide is a single molecule designed to activate both GIP and GLP-1 receptors based on the native GIP sequence, and activity on GIP is similar to the native GIP hormone, whereas activity on GLP is lower as compared to the native GLP-1 hormone. Mean half-life of almost 5 days, enabling once a week dosing. No dose adjustment is required in patients with renal or hepatic impairment. So it addresses some important biological adaptations of obesity. So there are two important trials to remember. One is the SURPASS trial. The second is the SURMOUNT trials. So the SURPASS trials have been studied in patients with obesity, in diabetes, whereas SURMOUNT has been done in patients with obesity. It has shown good efficacy in reduction in HbA1c and also in improvement in weight and other metabolic parameters. In fact, SURMOUNT OSA has shown improvement in patients with obstructive sleep apnea, and outside India it is also approved for patients of obstructive sleep apnea. In type 2 diabetes, it is indicated as an adjunct to diet and exercise to improve glycemic control in type 2 diabetes mellitus. And in patients with obesity, it is recommended, it can be used in patients with a BMI of greater than 30 or in patients with BMI greater than 27 with other comorbidities like diabetes, hypertension, dyslipidemia, or even obstructive sleep apnea and PCOS. So some of our PCOS patients are also doing well with weight reduction, and improvement in fertility is also seen in some of our patients. So coming to the SURMAS and the SURMOUNT program, so Monjaro has been studied in a comprehensive development program involving greater than 6,200 participants across different stages of type 2 diabetes. So as I already mentioned, SURPASS has been studied in patients with type 2 diabetes. SURPASS 1, 2, it has been compared with semaglutide, and it showed that even the lowest dose of tirzepatide 5 mg was superior to 1 mg of semaglutide. SURPASS 3 with Degludec, SURPASS 4 versus insulin glargine. These are the SURMOUNT trials. SURMOUNT trials have again done in patients with obesity. The important one here is the SURMOUNT 5 and SURMOUNT 4. SURMOUNT 4 has shown the long-term effects of using tirzepatide and what happened to patients who stopped tirzepatide. And SURMOUNT 5 is about comparing semaglutide and tirzepatide at the maximum tolerated dose. So coming to SURMOUNT 1, investigated tirzepatide 5, 10 and 15 in patients, adults with obesity or overweight with complications without diabetes. That is important. And what was seen here was almost 16% average weight reduction in body weight with the 5 mg dose and 22.5% with the dose of 15 mg. Majority of patients with obesity achieve greater than 10% weight loss, and achieving greater than 10% weight loss can actually lead to remission of a lot of your metabolic complications. Patients with obesity on tirzepatide experienced also improvement in body composition. So there is some skepticism about loss of protein, fat mass and even your muscle mass. So it is more of visceral mass which is lost, which is important. There is some amount of protein loss and muscle mass loss also. So make sure you keep yourself hydrated and take adequate protein in your diet. That is very important. In fact, there are some new investigational drugs now which are being, along with these GLP-1, which are being tried, like bimagrumab, which is an actin-3 antagonist, which leads to muscle preservation along with weight loss. So that is important. So people taking Monjaro experienced improvement in various cardiometabolic parameters, not just diabetes and obesity, reduction in blood pressure, triglycerides, and improvement in LDL and HDL cholesterol also. So the question is, what happens if you discontinue tirzepatide? This was studied in SURMOUNT 4. So in these patients, there were two groups, one which was continued and one which was stopped after 20 weeks. So you see here, patients who were continued, so most of the patients lost around 20% body weight. The patients who continued tirzepatide further lost body weight to almost 26%. Whereas the patients who discontinued at 36 weeks and you evaluated them again at 88 weeks, it was seen that they had lost around 9.5% from the time they started tirzepatide. So continuing tirzepatide over a period of time would lead to even more weight loss with the maximally tolerated dose. And that has also been recommended nowadays in patients with diabetes and obesity with major complications of obesity, that you can continue them for a long-term period. Now coming to the adverse events, which is right now the talk of the town. A lot of adverse events have been reported. So the major adverse events are mainly gastrointestinal, maybe nausea, vomiting, diarrhea. The important ones to highlight here is that you have to be skeptical in patients who have had a history of pancreatitis, and try avoiding who have had a history of pancreatitis. In patients with family history of medullary thyroid carcinoma, you have to be, because you have to take that history. Although there has been a Korean registry which has just released the results, they have evaluated patients from 2014 to 2020. And they compared GLP-1 with SGLT2 inhibitor and DPP-4 with SGLT2 inhibitor. And at the end of this database, they have seen that there is no increased risk of medullary thyroid cancer with either GLP-1 or DPP-4 inhibitor. But because in rodents it was seen there was an increased risk of medullary thyroid cancer in patients in rodents, that is why there is a black box warning. But there is also a species differences because in monkeys and humans there is less abundance of C cells which can lead to medullary thyroid cancer. Important thing again which is the talk of the town is NION, non-arthritic anterior ischemic optic neuropathy. So NION is a very serious complication, but there have been studies where have shown increased risk, but then there are studies which have not shown any increased risk also. NION is also increased in patients with obstructive sleep apnea, in patients with diabetes, hypertriglyceridemia and hypertension. More important here to remember is always do a fundus examination, and if the cup to disc ratio is less than 0.3 and 0.2, this can be a predisposing factor or a factor which increases the risk of NION. So doing a fundus examination is very important to rule out NION. It is said, it is hypothesized that there are GLP-1 receptors in the optic nerve, and probably because of hypoperfusion of the short posterior celiac artery, it can lead to optic neuropathy. But again, even doing a fundus examination will not confirm which patients will develop NION, and it is a very rare complication. So the adverse effects have been spoken about. Coming to the summary of the slide now, tirzepatide significantly reduces body weight by an average of 16% with 5 mg, 22.5% with 15 mg. Improvement in key cardiometabolic parameters. The most common adverse reactions were GI in nature and were mostly mild to moderate. Recently, there has been certain doubts about whether it leads to increase in suicidal tendencies. So in our patients, what we have seen is that actually obesity-related depression improves with these anti-obesity medications. But it is very important that patients of depression, you do a simple PHQ-9 scoring. If the patients have a moderate to severe depression, be in consultation with your psychiatrist before starting this medication. Thank you so much for patient listening.
Thank you, Dr. Anupam Vishwas, for finishing the talk in time. Now our next speaker is Dr. Hanish Gupta, sorry. I will call him on the dais, and he is a very experienced doctor, a specialist consultant at St. Stephen Hospital, New Delhi, founder and consultant Life Aid Clinic, Mayur Vihar, Fellow Diabetes India 2024, Treasurer RSS DI and Delhi Chapter, Managing Trustee, Life Aid Education Trust, panelist in elsewhere, permanent member of ADA and EASD. He got honors and awards many times, especially Emerging Opinion Leader Award and expert on Government Steering Committee for Prevention of Control of NCD. Now he has many publications to his credit, and no more wasting time, over to Dr. Hanish Gupta.
Thank you so much, sir. Thank you for this kind introduction, kind words, and thank you everyone, and thank you Lily for giving me an opportunity to be here on the dais today. My talk is going to be about tirzepatide versus semaglutide, evidence from head-to-head trials. This is unique in its own way because hardly do we see that two molecules which are top-notch molecules, they ever do get a head-to-head trial. So always the talk is about which is better than which one. That probably gets settled because we do have two trials which have compared these two medicines head-on. And this is my disclaimer. Of course, I am contracted by Lily for this particular talk. And thank you, EDPA, for giving me an opportunity. See, we started with forgotten hormone, that is GIP. And then more research was done on GLP. And finally, GLP came out earlier than GIP. But we need to understand that GIP was the one which got discovered first. It was in 1970s that discovery of GIP was done. It was secreted by duodenal K cells. And GLP was discovered in 1980. It was secreted by distal ileal L cells. So science progresses. Sometimes we lose sight of very promising therapies. It is not possible to do studies on humans all the time. Some things fail, and it is very difficult to actually come out with propositions as far as medicines go. There are proposed roles for GIP and GLP in regulation of metabolism. And let me tell you, it is not just the receptor analogs that work. While we talk as of now, there are also receptor antagonists that are being tried for the same proposition. So it's not that the agonists only have their say in this world. But as far as today is concerned, it is the receptor agonism, that is GLP-1 activity and GIP-1 agonism activity, which has garnered the support and garnered the possibility of use in the mainstream. So GLP-1 activity is mainly when we talk about central nervous system. There is reduced food intake, there is increased satiety, and of course there is increased nausea. That is the reason that molecules that have got GLP-1 activity only, like semaglutide, these molecules would probably lead to more nausea, vomiting, and patients will come to us saying that, okay, it's difficult for me to actually have any intake because I'm having vomiting. With the GIP activity, you can see again there is reduced food intake, but there is decreased nausea. And that is probably the reason that many of you who would have used tirzepatide versus semaglutide would have encountered that patients who are on tirzepatide, they will be coming more with diarrhea rather than nausea. And that is just one of the things that gets sorted in this jigsaw puzzle. As far as the pancreas part is concerned, there is increased insulin secretion by both of them, but GIP activity also contributes to an increased glucagon activity. And when it comes to adipose tissue, there is increased insulin sensitivity, increased lipid buffering, increased blood flow. So all these activities, they're attributable to the GIP, not the GLP. So that is one of the things that we want to explain physiologically out here, that it is both the things cannot be same. One is just GIP, the other is GIP plus, one is just GLP, the other is GIP, GLP, both of them together. Now, what are the unique actions of GIP at the pancreas? See, when we look at it, the GIP is contributing 44% of the action, and the GLP-1 is contributing 22% of the action. So endogenous GIP generates a more significant effect, insulin-mediated glucose clearance, compared with endogenous GLP-1. So now coming to the crux of the matter, how do we apply this clinically in our day-to-day practice? So we just take a hypothetical patient here. I'm sure that this Anjali has not been changed for 7-8 months. So everybody has seen this Anjali many times. So she is an obese patient living with type 2 diabetes. And why should we consider Mounjaro, which is tirzepatide, for a patient versus a different obesity management protocol? So here comes SURMOUNT-5, which is tirzepatide maximum tolerated dose versus semaglutide maximum tolerated dose for people with obesity. So you need to understand that there are two sets of trials that were done. One was SURMOUNT, one was SURPASS. SURMOUNT trials were actually only with the patients with obesity. SURPASS trials are the ones which were done for the patients with diabetes. Now SURMOUNT-5 is that head-to-head trial which was done with tirzepatide versus semaglutide. Now Mounjaro maximum tolerated dose can go up to 10 mg to 15 mg. Semaglutide maximum tolerated dose can go up to 1.7 mg to 2.4 mg. It was a phase 3 multi-center randomized parallel arm open label active comparator trial. 750 participants were taken. Mounjaro and semaglutide were of course administered subcutaneously once weekly. Now this is very important to note down here, which may be missed. Just below the slide C, as an adjunct to reduced calorie diet and increased physical activity. So every time, when you get a patient and you say that, and you give, hopes to them, अरे ये drug तो 22% कम कर देती है weight, या ये drug तो 15% कम कर देती है. Now it is not just the drug. Always remember that, when we are driving, when we get an automobile detail also, then we say, कितना mileage था? वो 22 किलोमीटर पर आ. But do you actually get that on the road? I mean, आपने रोड टेस्टिंग करी, रोड टेस्टिंग के अंदर कोई भी ऑटोमोबाइल वाला बोलता है कि सर कितनी माइलेज है? 22, 23, 24 तो सर आराम से देती है. आप रेगुलर सिटी के अंदर गाड़ी ड्राइव करते हैं, आपको 15 से ज़्यादा नहीं मिलती. That's road testing, that is controlled environment. So all trials are done in controlled environment. So when you make this statement as an adjunct to reduce calorie diet and increase physical activity, that is what you need to also imply to your patients as well. So don't be, having so many high hopes, but at the end of the day, We'll come to the phase trial studies and we will understand that. But just this was a point apart from what I wanted to make, that these are, controlled environments. These are road testings done in controlled environments. So either mileage अच्छा ही होगा. So you need to understand that when you are offering drugs, don't offer miracles to the patient. Tell them diet भी reduce करनी है, physical activity भी करनी है, साथ में drug काम करेगी. Now this is Mounjaro maximum tolerated dose, demonstrating a superior reduction in body weight compared to semaglutide. Now the part here is that how much efficacy it can exude. Kitna efficacy milta hai. So if everything is being done right, then definitely tirzepatide will score much higher than semaglutide. Because at 72 weeks, participants taking Mounjaro, they experienced a mean percentage body weight reduction of 21%. Now that is huge. There is not a single proposition available up till now जहाँ पे 20% body weight reduce हो जाता है. And this is something which is a phenomenal thing, and that's probably the reason that these medicines, they are making, they have taken the world by storm. They have become such a high phenomenon. They are reducing the weight. Somebody comes to you with 100 kgs, if everything is being done right, loses around 15-20 kgs, that is miraculous, because he will be saved from a lot of illnesses. Diabetes reversal might happen, or remission, you can say not reversal, but remission may happen. And then again, so many cardiovascular, renal benefits that can be afforded to the patient that will come into the play. Now, 1 out of 3 participants taking tirzepatide, they achieved more than 25% mean reduction in body weight versus 1 out of 5 taking semaglutide. So it's like saying that more people with tirzepatide will achieve a greater weight loss as compared to semaglutide, because significantly higher number of participants are achieving weight reduction. So you have to understand 2 things. Not only the efficacy is important here, but the number of patients who are responding are also important. It's not just that the drug is doing a wonderful job in patients by bringing their weight down by 20-25%, but that effect is being seen in more number of patients as well. And then there are participants taking Mounjaro experiencing superior reduction in waist circumference. So this is what actually happens. Patient comes to us. There is first 3-4 months, or maybe 2-3 months, the patient comes 7-8 kgs come ho gaya, and suddenly it plateaus down. But whenever they keep coming back to me, I keep asking them, are you losing weight? They will say, no, I'm not losing weight. But I look at their waist circumference is getting down. Then I ask them a simple question, पेटी का साइज कम हुआ तुम्हारे? कहते हैं हाँ सर, 2 छेद इधर को करने पड़े. और मैं कभी जिंदगी में तुझे अपनी बेल्ट में छेद के अंदर करवाना पड़ा? कहते हैं नहीं सर. So this is what is happening. There is redistribution of fat also happening, and also importantly, what I realize is that the bone weight also goes up because the patient become active. Now the patient is becoming active, bone is a dynamic tissue, and the bone starts to accumulate calcium, the bone starts to accumulate more nutrients because of the excessive walking of the patient or increased walking of the patient, and the bone weight is going up. So the body proportion is getting changed, abdominal fat is going down, visceral fat is going down, the fat within the layers of the muscles is going down, and the patient weight has plateaued. But if you ask their fitness quotient, that are you becoming more fit, are you feeling better, then of course the answer is always yes. So you can see here, 7.9 inches, 2 इंच से ज़्यादा किसी के 2 छेद जो होते हैं बेल्ट के अंदर 2 इंच से ज़्यादा नहीं होते. And if they are saying 8 inches, that means 4 new buttonholes have to be made in the belt, which is quite phenomenal. Now this is again another patient, Janvi. She also has not been changed for the past 8 months. This is a patient for diabetes. Now we are going to talk about a different trial, which is SURPASS-2 trial. Now SURPASS-2 trial was the comparison between the 2 drugs when we talk about diabetic patients. So why should you consider tirzepatide for your patients with type 2 diabetes versus other GLP-1 receptor RAs? This is the SURPASS head-to-head trial where Mounjaro 5, 10, 15 was used for semaglutide 1 mg. Why semaglutide 1 mg? Because that is the drug which is licensed for use in diabetes. Now 8.3% overall mean baseline was there, 8.6 years of mean duration was there, 34 baseline BMI was there, around 1900 patients were there. And you can see that they had more patients on Mounjaro because Mounjaro had 3 arms and semaglutide had 1 arm, and 0.255, and they settled at 1 mg at 4 weeks. Now this is Mounjaro demonstrating a superior mean HbA1c reduction across all the 3 doses. So the lowest dose of Mounjaro that was given was 5 mg. It also did better than semaglutide 1 mg, and that is what probably the message out here is. then there are significantly more patients. Now, one is the efficacy, the other is whether the patients, number of patients are, how many number of patients are responding or not. So significantly more patients achieve HbA1c reduction across all the doses of Mounjaro versus semaglutide 1 mg. You can see here semaglutide is in gray and the colorful, because these are slides from Lilly, so color has been given to Mounjaro. So the colorful slides are Mounjaro, the strips that are going flying high with high building skyscrapers. Now, Mounjaro also demonstrated a superior weight reduction even in a trial which was done for diabetes. There was reduction in weight across all the 3 doses versus semaglutide 1 mg, superior weight reduction that did not plateau over the study period of 40 weeks. And you can see that the highest dose of Mounjaro 15 mg could afford the patient of 12.4 kg weight reduction, which is 13% of the body weight of the patient to start with. And, surprisingly, that because there was the answer also gets here, that the 6.2 mg, the 6.2 kgs were also lost by semaglutide. But surprisingly, they should have had an arm where no drug was being given. And the adjunct was only, diet and physical control. I'm sure some weight loss would have been there also, but that slide is not here. Now, there are more number of patients who achieved composite endpoint with Mounjaro versus injection semaglutide. Again, the colorful part you can see, there are so many patients with Mounjaro 5, 10, 15, number needed to treat. So many patients responding, almost 60% of patients who were having diabetes, they responded with a HbA1c reduction to 6.5 target level, weight loss greater than 10%, and no clinical significant or severe hypoglycemia. This is surpassed 2 head-to-head compared trial. As far as the adverse effects are concerned, you see, it's actually both have got a similar profile, but in the real world we have noticed that patients on tirzepatide will have less nausea, a little bit more diarrhea, and patients on semaglutide will have nausea and constipation. The beauty of this once weekly medicine is that the decision making of the patient is shifted from every day to just 1 day. Earlier there was every day you have to take a pill, you have to make the decision, the patient is going to have nausea, vomiting every day. But when you have to take the pill only once weekly, the decision making is shifted to 1 day. By the time the next dose time arises, nausea, vomiting goes away. So the patient is ready to take the next dose. So that's why once weekly medicines, they are doing so better than Rybelsus, which was earlier present in semaglutide. Overview of adverse reaction, nothing that leads to death, no significant. And the most significant were GI related. The incidence of hypoglycemia very similar to both of them. Just to summarize, the tirzepatide 10 mg, 15 mg, of course, demonstrated more superior weight reduction, being a GLP, GIP, both receptor analog, versus semaglutide, which is GLP-1 receptor analog. Tirzepatide achieved, 21%. Tirzepatide had a superior HbA1c reduction as compared to semaglutide. Thank you so much. If you allow me a minute, just a second to tell that dosing is similar. You have to start with a 2.5 mg dose, go for 4 weeks, 5 mg dose, go for another 4 weeks, 7.5 mg to continue with if you require it. And these are some important, thank you.
Thank you, Dr. Hanish. Excellent lecture. So we'll have some question answer sessions and maybe take a question or two from the audience. There will be a lot of your patients who will not respond to anything. I mean, you give them tirzepatide, you do lifestyle modification, and that is where you have to think of secondary causes of obesity. So, Dr. Pankaj, what is your take on some of these causes?
And actually, we are just discussing about obesity, and sometimes patients wouldn't, respond to drugs. So we just wonder at what's happening actually. So definitely there are a lot of secondary causes that we need to look into it, and most common is endocrine cause. Endocrinologists are there, Anupam and Anwanshu is there. And hypothyroidism is one of the most important cause where the response may not be adequate with these drugs. Then Cushing syndrome is another. Then insulinoma, sometimes the question was there in quiz, insulinomas and hyperinsulinemia. Then hypogonadisms, PCOS, there are some causes of endocrine cause. And the different causes, like drugs that we have been using, like steroids, the antipsychotics, the anti-epileptic drugs, any diabetic even, patient on insulin, patient on sulfonylureas may not lose that much of weight. So there are lot many causes of secondary, some hypothalamic causes are there. Some genetic syndromes, actually there are syndromes, actually they dwelt in the childhood, like lot of disease like Prader-Willi syndromes, right? One is the monogenic obesity, that MC4R mutation is there with leptin. So there are lot many causes that we need to look into that.
Yeah, so we have to keep in mind that there will be some patients who will not be just classic obesity, and if they are not responding to therapy, if they're gaining their weight, then you need to look into these secondary causes of obesity and treat it accordingly. Leptin receptor deficiency, MC4R
Naresh, here I'd like
deficiency.
to mention it is not the drug alone actually. Whenever you're treating these drugs with anti-obesity drugs, you have to understand the lifestyle modification for a sustained benefit and a long-term benefit, because these are the drugs which there is no definite time limit you have to use actually. You have to use this for indefinite time. There is no defined duration for which, but right from day one, lifestyle, diet and control and controlling other metabolic factors is very, very important to have the benefits actually.
Sure, sir. So Dr. Himanshu, non-responders, now, and no secondary cause found, what more can you do? Can you add some additional therapy, number one? And what other things do you do for your patients so that these non-responders become responders?
So one thing that I have observed, as I said, those who do not have the adherence to lifestyle modifications does add on a lot to the action of the drug also. So it's not a panacea, ऐसी कोई संजीवनी बूटी नहीं है कि लगा दिया तो सबके six pack abs बन जाएंगे, right? So lifestyle modifications do remain. Yes, if you have patients who have severe knee osteoarthritis and all, you're not expecting that much exercise. But then in those patients, you can ask them to do upper body exercises. So if you're burning calories, those things work. Two, I've observed that at times patients who are already taking very low calorie diets and still not responding need to work on the other mechanisms such as metabolism. So there are drugs. I have seen a few of my patients improved with coenzyme Q10. Right? It's basically a drug that's supposed to increase. We do not have any direct scientific evidences that it does work for every patient. But yes, there are other nutraceuticals that help. I have added Orlistat to a few patients. That has also helped. So all in all, there will always be, so medicine is always a game of probability, right? So 95% will be responders, 2.5% will respond very high, and 2.5% will not respond at all.
So I agree with you, and these non-responders, if you do intensive lifestyle modification, give them high protein diet, decrease their carbs, decrease their fat intake to reasonable levels, increase fiber, and all these things together with drugs, maybe adding one more drug like he said, Orlistat, you can get weight loss even in these very tough to treat obese patients. So Dr. Biswas, I have a question for you. Who gets SEMA and who gets tirzepatide in your practice?
So again, treatment here should be individualized, and if you look, most of our diabetic patients, you can start with either of them, sir. There is nothing like this patient. But yes, definitely if you look at the cardiac trials, they are initially more in favor of semaglutide, but with the SURMOUNT cardiovascular CVOT trial, definitely you have role of tirzepatide also, where it was compared with dulaglutide, and dulaglutide has already shown superiority to placebo. So in this trial, they have taken a putative placebo, and that is why they can also be started with tirzepatide. Having said that, coming to patients with MASLD, semaglutide is approved because of the ESSENCE trial, but tirzepatide also probably will be approved in a few months, because they also have their data with the Synergy NASH trial. SURMOUNT MMO trial is also going on for mortality benefit, and even the TREASURE kidney trial with tirzepatide is also on the way. So if you look, these drugs are more similar, and you can use either of them in most of our diabetes and obesity patients.
Thank you. Dr. Hanish, a few words on weight loss maintenance, because weight loss happens and then it is regained. So a few words on weight loss maintenance.
Sir, so there was an earlier question that that kids should be, one of the delegate ma'ams was saying that बच्चों को अगर पहले से नहीं खाने दोगे तो वो कब खाएंगे, 40 की उम्र के बाद आके खाएंगे. So I want to allude to that question. The question is not that whether बच्चे को खाने नहीं allow करना. The question is that बच्चे को क्या खाने को allow करना है. So we go to, as our health initiative, we go to canteens of not only just government hospitals, but especially private government schools, but especially private schools. What do we get? We get spring rolls, we get Maggie, we get all the fried stuff. And I don't think so there is any lean protein that is being offered to any of our kids anywhere. There was a study that was done, Indian schools versus Japan schools. So Japanese kids, they will have a bento box. And that bento box, there are going to be 5 sections. Only 1 section is for carbs. 4 sections are for proteins. So every day in that bento box, the child will bring food from the home, and the child will start from taking protein and then end with the carbs. So the child will realize from the very beginning that protein is a very integral part of my diet. Other thing is, their school will start with physical education first. So hand-eye coordination will start for children from first to third. From third standard onwards, there are going to be rigorous physical exercises. They will start with a physical education period first in the morning. First day in the morning, they will start. For 1 hour, they will be having a physical education. In India, we will be only teaching the kids in the classroom, closed classroom. They will be in the school. PT period is going to be something which is more of fun, going around, not playing anything, and then they will come back home. So we are not inculcating the cultural relevance of control of obesity from the day one. So weight maintenance starts as a journey. It's not a destination. Why it fails? It fails because women will decide one day कि मेरे घर में शादी है 3 महीने बाद मुझे 75 किलो का होना है. They will touch 75 kgs. The moment they will touch it as a destination, they will regain back 90 की हो जाएंगी. Because people have to realize that weight loss is a journey, it is not a destination. ये कोई point नहीं है कि milestone पे पहुंच गए 75 किलो touch कर दिया उसके बाद मेरा काम खत्म. You have to continue that journey. You have to keep yourself alert, what you are eating, how much you are eating. It's always about, more than how much you are eating, it is always about what you are eating. That is the main crux that I will say.
Thank you. Dr. Vandana, any comments?
I completely agree what Dr. Anish has said. It is what you eat and the lifestyle, that is the exercise. It is हमारे यहाँ पे schools में physical education का एक chapter होता है. वो आधे time it's a theory chapter. And there is no physical education. The physical education, they said, do this, but it's never followed. It has to be done from the very beginning. You have to be a day which can be off exercise, but that should not be like deliberate. Okay, once in a while. So if it is in your day-to-day activities, there is walking, exercise, muscle strengthening, and a day you don't do it, you should feel I'm missing something.
Dr. Tiwari, आप conclude करोगे?
Right, sir. So obesity, as every speaker and we know that obesity is a chronic disease. And I have been to abroad, especially my sons are staying in Toronto. I have seen that obesity is coming in the poor and poor middle class rather than the rich class. Because rich class can afford to eat healthy. But the poor and middle class, they go to the McDonald's and other outlet where the fast food is there and non-healthy food is there. So apart from educating the parents, children, we should basically increase the affordability of the healthy food. That is what I say. Thank you.
Dr. Mehra, can you conclude it?
Yeah, please. Conclude, sir. Dr. Vishwas, one of my members actually asked us to discuss about that videos going on that Australia had 5 lakhs people affected by suicide. So what is the comment on that? Because they were asked to ask the question from the panel.
So for that, again, that is why it's mentioned, it is very important to do a PHQ-9 score, which divides depression into 3 to 4 types. One is whether it is minimal, whether it is mild, whether it is moderate, moderately severe or severe. So if it is moderate or moderately severe, it is definitely better to consult a psychiatrist before starting the drug, and also regular follow-up with a psychiatrist.
Regarding suicidal tendencies?
Yes, that is what, because of that.
So, thanks Dr. Naresh for wonderful coordinating this session, and lovely presentation of Dr. Pankaj, Dr. Hanish, and Dr. Himanshu, and Dr. Vishwas. So, as Dr. Pankaj started, that the obesity is a chronic disease, long-term, with a lot of genetic, environmental, behavioral, and hormonal factors. So, you are talking about the treatment part. The previous speaker, they talk about the medical part, lifestyle, behavioral part, and the surgical part also. When come to management, now we have seen a clear-cut benefit of tirzepatide with a dual benefit of GLP and GIP both. And not only weight reduction to the tune of 21%, the inches loss also, and the cardiorenal benefits also, and the acceptance also, the minimal side effects. Advantage of GIP, it reduces nausea also, which is induced by GLP-1. So that is also advantage with this molecule. Acceptance, we have all experienced, it is significantly better over the period and when compared to the other GLP-1 receptor agonists. So I think now we have solution to obesity, whether it's come with diabetes or other metabolic disorders, and looking at the lot of pleiotropic benefits. I think this is a drug of future and present also. I think let us wait for the price control also once it comes, and then there will be a drug for masses also. Thank you.
Thank you so much.
The head-to-head trial between tirzepatide and semaglutide.
Yes, sir. Sir, I am the culprit, yes, sir.
I have a request, because you presented the head-to-head trial, but don't you think that this trial is slightly skewed in favor of tirzepatide? Because you are using full dose of tirzepatide and sub-maximum dose of semaglutide and giving
So
it.
the licensing for diabetes is 1 mg only for semaglutide. Wegovy, they are marketing for a drug as a for obesity. It is up till 1.7, 2.4.
Up to even up to diabetes,
Yeah,
they say
so
they have up to
when-
1.7, but
when
yes,
sir-
up to that is 2.4.
Sir,
But
0.4,
comparing
yeah,
that maximum with this subminimal.
Yeah,
and
so
then the
I'll
result is
clarify.
skewed.
Surmount 5 was for obesity. In that, the maximum tolerated dose of both the drugs was used, 10 mg, 15 mg for tirzepatide and 1.7 mg or 2.4 mg for semaglutide. When it comes to Surpass, the Surpass was the trial for obesity. In that, it was used up till 1 mg because 1 mg is the licensed dose for diabetes.
I'm talking about comparable doses.
So actually, if you are an obesity specialist, then you write the diagnosis of obesity with diabetes. And if I'm writing obesity with diabetes, I am going to go up to 2.4 mg if needed. So, I mean, but anyway, this is a debate that can go on. Any more questions can be taken care of in
I
tea
always get a tachycardia when Dr. Anil Mota asks me a question.
So we'll
I'm saying I always get a tachycardia when you ask a question.
Oh, sir, I got tachycardia when I saw the trial because I thought I'm prescribing a wrong drug.
So we'll call it.
Excuse me.
Personally, I have not combined Orlistat with GLP-1, but if I were to combine, I would combine something like phentermine topramate or one of those, something, not exactly Orlistat, because वैसे ही है वो gastric emptying delay कर रहा है तो Orlistat क्या करेगी मुझे मालूम नहीं है. I'm not too sure. Thank you so much.
Yeah, just a minute, sir.
Bus.
Just a minute, sir, just a minute.
हाँ जी, बोलो.
I just wanted to know about the serious side effects. I don't know whether they have been talked about. Recently, we have been hearing that serious side effects like mental illness, like mental side effects with all these drugs.
Yeah, just now Dr. Biswas talked about it.
Okay.
Yes. Thank you. So from our side, it's over.
Thank you to all the chairpersons and speakers. I would request the chairperson and speakers of this session to kindly come on the side so that we can felicitate them. I would request Dr. Makkar and Dr. Paris Kangwal to kindly felicitate the speaker and chairpersons.
Thank you all for that session. And now I'd like to invite
So I welcome Dr. Sani. Sani sir is here. I think so we are running just short time, so we can have a break between two sessions, and Dr. Sani will take one, and then later on he would take the other session. So for this, I would like to invite the chairperson for that, Dr. Paras Kangwal, Dr. Mitesh, Dr. Vijay Arora, and Dr. Oli Bansal. Dr. Vijay Arora, I think, is on the way. Dr. Ajay Gupta, you can come and chair session, please. Dr. Paras. And I would like to request a moderator, Dr. Minocha, Dr. Gaurav Minocha. Is he here? Yeah. So just take on session from here.
So good afternoon, friends. So after a very active session on obesity, we move on to another exciting area, which is lipids. And lipids have evolved over the last decade or so, probably as fast as anti-obesity drugs. And we have a number of molecules now which have come up. What we are talking about is not just lower numbers, we are talking about sooner also. So it's now sooner and lower. And in the last 5 years or so, there's so much of development has taken place that ESC in 2025 brought out their new guidelines, now talking about these newer molecules and the newer targets. So to discuss the same, we have Dr. J.P.S. Sani. He'll be talking about lipid management in 2026, if I may say. And he's the chairman of Gangaram Hospital, a great academician. It's lovely to hear from him. Thank you, sir.
Thank you, Dr. Gaurav, and thanks EDPA for giving me this opportunity to give two talks. The first one is the new paradigm in lipid management, update on recent guidelines. So what I will do, with the permission of chairpersons, I may take 20 minutes. Is it okay? Yes, perfect. Okay, fine. Thank you. So I thought we will take the help of our own guideline of our country. This was the first guideline of the country. So far we had consensus statement and expert opinion by our colleagues from CSI and from LAI, but there were no guidelines because the reason was there were no data of our country. So during the COVID period, this decision was taken, and it took us almost 4 years to write this manuscript with help of 20 cardiologists all over the country, based on the data of our country. The prevalence of the lipid in our country, how we are managing our patients, statin data, the clinical trials where we have participated, the genetic factor, lifestyle, so many factors data we need to calculate from our own country to say that this is our guideline. So this was the first guideline published in Indian Heart Journal last year, in 9th April. And so question was, why there was a need of guideline? Because the best guideline in the world is ESC 2019, and everyone follows that throughout the world, including Americans. They also follow that. So I said, why there is a need for that? So one was the factor that we get disease earlier, more than 50% less than 50 years of age, and now 15% less than 40 years of age. This is 3 times more than the Western world. Second question was, why are we getting disease earlier? So another question was, are we getting the risk factors of hypertension, diabetes earlier in our country compared to the rest of the world? Answer is yes. We have metabolic syndrome, central obesity, again very high in our country compared to the Western world. In tobacco, we have chewing tobacco and BD smoking in addition to cigarette smoking, a unique risk factor of our country. Then we went into the type of lipids, that is atherogenic dyslipidemia, high TG, low HDL, and small dense LDL, again highly prevalent in our country. Finally, our own data of genetic, which we did in another country, and a good data of a large number of population of our country showed that familial hypercholesterolemia is 15% of all young MI compared to 10% globally. Lipoprotein little a, which is a very important neglected risk marker, should be done for everyone in lifetime at least once, again found to be very high in India compared to the rest of the world. And finally, what we found where we differed was our lifestyle. The sedentary habit, a good document came, 195 countries, we are from below 12th in sedentary habits of the country. Women are more than men. Regarding the dietary pattern, the cooking, unhealthy cooking is one of the important factors which came, and then came the poor study of Dr. Salim Yusuf, which clearly showed, being vegetarian, we consume a lot of carbohydrate food. The normal recommendation is 50%, we are 70%. So lifestyle factors, including high carbs and sweets, that all led to atherogenic dyslipidemia, central obesity, along with epigenetic and genetic factors. So that was the reason why we needed our own guideline. So Dr. V. Mohan helped me while preparing this document. He published a beautiful article on ICMR India Study 17, looking at all the risk factors in the country in 113,000 population. Hypertension in 35% of population, diabetes 11.5%, pre-diabetic 15%, and look at dyslipidemia, 81%. Mainly driven by high TG, low HDL, and small dense LDL cholesterol. If you look at our country's data of high cholesterol and LDL cholesterol, it is there in above 100 milligram of LDL, which we say is a cutoff for normal now, is 50% of the population, both in men and women, not much of difference. But there was an interstate and inter-regional variability, also to some extent between rural and urban area. But surprisingly, this was the story of atherogenic dyslipidemia. Whole country is red. High TG, low HDL, small dense LDL, present in 55% of patients in the country. And there is no interstate or inter-regional variability, even much less variability between urban and rural area. So this was the prevalence which was given by Dr. Mohan and team, and that has waken up that this is the prevalence of dyslipidemia in the country. Now coming to the management strategy of the population, how to manage them, since we did not have our own risk calculator, all the foreign risk calculator like Framingham Heart Study, Frisk and everything have underscored because their risk starts above 40 years and we have 15% of us below 40 years. So that's why we could not take the advantage of any of the risk score. So unfortunately, we do not have risk score as of today now. We have to work on that. So in the absence of that, we used only the risk factors. Now here, this table is nothing but ESC 2019. We made certain areas, certain differences. We said LDL cholesterol is important, but non-HDL should not be ignored because high TG means the remnant cholesterol present in triglyceride is there. So you have to calculate both to give an actual risk factor to the patient. Extremely high risk population is the one, those who get recurrent coronary artery events within 2 years. And what we found while preparing our manuscript in another interesting patients group, this was a few center study, we showed that young heart attack patient, less than 50 years, 50% of them they are there. They have 15% of them they have FH, and those who have got FH, 50% of them have got high LPA. So two genetic risk factors in a young MI patient led to recurrent coronary artery events very high. And we suggested this extremely risk population should keep it below 40 based on the Odyssey trial, or keep it even below 30 based on the Fourier trial of the PCSK9 inhibitor. Very high risk population, we did not differ between ESC. All atherosclerotic cardiovascular disease, FH with CAD, diabetic more than 20 years with target organ damage, CT angiogram showing more than 2 vessel 50% block, keep it below 55. Based on, this magic number came 55 based on the Improve It trial, which was on ezetimibe with statin. And high risk population, again we did not largely differ, but we added one more factor which was now accepted by ESC also, that every diabetic or every hypertensive patient, if they have additional one risk factor, and which was the central obesity, family history, tobacco, hypertension, or diabetic, then keep the LDL below 70. And in practicality, it looks like that every diabetic and hypertensive patient, if they do not have atherosclerotic cardiovascular disease, keep it below 70. And that means most of them will be requiring statin drug. And the commonest risk factor was central obesity. Low risk population, we differed. They say 115, we say 100, based on the expert opinion only. And then came the how to manage acute coronary syndrome population in our country. The pathetic situation was that all the even tertiary hospital of the country, topmost hospital of the country, the discharge slip of acute coronary syndrome has got all investigation except lipid profile. That is a pathetic situation which we found. So what we suggested, non-fasting lipid profile should be done the moment patient enters into any hospital for ACS. Non-fasting should be done, and hit hard and hit early is the way to go for, because we have to stabilize the plaque in 8 to 12 weeks. Otherwise, there will be recurrent coronary events which will happen in 10% of ACS population. And for that, what we suggested, high dose of statin, 40 Rosuva or 80 Atorva, along with ezetimibe, as a combination, rather than giving only one drug, should be given to all the patients and get the next lipid profile not at 6 weeks or 8 weeks, at 4 weeks. And this is based on our data of our country. So do that, and if you are not reaching below 55, then add bempedoic, or we can straightaway now shift the inclisiran or the evlucamab injection to bringing it down below 55 as soon as possible. So why we started on high dose of combination? Because this was a study which was done in 200 patients from Gangaram, 200 patients from the Kerala, and clearly shown those who have got LDL around 100, 110 and above in baseline, if you give only high dose of statin, you are able to reach the goal only 60%. But if you give combination, then also you can reach only 80%, not 100%. Probably you will be needing much more drug. And why 4 weeks? We did a study again in the country in few hundred patients only, but that is the data we could able to generate during COVID period. We did lipid profile at day 0, 17, 14, 28, and 42. And what we found, the maximum effect of statin comes at 4 weeks. Beyond 4 weeks, there is no further reduction of LDL cholesterol. By 15 days, 70% of the LDL reduction comes with the high dose of statin. So that's why we have chosen that we should go for the 4 weeks as the second. And thirdly, the problem came that when we look into the data of our country, majority of the patients, they start with high dose of statin. Down the line, they reduce the dose of statin. So how to answer that question? So there was a lot of debate among us at that time that we can allow them to do that, but people did not agree. So we said we allow only 2 areas where you can downgrade or de-escalate the dose. One, if a patient gets statin-associated symptoms. Number 2, being atherogenic dyslipidemia, if there is a rising trend of HbA1c on day 0 and at 8 weeks or 12 weeks, that means you are prone to develop new onset of diabetes because of high dose of statin. You can down titrate the dose, but don't forget to get another lipid profile after 4 weeks. If it goes above 55, add bempedoic acid, which do not affect sugar. This was the only guideline which has given for the first time stable coronary artery disease management. Here we are not in hurry because annual rate is only 2 to 3%. So we have started with the lower part of the high dose of statin, 20 Rosuva, along with 40 Atorva, but added ezetimibe here also. Because we say that if you increase the dose to double, then the chances of reduction is only 8%. If you add ezetimibe, you reduce LDL by 15%. At the same time, new onset of diabetes is less and myalgia is also less. So reach the goal early and safely. So that's what we thought we should do. The unfortunate again problem was that like the Davansi study of Europe, our own studies what we found that those patients, those who are on statin after 1 year, only 20% patients are at goal of less than 55. We have our own study of Gangaram Hospital, myself and Dr. Mehta. We did on 3,800 patients and started looking what is the reason for that. Was it a side effect of the drug? Or was it the cost of the drug? Or it is the media which played a role, no doubt in that. But you know the universal answer came from patient that it is their doctor who reduced the dose. And this is called the physician's inertia. Unfortunate. And most of those patients, those who are already reduced the dose to 20 or 10, they all had LDL above 55, and some of them got recurrent coronary events. So putting a stent is a good move, but managing after stenting is important. Non-fasting lipid profile is a way to go. We have got enough of evidence for large number of clinical trials. Every guideline has accepted now that it does not make much of a difference. Triglyceride increased by 25 to 30 milligram. Early morning rush of the patient is taken care of. But if you're looking at non-HDL, the total cholesterol minus HDL, again, it is not changed by diet. It's very easy to do. You don't need even direct LDL estimation for those population. So this is the way to go for most of the patient, except patient who has got a very high triglyceride, who is suffering from a very high triglyceride or familial chylomicron syndrome. Now the second question was, shall we treat high triglyceride? We have been labeling LDL as one of the important markers. And we have now a good data from the Copenhagen study and from global American study also, in our own country, small data, which shows that even if your LDL is below 55, a quarter of the patient have high triglyceride. And in Indian data, our data show not for quarter, it is 40% have got triglyceride high. So, and we have data to show that if your triglyceride goes up to 450, there is an increase in cardiovascular event because this triglyceride contains remnant cholesterol. So that is additional to the LDL cholesterol. So this is what we say, if your TG is above 150, look at non-HDL cholesterol. Total cholesterol minus HDL cholesterol, it is 30 milligram more than the LDL cholesterol. Remnant cholesterol means VLDL cholesterol, IDL cholesterol, small chylomicron, which is present in the triglyceride. And we have also good evidence to show that the remnant cholesterol in TG is much more dangerous than LDL cholesterol. Because the triglyceride moiety has got two parts. A blue part, which is VLDL triglyceride, which do not part in atherosclerosis. But the yellow part is the VLDL cholesterol, which is what we said, remnant cholesterol. It causes atherosclerosis, and it causes directly, whereas LDL has to be oxidized to cause the atheroma formation. So this is dangerous. So this is our algorithm. We said, in the society, if a patient comes to you in clinic with high TG of 200, 250, 300, and is not a diabetic, and he is not a patient of atherosclerotic cardiovascular disease, don't treat him. Don't give him any medical treatment. Lifestyle modification is good enough. One of the best medical management is lifestyle, like exercise, reducing smoke, reducing carbohydrate diet, weight is good enough. But if a patient is diabetic and suffering from atherosclerotic cardiovascular disease, and his diabetes is controlled, one of the best methods to reduce triglyceride is to control diabetes, control hypothyroidism. If you control that, and then also your triglyceride levels are high, that means this is remnant cholesterol. If the level is between 150 to 499, then you have to treat the remnant cholesterol to prevent atherosclerosis. There is no role of fenofibrate. Absolutely zero role of fenofibrate at this stage. Remember that. This is very unfortunate, one of the commonest medical errors in clinical practice. So what we use is statin or use ezetimibe or bempedoic acid. If your non-HDL cholesterol is still not controlled, it is not going below 85, then add the fish oil, and not the total fish oil, the only icosapent ethyl, that is EPA part of the fish oil. Fish oil has got two parts, EPA and DHA. The children, for their affection, they send their parents fish oil over-the-counter jars, which are of no value for cardiovascular disease protection, because it contains DHA also, which is a pro-inflammatory. So use EPA. But if your triglyceride is above 500, 1000 or 2000, then we are not worried about heart attack. We are worried about pancreatitis. This is the third commonest cause of pancreatitis after alcohol and gallstone. And here, there is a great role of our favorite drug, fenofibrate. You should use it, but use it alone at that time. Bring it below 500, recheck your lipid. If the LDL is high or non-HDL is high, then add statin to that population. And another drug which we can use in our country, which we put it in our guideline, is a saraglutazole. Because that is a drug, it does not have a hard endpoint data, but it shows that in a diabetic patient whose sugar is controlled, his TG is high, you can use saroglitazone. The second group is the one is TG is high and patient has got MAFLD or NAFLD, what we say SGLT2 is high, fatty liver, you can use saroglitazone. But there are a number of patients in our practice, those who got very high triglyceride. In spite of all the measures what we have taken, the levels are high. Then we have got injection volnacerone and plat3 evenocamac. Genetic dyslipidemia, I'll go a little fast in next 2, 3, 4 minutes. The familial hypercholesterolemia and lipoprotein. Familial is the one which Dr. Goldstein and Brown got Nobel Prize in 40 years ago. They identified the LDL receptors and found this disease comes in 3rd or 4th decades. Grossly underdiagnosed, undertreated in the country. And the Dutch Lipid Clinical Network criteria is a way to go for that. Is a scoring system. The gold standard is genetic test, but that is not possible. So young heart attack, you get 2 score, family history, you get 1 score, LDL, you get score of 1, 3 or 5, depending upon the LDL. But the ARC, never forget to lift the upper eyelid of the patient and look for the ARCUS. And that ARCUS, it gives you 4 points. So that is very, very important. There are many patients, those who are already on statin. So what to do? We have a correction factor available now for each statin in each dose. Like I had a patient who had got on atorva 20 milligrams LDL 110. So what is his statin naive population? You have to multiply with 1.8, which comes to 198, score becomes 3. So we'll go into more detail, but remember in FH, the treatment is not complete if you have done a cascade screening. The cascade screening is nothing but the lipid profile of a children and brother and sister. So by diagnosing a case of FH, we do not identify a case, but a family at risk. And this is our own data, 1,400 patients, 15% of the patients in the country have got familial hypercholesterolemia. One more learning is that we started looking into the risk factors, and what we found, any young heart attack patient comes to you, if he has got no diabetes, no smoking, but his cholesterol is above 100, 120 or 30, think he is FH, because there is no other risk factor. And this is the algorithm that every patient of FH should be put on maximum doses to reduce the LDL below 55 if he has got CAD. Treatment is not complete. If you have done a cascade screening of brother and sister and children, pick up the carrier and try to treat them. I've got the youngest child, 4 years and 3 months old, he's on statin now. 14 children are elevated LA above 50 milligram is very highly prevalent in our country compared to the rest of the world. And what we found, those who have got very high LPA, they have got increased myocardial infarction, aortic valve disease, stroke, and the cardiovascular mortality. Our own data, which is now becoming 1,500 patients, shows that in 1,500 patient data is now available. LPA above 50 milligram is seen more in young heart attack compared to elderly, and it is directly related to severity of disease. And in FH population, it is 45% of patients, those who got LPA. Unfortunately, there is no treatment at the moment for that. PCSK9 inhibitor, inclusion reduced by around 20 to 25%, but we have a drug coming up called pelacarsen in Horizon trial next year, which will give us, reduce the LPA by 80% to give you a meaningful reduction of cardiovascular event. Dietary, I will not go into this. Our data is very clearly that sugar causes more heart attack than saturated fat. If you take small quantity in a general population, if you take small quantity of ghee, butter, or mutton, it will not kill you much. If you take sweets, it causes much more heart attacks to that. That you can go through our paper, which is there. This lipidemia in young, we said 18 years is the age we should get first lipid profile. And the last part, the last sentence, last slide I'm showing, this is an interesting finding, what we found while preparing our document. In fact, we have got this booklet available now. I think Mankind will be able to give it to all the delegates. This is the important finding. A non-uniform laboratory reporting of LDL has resulted a significant number of cardiovascular deaths in our country. Because we have got 8 lakh laboratory, 2,500 unfortunately accredited, and we found the range from 70 to 140, 80 to 130 or something like that. So what we did in Gangaram Hospital, we made a special lipid profile protocol and have sent to all the laboratories in the country. Those should have a level that less than 100 is normal for general population. Then we have written, look for your estimated risk and goals. So we have given which is high risk, very high risk, and accordingly we have suggested goal. Like this patient of mine who has gone PCI, he was very happy with his LDL 90. And he never came to me, he said, Doctor, मेरा तो LDL normal 90 है, 100 आपने लिखा हुआ है. मैं कहा नीचे नहीं पढ़ा आपने क्या लिखा है. तो वहाँ मेरा रिस्क देखा तो आप तो बड़े वेरी हाई रिस्क में है. वेरी हाई रिस्क का LDL क्या है 55. तो this patient got heart attack again. This 50% lesion becomes. So that is the challenges which we saw. So finally, to conclude, dear friends, that we have tried to incorporate everything, but the document you have to read, it is available online now, and this is specific for Indian population, not much different from European guideline, but there are certain areas. We still believe that we should reduce cholesterol as early as possible and keep it low according to the risk profile of the patient, and always keep it low for longer period of life. Then it will be. And what we added was together the better. That means not only give statin, but give ezetimibe to reach the goal as early for every patient of secondary prevention and for diabetic primary prevention. Although this consensus guideline cannot replace the individual judgment, who remains the sole arbitrator of the patient's management. So thank you very much to all my colleagues, those who have participated. I'm sorry for taking...
I think an excellent session by Dr. Sani sir. So to conclude, LDL is fire and statin is not the only fire extinguisher, right? And LDL below 55, if you bring it below 55, you get to the new 55. So that should be the target. Dr. Manoj.
Yeah, so thank you, Dr. Sani, for a very enlightening talk. I think a lot of questions still remain. This very short time that we gave him, 20 minutes. It could have carried on for another 20 and maybe half an hour. The question is about the newer drugs that we have will now or have already arrived, like the inclisiran and the PCSK9. What do you think in the real practice? I mean, how many, what proportion of your patients would require after the triple therapy? I mean, first question would be, how many patients you would think you would at the outset start the triple therapy with the statin and bempedoic and ezetimibe?
Yeah, so you see what the guideline we suggested, start with 2 drugs. And now we are going to update our guideline further next year. When we said in second stage, when we want bempedoic acid, you can straightway have inclisiran. Okay. Or even the Repatha, whatever.
So first bempedoic, then ezetimibe.
Then okay. This is one. And what we say that between inclisiran and evolocumab, we prefer inclisiran because of the compliance. It's only 2 injections a year versus 26 injections of the evolocumab. Number second, a sustained reduction of LDL cholesterol with inclisiran, whereas it is a fluctuation with the Repatha. So number third, it is almost becoming 1/3 of the cost to that of the... So that all 3 factors makes the inclisiran much important drug to be used. But don't forget to look for non-HDL cholesterol levels. That is what I want to make a big message, because our country has atherogenic dyslipidemia. If we just look at LDL alone, then you will make mistake. Disease can progress. So you have to look for non-HDL cholesterol and try to use and reduce as much as possible fenofibrate in practice.
Right. So the learning that we want to take from you, because you probably would be using a lot of inclisiran, and we would want to learn from you is, what proportion of patients would require inclisiran, and what is the response like?
That's right. You see, also depends upon the baseline LDL. Like if a patient is FH, cholesterol is very high, 200, LDL is 250, 260. Invariably, most of them will be requiring inclisiran.
Right.
Now, the other group of patient is the one, those who are statin intolerant.
Right.
They are unable to tolerate or partially intolerant, statin intolerant population. Again, the use of inclisiran high. So if you ask me, my gut feeling is around 10% of the population will be requiring injectable drugs, which were not able to afford by the cost of the drug, but now the newer drugs are helping us to help with that.
Yeah, but in the intolerant patients, probably we would start with bempedoic and ezetimibe, try that, and then probably go on to inclisiran.
Yes, we can, if they have very high baseline LDL cholesterol, or those who come with the recurrent coronary event in spite of on statin and ezetimibe, then even on the admission we give inclisiran or Repatha. We can give one of those drugs.
Right. So going on from like the secondary prevention to another very important question would be primary prevention. So diabetics, we all now believe and have seen and is proven they are CAD equivalents. And for long it has been recommended, somehow not been followed, that diabetics should be started, all diabetics beyond 40 years should be started on statins. That somehow we don't see in the practice. What is your take on that?
I think I agree. That's what I've shown in my slide also, the risk factor, that most of the diabetic, even I will say no hypertensive, probably will be going in that direction. And in diabetic population, what we have learned after the improved trial, that alone statin may not be good. You have to add ezetimibe also. If you do combination drug, then you reach the goal early and safely. And
Right.
you are attacking multiple pathways. Just like hypertension and diabetes, we are attacking multiple pathways. Similarly, for lipid has to be multiple pathways.
So a combination therapy probably
Is
will be
always
good
better.
because probably patient will be more compliant. We have a lot of vitamin deficiencies and a lot of patients have these muscle aches and pains,
Yeah.
and probably it should be good to start with the combination
dose will be less.
therapy.
Yeah.
In this reference, another question probably would be like, risk enhancers. So people, as you said, only hypertension, and borderline, LDL levels, and a hypertension of more than 10 years. Would a CT CAL score or a carotid ultrasound add on some information for you to start a statin? Because otherwise, you would not be able to start a
So
statin.
what we missed in our last guideline were 2 or 3 important points. One is we started the LPA was not added.
Okay.
If the LPA is above 50, like for example, 2 patients have LDL 100 and 100. One whose LPA is normal and the other one whose LPA is high. If LPA is high, this 100 will behave like 130.
Right.
This is risk enhancer, number one. Number two, calcium score.
Right.
So calcium score has got a great advantage that if a patient, many times they come to you, Dr. Saab, मेरे को blood pressure है, I'm a smoker, मेरी artery block हो गई है कि मैं एंजियो नहीं करानी, something
बिल्कुल,
like that.
right.
Even CT एंजियो नहीं करानी.
Right.
मैं कहा कोई बात नहीं, calcium करा लो. तो calcium से, if the calcium score comes positive, any number, 10, 20, 30, 40, that means atherosclerosis has set in.
Right.
We have to put him on statin. But there is a problem, there is a caveat to that young population less than 40, sometimes calcium score alone may not be,
May not be
10% time we miss that
Right.
soft plaque.
Right.
That's why history of the patient is most important.
Right.
If the history is classical of angina, even calcium score is 0, I will ask for angio or at least CT angio.
Right.
And we have seen many patients like that. This
Right.
happens. And the third factor in women has been now the premature menopause.
Right.
And complication during pregnancy of
That is common as a
preeclampsia.
big risk
so
factor
these
now.
are risk enhancers.
Right.
The rheumatoid arthritis, the SLE, again
Even
a risk
HIV,
enhancer.
they say less than.
So in
yeah.
this we want to add in next our update of the guidelines.
Right, right.
So
So,
we
any
start with
chronic inflammatory diseases,
Yeah.
actually they should be considered as risk enhancers.
Yeah.
And idea is to probably use any behalf to add statin to protect the patients. So as I said, calcium score is a way to diagnose atherosclerosis. I use a lot of carotid ultrasound. So I have that obviously a way because I have an echo machine. I can use a, and I find that a lot of patients where actually there may not be an indication to start statin. If I just put a probe, I do use a screening carotid. I find out 30-40% patients I start because of the carotid ultrasound. So that's
Although
a very
the calcium score become easier,
Yeah.
just take 1 minute. Just lie down, it goes up and within up
no,
you're
but
up and
the patient
you know
obviously has
that
to
this
go
thing-
there and pay some money for
And
that.
it is now
Any
becoming affordable.
questions that the audience may have?
Dr. Sani, one big problem we face is pregnant women with very high cholesterol and very high TG. 300 cholesterol, 1500 TG. How do we manage during
That's
the
right.
pregnancy?
So very good question. During pregnancy, the statin is generally recommended as contraindicated. But recently, FDA and guideline has changed.
Right.
And they say if a young woman is suffering from atherosclerotic cardiovascular, because I have got 2 patients recently, within 6 months, they had heart attack, stented, and then they got pregnancy. So this is the area, one area. The second was familial hypercholesterolemia, very high LDL cholesterol. In these 2 situations, they have suggested you can give statin to this population during pregnancy. During pregnancy. They say you may avoid in first trimester, but some of the studies say no, you can go ahead with the statin. So these 2 conditions we can give statin to women. Although the best drug to reduce cholesterol is the bile acid sequestrant, but they are not better tolerated by women because they get vomitings and the vitamins are not getting absorbed from that. So that becomes a challenge for us. But ezetimibe, bempedoic acid, strict no.
Thank you, Dr. Sani. I have one question here, sir. सर LDL तो हमने आपसे घटाना सीख लिया, सर HDL बढ़ाने की तरकीब बता दो।
HDL बढ़ाने की तरकीब तो पता है, जैसे हम कहते थे एक्सरसाइज करिए, थोड़ी वाइन पीजिए, थोड़ा काजू किशमिश अखरोट खाइए, और कुछ दवाइयाँ भी यूज़ हुई during last 10-15 years, but all those medicines failed particularly anacetrapib group of drug. They say they increase the HDL, but they increase mortality. It was no beneficial. So now they say HDL को भी बरी रखो, नीचे रखो, कुछ देखो मत उसके लिए. HDL की जगह में non-HDL को देखो. That is more important because उसमें remnant cholesterol है. So the HDL की problem है कि the qualitative versus quantitative HDL makes a difference. So the answer is still not there. So at the moment guidelines are silent about HDL, but they are really looking for non-HDL, which we miss many times in clinical practice. I have many patients now whose LDL was 40-45, yet the disease progressed. And when I look back into the lipid profile of this patient, I made a mistake. Their TG was 240, 230, 260, and non-HDL instead of 85 was 100, 110. And the RCA, which was 40%, in progress to 90%, in spite of LDL being at 44. So that shows the non-HDL cholesterol has to be seen and should be treated by statin and non-statin drug. If not possible, then icosapent, which is now available as fish oil of EPA, 1 gram twice a day.
Sir, in all the algorithms that you mentioned, we talked about LDL-C, focusing very much on that. What about lipoprotein levels, which are being assessed nowadays?
That's what I said. The LPA, the lipoprotein little a, is a very, very strong risk factor for cardiovascular disease, which I've shown you. Unfortunately, there is no treatment at the moment, and we are waiting for pelacarsen. PCSK9 reduces by 20% only at the moment, but it enhances the risk. I've got a boy, 28-year-old, 145 LDL. He's asking, shall I start statin? I've got nothing. I said, get your LPA. When he found his LPA 142, I can start statin. And my youngest patient, who is the 4-year-old child, who is on statin. So they have to be, because they are the children of FH carrier.
So thank you, sir. Thank you so much for your practical solutions. And I think we give him a big standing ovation response. So thank you, sir. So we move on to the next session after this. I invite the organizers for the...
Swati, over to you.
We move on to the next session, and Dr. Himanshu Sharma is running over to the stage. Welcome. Dr. Himanshu is the moderator for the next session. The gold standard, semaglutide leads the way in weight management and beyond. And I would request the chairpersons and speaker of the previous session to kindly come to my left-hand side so that they may be felicitated.
I would like to invite our eminent chairpersons for this session, Dr. Rajiv Lochan, sir, Dr. Amit Chhabra, sir, Dr. Rajesh Kesri, sir, and Dr. Deepti Gujral, ma'am. And I would also like to invite our esteemed speaker, Dr. Muddar Tripadia. Pranam, boss.
Ladies and gentlemen, my pleasure to invite Dr. Mugdha Tapadia for this talk. I think her credential written in front of you. I need not waste my time and your time. I would directly ask her to start with the talk.
Thank you, sir. So we have heard a lot about obesity this morning, tirzepatide, and now I'm going to talk about semaglutide today. This is a way forward in weight management and beyond. Novo Nordisk has asked me to present, and this is a financial declaration. So obesity, we have all heard, it is a prevalent, complex, progressive, relapsing chronic disease, which has abnormal fat deposition that impairs health. Almost 1 billion people in the world are affected by obesity. Dominantly, we see that they are adults, but children and adults are also obese. And the paradox is that, as we have discussed earlier, there are patients in the double burden where in the low and the middle income countries, there is malnutrition and obesity both. Coming to India, almost 254 million people are affected by obesity and 351 million live with abdominal obesity. And we all know it has multiple complications. We know that there are 230 plus complications of obesity, and you can see the strength of evidence for these complications are given in colored pattern in this diagram, where we see the large, like hypertension and diabetes are the large circles. That is the higher number of association seen with these diseases. And we can see that there are a lot of complications, and each and every organ of the body is affected with obesity. So obesity affects every organ. Now I'd like to have your attention to this slide. This is a very important slide when we are talking about weight loss. When we talk about weight loss, what % of weight loss is our target and what are we going to achieve out of it? So 5% of weight loss will give you improved insulin sensitivity, triglyceride, liver triglyceride, beta cell function, muscle insulin sensitivity, abdominal adipose tissue decrease, and adipose insulin sensitivity. There are 3 things where even the 5% weight loss will be, with 5% of weight loss, things are going to get better, like liver insulin sensitivity, adipose insulin sensitivity, and inflammatory markers. And they will remain stable even if the weight loss is more. But there are certain things with progressive weight loss, you will see more improvement, like in lipid triglyceride, beta cell function, muscle insulin sensitivity, gene expression of subcutaneous adipose tissue, and abdominal adipose tissue. So when we started talking about weight loss and how the obesity leads to so many complications, what were the ways to decrease weight? So again, the standard and still remains the adjunct to these medicines, the physical activity, nutritional medical therapy, and psychological interventions like CBT. But they were able to achieve only 3 to 5% of weight loss. In few dedicated people, even the more weight loss, but most of it 3 to 5% of weight loss. And at the other end of the spectrum, there was endoscopic procedures and bariatric surgeries, which were able to achieve 25 to 35% of weight loss. But in between, there was this gap, which is filled up with the pharmacotherapy, or with for the people who have had significant obesity, but do not want to undergo any endoscopic procedure or bariatric surgery. These are the people who can be prescribed this pharmacotherapy. We all know that Wegovy or GLP-1 RA works in 2 areas of our brains, the activation of the hypothalamus and the hindbrain. Semaglutide has homology of around 95% to the GLP-1 analog, and half-life is around 1 week. And it also activates the hemostatic regulation and increases satiety and making your patient feel full earlier. And the hedonic regulation, where they reduces food cravings, especially to the certain types of food. So what we have seen is that weight loss benefits with Wegovy was that more than 20% weight loss in 1 in 3 patients, weight loss starting as early as 4 weeks, and this weight loss sustained for 4 years with Wegovy continuing. So there were various step trials which were conducted, and here we found that more than 20% weight loss in 1 out of every 3 participants on Wegovy, and the figure just came out from US that 1 in 10 individuals in US are on these GLP-1 analogs or these weight reducing medicines. And you see here in this chart, there almost average of 40% of people who lost more than 20% of weight with the Wegovy. So what improved along with the weight loss was the lean body proposition. So there was decrease of fat mass proportion in 4% by 4% and lean body mass proportion by 3.5%, and this is what is at week 78, and this is a good feature. So there was this Simalin trial where 106 patients were studied, and they were given, they were monitored by their body composition analysis, by the DEXA scan, and what they found was there was improvement in hand grip strength with Wegovy, and the muscle strength increased. They were evaluated at baseline at month 7 and month 12. The other part that was seen with this trial was there was improvement in muscle mass, there was decrease in muscle mass at month 7, but from month 7 to month 12, there was slight increase in muscle mass. Why this happened and how this hand grip strength increased, there are various postulates to it. And one of the important postulate is that with the muscle mass, with the loss of weight, there is also loss of fat inside the muscle. And when there is a fat loss inside the muscle, which probably has led to this muscle strength with Wegovy. Along with that, there have been decrease in waist circumference, decrease in CRP, that means the decrease in inflammation. The systolic and the diastolic blood pressure reduced, and there was improvement in triglyceride levels as well. Talking about HbA1c, there was significant reduction of around closer to 2% at week 68, and mean HbA1c at 68 weeks was around 6.2%. So there was another step 10 trial which was done in pre-diabetes patient, and here it has been observed that more than 8 out of 10 with pre-diabetes reversed to normal glycemia in patients who were overweight or obese. So Wegovy in patient with obesity and cardiovascular disease, it has been seen by the SELECT trial that there was 20% MACE reduction with Wegovy. And we see the early separation of the graph as early as 4 to 6 weeks. And because of this trial, the European Society of Cardiology has introduced semaglutide in the guidelines in patients with overweight and obesity without diabetes with chronic coronary syndromes to reduce the CV mortality, MI or stroke. So in SELECT-2 trial, there was also seen the relative risk reduction of 20% in 3P MACE. And the extended NNT, the number needed to treat, again there was a reduction in 20% relative risk reduction. And in the CKM, that means cardiac, kidney, metabolic disease, there was 41% of relative risk reduction, which really significantly improved the outcome in these patients. So Wegovy reduced the MACE, as I told you, there was early separation and soon after randomization. And what we saw was that first statistically significant MACE reduction was seen with semaglutide 2.4 milligram versus placebo. It is as early as 20 days after the randomization. And at day 86 after the randomization, first sustained statistically significant difference in MACE reduction was seen with semaglutide 2.4 milligram. So first, the patient was started and gradually increased to the dose when the patient reached 2.4 milligram. We are talking about after patient reached 2.4 milligram, that is when this reduction was seen. So cardiovascular outcome, then there was this real world studies conducted, and here there was a SCORE study and the STEER study. This was after they were in the market. So this were retrospective longitudinal observational cohort study. The data source was the database, the Komodo research database. And in select-like population, like patient who had the BMI of more than 27, more than 45 years of age, had history of MI, stroke or peripheral artery disease without any history of diabetes. Here, this was compared with semaglutide versus non-SEMA users. There was another study called a STEER study. Again, this is real world study. Same, the data source was Komodo Research Database. Here the patient again was the select-like population. Similarly, here the patients were compared in semaglutide versus tirzepatide group. What they found was that there was 57% reduction in 3-point MACE in patients where they were compared with semaglutide versus non-semaglutide users, and 57% reduction in 3P MACE when it was compared with tirzepatide. Again, I have to tell you, this is a real world data. We have taken the major inclusion criteria, but there were no exclusion criteria. And again, it is not in a this is in a non-standardized form. This is a real world data. Wegovine patients with kidney disease, it was seen that 22% risk reduction at a composite kidney endpoint with semaglutide. This was what was the composite endpoint? Onset of 50% or equal reduction in eGFR compared to the baseline. Onset of persistent eGFR less than 15 ml per minute per 1.73 meters square. Initiation of chronic renal replacement therapy in the form of dialysis or kidney transplant, renal death or CV death. So in these patients, it was seen that first composite endpoint was achieved after, say, 20 weeks, started to achieve at 20 weeks or so. Before that, there was overlapping effect. And again, why? This is because the effect was seen with the higher dosages of semaglutide of 1.7 milligram or 2.4 milligram. So, safety amongst the STEP trial that we see that it is well tolerated. The discontinuation rate because of the adverse event is 4.3%. And GI side effects are the most common side effect. Observed rate of hypoglycemia were 6.2% versus 2.5%. That was in placebo group. Cholelithiasis was reported in 1.6% patients receiving semaglutide 2.4 milligram versus 1.1 milligram who were receiving placebo. Very few events of pancreatitis, 0.2 versus 0.1% in placebo. No increased risk of malignancy or neoplasms. No increased risk of diabetic or any retinopathy in patient with obesity without type 2 diabetes, and there was no increased risk of CV events. So semaglutide has a unique thing that it has been studied because of course it has an added advantage of it being launched earlier. It has been studied in 60,000 patients across STEP, Sustain and Pioneer clinical trial program, and it has exposure to around 38 million people worldwide, which is a huge number. Because it has started, the trial started and was available in market this since 2018. Again, it has to be started at the dose of 0.25 milligram, and every 4 weeks the dose has to be increased, and we have to see the response and see the tolerability of this drug. And 0.5, 1.7 and 2.5 milligram is the maximum dose. So if you start with 0.25 milligram, you can reach at 17 weeks, you can reach the maximum dose of 2.4 milligram. So in conclusion, I would say that Wegovy has provided substantial and clinically meaningful mean weight loss of around 20% in 1 in 3 adults with overweight or obesity. It is the only anti-obesity medication with proven CV benefits, and semaglutide has been studied in large number of population in various clinical trials. Thank you.
Hello. If there is any query and questions from the house, we can take few questions. Yes, sir. Dr. Nakra.
We have noticed in the earlier talks that there is incidence of optic neuritis in certain cases of a patient on semaglutide. And I don't know whether it is related or not, but I have a patient whom I started tirzepatide, and for 4 months she has taken for knee replacement surgery, to reduce weight for knee replacement surgery. Then she has landed with acute psychosis. She is still admitted with us. She has come with acute psychosis. What is your take on that?
Sir, in the clinical trials or the large number of patients which have been put on the semaglutide, acute psychosis has not been reported yet. But if this becomes an index case, then we should be reporting it. Yes, we see depression, and as Dr. Vishwas was saying, that we have to take PHQ, we have to do that pro forma and see if the patient is in depression and take a psychological help before starting this drug. But if this is a psychosis, I would definitely request you to report this, sir. Yeah.
Thank you. Just one summarizing point from each of our chairpersons. Anything you would like to add, sir?
See, we've been continuously talking about weight loss, maintaining weight. I will not talk anything scientific. I'll just talk something very non-scientific, basic. See, I have passed through 3 stages of life. बचपन गांव में बीता, जहाँ दिन भर खेतों में हांडते रहते थे. हांडते का मतलब समझते हैं? वो दौड़ते रहते थे. उसके बाद थोड़ा जीवन छोटे शहर में बीता, जहाँ स्कूल जाने के लिए हम 3-4 किलोमीटर जाया करते थे पैदल. 3 हॉकी के प्लेग्राउंड्स होते थे. उसके बाद दिल्ली में आ गए, जहाँ 500 मीटर पे स्कूल था, बस से जाते हैं. जहाँ जिम जाने के लिए कार से जाते हैं. दिस इज वेट लॉस, मेंटेनिंग वेट. You maintain weight, we don't talk of weight loss. Start from childhood, don't let them, look at me, I'm 77. No disease, all basic joints जो भगवान दिया सब वही के वही हैं. I have not changed my lifestyle. I have not changed my lifestyle. So what I would say is, medicines are now coming, definitely important, but if we can go back and maintain our lifestyle, even the best of lipidologist has a punch. Sorry, sir. So we have to go back to lifestyle.
Just in a similar note, I would like to make one note here that, you know, the doctor himself or herself is also very important. The doctor himself should be a motivation for the patient to lose weight. This is my personal journey. I lost weight with lifestyle. But what I'm surprised is that it is obviously to my benefit, but my patients have benefited more. Patients who I've been treating since more than 10 years, they hadn't lost a single kg. After seeing me, they said, Doctor, aapne kya kiya, hum bhi karenge. And they have been so motivated that they have lost weight. A patient who's more than 100 kg lost in past 1 month 4 kg. And there are many such patients who, while going out, they ask, Doctor, aapne kya kiya? So I think the doctor himself, herself should be a great motivation for the patient. कि पेशेंट डॉक्टर को देख के बोले भाई मुझे भी ये करना है जो डॉक्टर साहब ने किया है, and I also have to be like that.
And anti-obesity medications are not a replacement of lifestyle modification. It is to be on the top of that. If the patient is not able to reduce weight or manage, even with the lifestyle, we offer them. And but not everyone that we will take injection and then we will lose weight. It happens, most of the patients come to us that we want to reduce 3, 4, 5 kg only without doing anything. So it is to be on the top of lifestyle modification. Thank you.
Thank you. We'll close the session because of paucity of time. Thank you all for the wonderful session.
Moving on to the next session, we have a wonderful session on a new molecule, Finrinon, in HFpEF. We know there are very limited drugs in HFpEF. So the chairpersons for this session, I would like to invite Dr. Anil Mota, Senior Consultant Physician, Max Hospital. Dr. Anil Mota, please. Dr. Sanjay Mahajan, Senior Consultant Physician, Kailash Hospital. Dr. Naresh Dang, Senior Consultant Physician, Max Hospital. Dr. Naresh Dang, sir. And Dr. Ajay Mittal, we all know him, very senior consultant, one of the most senior member of EDPA, senior consultant in Deepak Kailash Hospital, senior cardiologist. So I would request the chairpersons. Dr. Dang is there, yeah, please. So I request the chairpersons to start the proceedings and introduce the topic and start the proceedings. We are really, running late.
I think now the Finerenone is available and it is a miracle drug for diabetes, CKD, and now it has been approved for heart failure with preserved ejection fraction. And Dr. Sani is, I think we can learn what he is going to speak in about for another 20 minutes. Question after that.
Thank you. Thank you. Thank you very much, Dr. Ajay and dear friends, once again. So what we are going to discuss about the Finerenone, how to use this drug in clinical practice. This is a MRA, mineralocorticoid receptor antagonist. We have been using spironolactone and allopurinol for HepRef and also for resistant hypertension. But this is a new drug which has come, and let's see how it works, how it is different from other MRAs. So let me give you an example of one case, 8-year-old woman. She was diagnosed as HepF with CKD. She doesn't have diabetes, blood pressure is fairly well controlled, but she complains of a lot of breathlessness. And she is on SGLT2 inhibitor, RAS blocker, and diuretics for the standard of care for HepF population. And she was hospitalized for breathlessness. So this type of patients are not that uncommon what we see in clinical practice. What we have also learned that the HepF is a disease which is under-recognized in society, and that too particularly in our country. The world fever shows that up to more than 50% of people have HepF. And our own data from various registries, from Kerala and Trivandrum registry didn't show that. That shows 25 to 30%. Probably most of this HepF population are with pulmonologists. And also to a large extent, they are also with nephrologists. And these are the group of patients which are missed in clinical practice, and they have the prognosis which is as bad as HepRef. And repeated hospitalization, worsening of heart failure is also as common as HepRef population. So it is not a disease which is, we'll say, inferior to HepRef, but yes, has little less mortality compared to HepRef population. So our patient belongs to this category, and what the guidelines are now available from American Heart Association and also from ESC, we know for HepRef we have learned to use 4 pillars, the beta blockers, the ARNI, the MRAs, and the SGLT2 inhibitor. But for HepF, or mid-range, above 40 between 40 to 50 is mid-range, and above 50 is HepF population, the guidelines are almost similar between the two groups. Only thing is that SGLT2 inhibitor is class 2A indication in ACC, but in ESC they have been given class 1 indication now. And for mid-range, ARNI, MRA, and beta blockers are good because large number of patients of mid-range are coronary artery disease patients. HepF population, there is no role of beta blockers, and they are similar between ESC and AHA. The 2 important trials which has helped us to bring the SGLT2 inhibitor to the armamentarium of the management of HepF has been Emperor Preserve trial, and second is the Deliver trial, where the DAPA was used and Emperor empagliflozin was used. What they found that the trials were positive, but yet the patient, those who took the SGLT2 inhibitor, they had a residual risk of increased heart failure of the tune of 14 to 16% in both the trials. So that means there is some area where we need improvement to reduce the mortality and hospitalization for heart failure. So this was the situation of our patient Jane. She is already on SGLT2 inhibitor, and yet she was admitted with heart failure. And what we have found now, the patient, those who are having EF above 40%, the MR overactivation has been seen triggered by ROS overactivation is a fundamental pathophysiological mechanism. So what happens, if there is a mineralocorticoid receptor overactivation, there is sodium and water retention, inflammation, hemodynamic factors, and then hypertrophy of vasculature. And that leads to both the organs involvement, the kidney failure and also the heart failure because of increased fibrosis and cardiac remodeling. And if you inhibit this MRA by using a drug like finerenone, which definitely will take care of the fluid imbalance, hemodynamic factor, inflammation, fibrosis, and ultimately will protect the heart and kidney. Now coming to the comparison of the known, what we say, steroidal MRAs, they are spironolactone and eplerenone, and non-steroidal is finerenone. Non-steroidal finerenone is a little bulky structure. It is potent, but equal to spironolactone. Both of them are superior to eplerenone in terms of potency. Selectivity, finerenone is much ahead of other two drugs. Sexual side effects, endocrine side effect of the gynecomastia and amenorrhea or menorrhagia is much more common with the spironolactone compared to the finerenone. Half-life is only 2 to 3 hours. Spironolactone has a large half-life, and it results in multiple byproducts, what we have seen, but it is the active drug itself. And that's why this drug is now being utilized for the CKD with diabetic population and now patient with HFpEF population. Whereas the other two drugs are mainly for, at the moment, for HFrEF population. Their study on HFpEF population have not shown good results. Some of the studies are still going on with spironolactone. Finerenone was also tested against spironolactone in two trials, the CONPASS trial and ARTS trial, direct comparison between the two. And what we found that there was a small increase in potassium level in finerenone compared to spironolactone. So hyperkalemia as a side effect is much less with finerenone compared to the spironolactone. And also the renal impairment, the decrease in the GFR was also found to be much more with that. The drug was first studied in Fidelity program. It is a pooled analysis of two trials. One is the Fidelo DKD, the other one is Figaro DKD trial. Both the trials were done on diabetic CKD population in all the range from the stage 2 to stage 4 CKD population. All the ranges of CKD population, this drug was used. And what we found, very interesting finding, that it reduced the CKD progression by 23% and reduced the chances of end-stage renal disease by 20%. But if you look at the cardiovascular morbidity and mortality was reduced by also 14% and 22% of first hospitalization for heart failure. So this was a study done on diabetic CKD population. But we found the benefit in both the organs and 32% reduction in UACR. I mean, these studies, most of the patients were on having high microalbuminuria. So this drug became really a good drug and one of the pillars of nephropathy population, particularly diabetic patient. You can give RAS blocker, you can give SGLT2 inhibitor, and this is the third drug, finerenone, which was given to reduce the proteinuria and prevent the progression of nephropathy. So based on this study of Fidelity program, the ESC 23 guideline not only gave clearance for the nephropathy prevention, but also for prevention of the hospitalization for heart failure as a class 1 indication. So the drug got the approval before the fine art trial. So finerenone has a stronger recommendation for the treatment for mid-range and HFpEF population than the steroidal MRAs. It is almost like class 2A indication for 2025 iCardio and also Japanese Heart Failure Association meeting. So both the places, and now FDA has given approval for heart also. So in India, finerenone is approved with the same indication as US FDA for the management of CKD associated with type 2 diabetes and heart failure with ejection fraction above 40%. To reduce the GFR, to sustain reduction of this end-stage kidney disease, CV death, myocardial infarction, and hospitalization for heart failure. So based on this data, very strong data, the fine art study was done, and that was released last year in London at ESC meeting. So here the difference was that in Fidelity program, they have given finerenone only up to 20 milligram, But in heart failure population, they have given up to 40 milligram, those who can tolerate. So this is 10, 20, or 40 milligram versus placebo. And then we look into the primary endpoint of cardiovascular mortality and total heart failure hospitalization. These are the patients above 40 years, above 40% of ejection fraction, high NT-proBNP, and patient with history of heart failure. And what we found that the patients, those who were included in fine arts heart failure trial, they were the one, those who have just within 7 days they had heart failure, just what we say, a worsening of heart failure. For that, vericiguat is now being given. And that worsening of heart failure, recent heart failure, all those high-risk population were taken. And look at the background treatment. The loop diuretic was given, almost 85% patients were also on beta blocker, and ARB was also in sizable number of population. Only SGLT2 inhibitor was small number because by that time the SGLT2 inhibitors were not in the guideline, but they were still given. So our patient is now belong to that because she was recently admitted with the heart failure only. So finerenone demonstrated clinically 16% relative risk reduction of cardiovascular death and hospitalization for heart failure. The difference in the treatment effect on the composite cardiovascular endpoint came very early. You can see the curves diverging very early in the onset of the clinical trial throughout the fine art trial. So that is what we thought, that this patient should receive this drug to prevent further heart failure. The reduction of composite cardiovascular endpoint was seen alone also for hospitalization of heart failure, and cardiovascular mortality showed similar type of benefit, more for heart failure hospitalization. And then they look into the subgroup analysis, and what we found, those patients who was on SGLT2 versus non-SGLT2 inhibitor, both got benefit. They also saw that all the ejection fraction from 40 on to 60, 65, everyone got the benefit. And the new onset of diabetes was also reduced in this population. So there was the additional benefit. And when you look into the side effect of the clinical trial, they were not much different between the finerenone and placebo as far as the discontinuation of the drug is concerned. But if you look at the hyperkalemia, as expected, it was above 5.5 was seen in 14% in finerenone and 6% in placebo group. But the potassium above 6 was not seen much difference between the two. Hyponatremia, which is again a possibility we can see, but hypokalemia, which is also a possibility in many patients of heart failure, that was reduced in finerenone group compared to placebo as expected. So that was the advantage of that. So the recommendation now what has come is that the finerenone has received the recent FDA and Indian DCGI approval to reduce take the lower part, that above 60 GFR, you can start with 20 if the potassium is normal. But if the patient whose GFR is between 25 to 60, start with 10 only and increase to 20, but again look carefully for the potassium. So dose adjustment is based on potassium level. If the level remains below 5, you can increase and maintain the target dose up to 40 also in heart failure population. If between 5 and 5.5, maintain the current dose, whatever it is, 10, 20 or 40. But if it goes above 5, but below 6, you have to reduce. If it's 20, you can reduce to 10. If 40, reduce to 20. But if the potassium goes above 6, straightway stop the drug. Wait for the offending agents. And one of the commonest offending agent, what we found, is the intake of potassium in the diet, like citrus fruit, lemon, or coconut water, dry fruits, and many times what we say that what we take, senda namak or something, the black salt. These are the area which needs to be corrected. So monitoring of potassium and GFR is required to treatment initiation and dose adjustment in all the patients. So now what we learn now, the therapy with different mechanism of action has address the multiple mechanism of action. And what we have found now, for patients with HFpEF, besides diabetes, SGLT2 inhibitor, and now the third drug which has come is the Finrinol, non-steroidal MRI. So it becomes a strong tool to prevent the further cardiovascular disease. And the Moonraker clinical trial program is going on. We are participating in this from Kangaram Hospital now. And where the Finrinol is used along with the SGLT2 inhibitor, and Finrinol is also being studied now for HFrEF populations, particularly those who are unable to tolerate spironolactone or that will give us answer whether this drug can be used in HFrEF population. Or as of today, we should use only in HFrEF population. I think the message that Finrinol is the first and the only MRA to demonstrate definitive benefits and good tolerability in patients with heart failure with mid-range and preserved ejection fraction, irrespective of home medication like SGLT2 inhibitor. Is the only MRA to receive regulatory approval not only from the FDA but also from India. And fine heart program is still going on that will answer some of the unanswered questions of using this drug in clinical practice. Thank you very much for listening to this.
Dr. Ajit? I want to ask a practical question. Suppose I have started treating high blood patient on 4 pillars and the exercise sometimes improves and now it is 45 or 48. Whether you like to switch around to Finarinan or you continue with that?
I think very good question, very tricky question of course. I think since we have started with Eprinol spironolactone, based on that we have improved. I think at the moment there is no indication that we should shift that to that. The question comes sometime that patient of diabetes has CKD, like Fidelity program, with proteinuria. And now you are treating, and this patient has got resistant hypertension. The guideline says you use spironolactone or Eprinol. That's what the guideline says. But patient has proteinuria. And we have also learned the spironolactone and eprinol probably they are not renoprotective. They are cardioprotective. They reduce blood pressure. Now whether we should shift this patient to Finrinol to give dual benefit. But when we look into the data of antihypertensive effect of Finrinol versus spironolactone is superior. That it causes much more reduction. So the answer there also is questioning. So this is a good question, but I think answer is to keep it on the same level.
Wonderfully presented, sir. Within 1.5 years in the market, we've been using it quite often. But two comments which I would like to make on this is, we should prefer to start Finrinol at higher EGFRs. Do not wait for the EGFRs to go down to 45 and then start. You won't get results. Because I've been doing it for last 1.5 years, trying to use it above 60 EGFR. Then HFpEF came in. Try to do NT-proBNP equal in every patient, find out these patients. This is a very important subset we have to look into. So Finrinol at higher EGFRs, we've seen that the EGFR decline is delayed. The UACR regresses, micro, macro to micro or normal. Number 2, the confidence trial which came in just recently has actually said Finrinol, if you have an SGLT2 on a patient, add Finrinol. And vice versa. And if both are given together, a 10 milligram of empagliflozin and Finrinol 10 or 20, depending on the EGFR, you could get a much better effect on regression of UACR and EGFR. So try to use them at a higher EGFR. हमको लगता है थोड़ा सा रुक जाए, but when you get that the albuminuria, more than 30, around 100, that is the time when you should really add and see the response. It works fantastically.
Very good comment, sir. I think this is what we want to make. Many times we keep on looking at creatinine and GFR. GFR may be normal, but proteinuria is there. And there, this is the drug, as you rightly said, it works. And this is what the Figaro trial said, that you start early, you'll get much more benefit. If you want to reduce proteinuria in such population, diabetic with CKD, with diabetic with proteinuria, we say. In that situation, the ARBs and the SGLT2 inhibitor, and this is a third filter. So, and results are very gratifying. I can tell you, you follow them up over a period of even within 1 month, there is a reduction of proteinuria. Yeah.
one message I have that this drug in heart failure with bed ejection or preserved ejection can be used in diabetics as well as non-diabetics. Because 50% of the population of fine arts was non-diabetic. And even in that non-diabetic population, they found that there was improvement in proteinuria. So you don't be surprised that in years to come it will be used for proteinuria in non-diabetic population. Those studies are still happening.
Yes, very good point. I didn't speak for that. Diabetic in fine arts, both the patients were there.
Dr. Mota, would you like to add something here? I think it was an excellent session and discussion, and we have wonderful drugs in renown in our armamentarium for the management of preserved ejection fraction and mid-range ejection fraction. Any one question we can take from the audience?
With all these 5 pillars of people heart failure, what is life expectancy now?
You see, I'll give you an answer in a different way. The last 3 decades or advancement of medical science has resulted in increase in lifespan by 11 years. And when we look into the different departments' contribution, cardiology 7.5 years, rest all departments but 3.5 years. I mean, just going for that. The lifestyle modification played a major role, control of risk factor played a major role, PCI and bypass surgery only 10%. Now coming to your point now, since we got now at that time, SGLT2 inhibitor, Nocrinia, all even Verisugate group of drugs were not available, I think the expectancy of life will increase further. It will definitely increase further. Last few drugs, 3 drugs has also helped us. 4th and 5th drug. Now 5th pillar possibly may be Verisugate. The way it looks like Victoria and Victor trial, it looks like that drug will be also a 5th pillar for heart failure with reduced ejection fraction. For preserved ejection fraction, we have only 3 pillars at the moment. Maybe 4th pillar coming up. As in the morning, we have been having a discussion about GLP-1 analog. And GLP-1 analog, semaglutide has seen in step heart failure trial. And in that, it clearly shown that this drug improves the outcome and mortality in this population. So probably the 4th pillar will be GLP-1 analog for HFpEF population, those who are obese with or without diabetes.
Thank you, sir.
Sir.
Mic they go, mic.
So I would also like to know that it's not the number of years which matter, but what quality of life.
You see, when they look into this data, so because this is what I am quoting Dr. Roberto Ferreri. This was a talk given by him 2 years ago, looking into the data of how lifestyle has increased. When they look into the European, USA, Canadian population versus the South Asian population, out of 11 years, the 7 years were healthy life for Western population. It was reverse in Indian population and South Asian population. We increased the lifespan, but we were sicker. Bedridden, some of them, but they are taking much. So that is the quality. What raised a very good question. The quality of life and associated illness was much more in South Asian population. And even look at the Asia, Northeast Asia, Japan behaved like the European country. South Asia and Southeast Asia were the worst population. Those who increased their lifespan, yet they were not very happy because they were with medicines.
Secretary, you said 7.5 years by the cardiology.
I'm very proud.
2.5 by the other doctor. Otherwise, I had the impression that cardiology degree is by 2.5 years.
No.
I had the reverse impression. I thought physicians do a better job than us. Thank you, sir. Thank you, Dr. Sani. Excellent talk. Thank you, dear person. Please proceed to the presentation desk. Thank you very much.
I would request Dr. Prakash Keda to kindly come and felicitate the chairpersons and speakers. I would now request President of EDPA, Dr. Pankaj Chaudhary, as also the young and dashing Dr. Paris Gangwan to kindly come onto the stage. I would now request our special guests, Dr. Shama Batra, Dr. Neelu Gandhi, Dr. Ajay Lekhi, and Dr. J.K. Sharma to kindly join President, the next president of the stage, so that we may felicitate you.
We are happy to welcome people from all walks of life in Delhi, all academic premier institutions, IMA, RSSDI, Innovative Physician Forum, and all the associations across Delhi and NCR. We are happy to have them here.
And apologies in case the color of the cloth is not matching with the sarees worn by the two dignitaries. The colors were chosen by Dr. Paras Gangwal. Right. I would now request the current executive, all the past executives of EDPA, special invitees, as also the guests of honor to kindly join us for the inauguration ceremony. I would also request Dr. T.S. Clare to join us for the inauguration ceremony and request all the ex-presidents of EDPA currently seated to kindly join us for the inauguration ceremony. I will once again request all the ex-presidents as also the current executive of EDPA along with the special invitees and the guests of honor Dr. Clare will be delivering the Srimati Bela Devi Memorial Oration also to kindly join us. I request all past executives of EDPA to kindly join us for the inauguration ceremony. I would request Dr. Paras Gangwal to kindly escort the senior ex-presidents to the front. Thank you. Thank you to all the current executives, past executives, and warm thanks to Saroj Dubey ma'am. And I will now hand over the proceedings. This is the one picture which is always taken, everyone with Dr. Saroj Prakash ma'am, all the executives. And I will now hand over the stage to the Secretary of EDPA, Dr. Swati Chani.
Now I request all the current executives of EDPA to kindly come over to the dais. We'll be proceeding to our next session, which is a very important session of this afternoon. Dr. Pankaj sir, our past president Dr. Paras, Dr. Dan sir, please you have to come over to there. Dr. Anirudh, Dr. Aman sir. I request Dr. Paras to kindly escort Dr. B.M. Akkad, the guest of honor for today. So year after year, we've been felicitating our senior members of EDPA with Lifetime Achievement Award. So this year, the Lifetime Achievement Award is being conferred to Dr. Vimal Nakra. I request our President Dr. Pankaj sir to kindly say a few words about Dr. Nakra. I also request our Senior Vice President Dr. Aman to kindly escort Dr. Vimal Nakra and Ma'am Dr. Savita Nakra to the stage.
So, on behalf of executive, I welcome Dr. Vimal Nakra sir. Dr. Vimal Nakra sir is one of the founder member of Teacher Association. I think we can give a round of applause by standing ovation. He is alumni of GSP College and working so hard and so profound work has been done to his very Christian association that we are all indebted to him. So I request Swati to just do the proceedings.
So now I request all the executives to felicitate Dr. Vimal Nakra and Dr. Savita Nakra. I also request the executives to felicitate Dr. B.M. Akkad, our special guest of honor. I request everyone to be seated as we'll be announcing the postgraduate quiz results. Sir.
Thanks, friends. I'm really very much well known with the award they have offered me. And I don't think my life achievement stops the life further. And I'm really privileged to have my seniors who started when I started my career in East Delhi after coming from Kanpur. And I was very much impressed with Dr. Rajiv Gupta, I hope in that, and Dr. Gera. They were really mentors with me. And I am thankful to my esteemed colleagues here and juniors and the colleagues who have helped me all through my clinical work. And I should not forget my family also, who have really suffered a lot of my emergency calls and were awake when I was attending the calls in the night. And above all, the EDPA, I am very thankful to all the EDPA members. Thank you very much.
So now we'll be before going to the next session, I want to announce the results of Dr. A.K. Jain Memorial Quiz. I request Dr. Subhalakshmi and Dr. Ashok Kumar to kindly come over to the stage. Dr. Ashok was the moderator. Dr. Shubha ma'am, please. I also request Dr. Sangeeta Jain and Dr. Rahul Jain to kindly come over to the stage. I am now handing over the mic to Dr. Shubha to announce the results. Thank you, Dr. Swati. And as we have a wonderful quiz in the morning session, where we had 8 teams participated in the quiz, and we had 3 quiz masters for the same. So, moving on to the result of the team, Team RML, Dr. Nargis, Dr. Pushpendu, and Dr. Rishabh. They were secured 3rd prize in quiz PG program. So, Dr. RML team, if 3rd prize? Third. Dr. RML team, 3rd prize. Are you here? Please come.
Let's come over the stage.
I will be announcing 2nd also. ये 3rd है. May I request Dr. Sangeeta Jain ma'am to please felicitate, and all the other dignitaries may please join. 2nd prize goes to Team Safdarjung, comprised of Dr. Shubham, Dr. Rajesh, and Dr. Mani. ये 3rd का दे दो. Dr. Ashok. Dr. Ashok. Quiz का लिया ना. Safdarjung, they stood 2nd in the quiz competition, PG quiz. Yes, please proceed. First. And now announcing the team who stood first in the competition. That was Team Lady Harding. They secured first in the quiz competition. Dr. Ishika, Dr. Akash, and Dr. Saksham. I request Dr. Makkar sir to please felicitate and bless the team. Please come from that side. Come from that side, quickly. So congratulations to all the team for your wonderful performance and all the teams who have participated. That is also very nice. Thank you. I request the executives to please stay back on the stage. Dank sir, you, आपको भी oration. मक्कड़ सर, RPS मक्कड़ सर, आपको भी स्टेज पे आना. We are already late. 1 hour late. आप तो उतर गए.
अभी तो नहीं है.
Sir, say a few. So we want a few words of wisdom from you.
Few words of wisdom to the audience, to the EDPA. सर कुछ 2 words बोलो EDPA के बारे में. अच्छा छोड़ रहे थे तुम मेरे को.
Good afternoon, friends. My dear colleagues at the EDPA, Dr. Chaudhary, President, Dr. Dang, Organizing Chair, Dr. Vijay Arora, I think he's not there, but he is the person who connected me with the EDPA to begin with. Dr. Bansal, Dr. Ashok, Dr. Anirudh, Dr. Swati, and many more people in the team who are working behind the scenes to make this meeting successful. It is indeed a great honor to be here as a guest of honor, but I totally fail to understand why I have been chosen to be guest of honor. Because I am one of you. And I think the only thing, the only criteria that possibly made me guest of honor is that I am officially non-member of EDPA. So they thought that we can get him as guest of honor and give him honorary membership also. So I think, yes. So the only criteria for choosing me was that I am officially non-member. Now they are forced to make me a member. And next time onwards, you will not see me as guest of honor. But it's indeed a great pleasure to be part of organization which is so vibrant, so active. And 26 years for an organization of physicians to grow, I think it takes a lot of effort and a lot of strength. And I wish the leaders, the members, my colleagues and brothers in the organization, all the success in keeping this organization growing as it has been growing, and maybe, growing further, better, and hope to see you hosting the Golden Jubilee of EDPA. Thank you so much.
So the next important part of the day is Srimati Bela Devi Memorial Oration. Srimati Bela Devi Memorial Oration was instituted in the year 2000 by Dr. Saroj Prakash, one of the most senior members of EDPA, in the memory of her late mother. Srimati Bela Devi belonged to Khurja, a small town in UP. After marriage at the age of 15 years, Mrs. Bela Devi came to live in Shadra in the mid-20s. At the time, Shadra was a small satellite town of Delhi with a population of around 10,000. The place was rampant with malaria, enteric fever, and other communicable diseases, with very little, if any, by way of health facilities. Education was not considered important, and there was only a primary school for girls. Although herself minimally educated, Bela Devi believed in girls' education. She had to take a very bold step of educating them beyond 5th class, because it meant sending her 10-year-old daughter to Delhi daily by train. This was against all the financial or social odds, but she persisted. The family shifted to Delhi in 1942. This was a difficult period for a middle-class family due to ongoing Second World War with rationing, shortage of food and clothes. Agitation for national independence was also at its peak. However, Bela Devi managed to educate her 7 daughters and 1 son without any gender bias, practicing what is now being preached today about the importance of girls' education and health. A lady ahead of time, Srimati Bela Devi did not hesitate to even send her daughters overseas for higher education. She believed in financial independence for girls and succeeded in her effort, as all her daughters received good education, achieving their desired position in life in various fields of education and arts. This oration is dedicated towards this brave and visionary mother by her daughter, Dr. Saroj Prakash. As Dr. Saroj Prakash herself said, and I quote, "As a child, I was considered a harbinger of luck by my father, but I believe that it was me who was lucky to have a mother like mine. She made me what I am today." So as we all know, Dr. Saroj Prakash ma'am is one of the founding members of EDPA. She was faculty of medicine and she was professor of medicine at MAMC. She also served in LHMC. She has various awards and special achievements, like she was felicitated by MOHFW for outstanding and valuable contribution as a doctor to society on National Doctors Day on 1st July. She was felicitated as senior most lady physician of East Delhi and by multiple forums like LHMC Alumni Association and East Delhi Gynac Forum. So now I want to announce this year's oration. This year's oration is conferred to Dr. T.S. Clare. I request Dr. Pankaj to say a few words to Dr. T.S. Clare.
So before that, I would like to ask our executives, Dr. Dang sir, to felicitate Dr. Saroj Kumar Prakash ma'am with a bouquet. And Anurag, kindly help. So Dr. T.S. Clare is the chairman, BLK Max Heart and Vascular Institute. He was one of the 4 founding doctors of world-famous Escorts Heart Institute, Delhi. Dr. Clare developed a field of interventional cardiology and electrophysiology at Escorts, first state-of-art dedicated electrophysiology department in SAARC region. Dr. Clare is honorary professor of cardiology at Banaras Hindu University. Dr. Clare has many firsts to his credit. He implanted the first ICD in SAARC region. In 2002, he implanted the first CRTP and within a few months CRTD. In 2015, he did pacing with special techniques called his bundle pacing, first time in SAARC region. He initiated ICD implantation and RF ablation program in many centers in India and abroad. He implanted first ICD in Nepal, Sri Lanka and Punjab Institute of Cardiology in Lahore. Dr. Clare has helped many centers to develop heart care services. Dr. Clare has published more than 200 scientific papers in Indian and international journals of repute. He has also contributed many manuscripts and chapters in cardiology textbooks. A lot of awards, prominent being DSC by Punjab University, Lifetime Achievement Award by Indian Medical Association, Padma Bhushan by Government of India 2005, honored with Delhi Medical Association Centenary Award and Times Healthcare Achievement Awards in 2017 in the category Legends of Medicine. It's my proud privilege to ask Dr. T.S. Clare to come up on the stage, and we would like to honor you. Thank you, sir.
I request the executives to felicitate Dr. Clare. I now request Dr. Claire to begin with the oration.
Thank you, EDPA. The name is very good. Naresh, Dr. Pankaj, Dr. Swati, and the whole members of the East Delhi Physicians Association. And I also want to congratulate Dr. Nakra for his Lifetime Achievement Award. It was nice to meet Dr. Prakash, one of the legendary figures in the medicine. मेरे को जितने अवार्ड इन्होंने दे दिए आज मेरी शादी पे नहीं मिले थे वैसे उसका रीज़न ये भी था कि मेरी शादी कुछ हालात सर्कमस्टांसेस हुई अगेंस्ट माय विश ऑफ माय पेरेंट्स सो मेरे को तो अपनी ज़िंदगी का खतरा था तो मिलना तो क्या था एनीवे तो जब नरेश ने कहा कि जी आपको वी वांट टू कॉल यू फॉर ओरेशन सो आई सेड आप जो मर्जी कहोगे मैं बोलूँगा तो आई टोल्ड हिम कि जी ये बोल दूँगा देन ही सेड कि समथिंग डिफरेंट मैंने कहा डिफरेंट तो ये है कि फिर मैं आई विल स्पीक समथिंग विच इज़ नाउ मोर क्लोज टू माई हार्ट इट्स नॉट कार्डियोलॉजी बट नॉन कार्डियोलॉजी स्टफ सो दैट्स व्हाट आई एम गोइंग टू टॉक टू यू ही सेड टेल योर ओन स्टोरी हाउ यू केम फ्रॉम अ स्मॉल विलेज बट I don't want to bore people with that story too long because I am from a very small village in Punjab. The village name is Amargarh. When I was a child, there was no electricity, there was no road in my village. And when I became 6 years old, then only some school teacher came. And जो गांव का चौकीदार होता है तो he came with the drum that सबको सूचित किया जाता है जिनके बच्चे 6 साल या 6 साल के ऊपर हैं उनको स्कूल जाना पड़ेगा इट वाज नॉट ए गुड न्यूज़ क्योंकि हम तो बंटे खेलते थे गांव में सो एनीवे नेक्स्ट डे माय ग्रैंडमदर टुक मी टू द स्कूल एंड द टीचर वाज 25 इयर्स ओल्ड गर्ल वेरी गुड लुकिंग तो मैंने कहा दिस इज नॉट ए बैड आइडिया टू जॉइन द स्कूल सो दैट इज हाउ माय जर्नी स्टार्टेड and the school was in a dharmshala because we didn't have a building. So ये primary school था and to tell you the story कि आज भी वो primary school ही है मेरे village में. That's all. In those I joined I think in 1959 अभी भी primary है. And I had to go to another school to do my 8th class, then had to go to another school to do my 10th class. We used to go on foot. And I don't have any shame to tell you that 50% times we didn't have shoes. We used to go on नंगे पैर जाते थे क्योंकि I am from farming community तो उनकी फसल आती है 2 बार साल में तो जब फसल आ गई तो हमें वो खाकी बूट लेके देते थे और वो महीने में हम तोड़ देते थे उसके बाद you wait for the next crop जब मिलती थी. So what God was kind so I was I think good in studies incidentally. And I could go into Medical College Patiala. So that changed the whole thing. Then after Patiala, I was again lucky second time I was selected to PGI Chandigarh, which I had never imagined. Actually, as a doctor, I would say that is a watershed area. Before PGI and after PGI. PGI ने मेरे को बेवकूफ़ से जब खोते से बंदा बनाया. I would say simply because PGI is a great institution. Or I tell you that I am a relatively atheist person. I don't go to गुरुद्वारा मंदिर मैं मत्थे नहीं टेकता जाके लेकिन मेरा गुरुद्वारा मेरा मंदिर मेरा मस्जिद मेरा सब कुछ पीजीआई चंडीगढ़ है वहाँ जाके मैं अभी भी मत्था टेकता हूँ उस धरती को जिसकी वजह से मैं आपके सामने आज खड़ा हूँ. Because of my PGI training in medicine, and I tell you one thing, I love being a physician. I think physician is the most important link in medicine, most important. In fact, in PGI Chandigarh, Dr. Wahi will not give you a seat in cardiology if you have not done at least 1.5 years of internal medicine. He will not take you directly because he very rightly appreciated that basically कुछ भी बनना है स्पेशलिस्ट आपको आपकी इंटरनल मेडिसिन स्ट्रांग होनी चाहिए. So I did also registrarship in medicine and I really enjoyed being in medicine. और अब भी मेरे को बहुत इंटरेस्ट है मेडिसिन में. आई यू कैन डिस्कस गैस्ट्रोंटोलॉजी, नेफ्रोलॉजी और एनीथिंग. आई हैव कीन इंटरेस्ट. So then I became a cardiologist and then went out of the country. And I cleared my MRCP first time without working in UK, which was considered very rare those times because I was told कि नहीं मैं आपको 6 महीने 8 महीने काम करना ज़रूरी है, नहीं तो आप पास नहीं हो सकते. I said I don't have time, let me try. So I appeared and first time I could clear the MRCP examination. I got a job in London, but then I didn't like that weather of London. So came back, my wife, many of you may be knowing Dr. Neelam Clare, who is chief of neonatology in Gangaram Hospital. So she had already come 1 year before me. And I didn't want to work in India. I wanted to go to USA because I had cleared my USMLE. और वैसे भी जो पंजाब के सरदार है, आई एम वन ऑफ देम, वो या तो लुधियाने काम कर दे या फिर सीधा टोरंटो, बीच में कभी रुकते ही नहीं वो. सो मैनी ऑफ पेशेंट, जब मैं एस्कॉर्ट में था, बड़े पंजाब के पेशेंट आते थे मेरे पास और वो कहते सी डॉक्टर साढ़े घर जरूर आयो. तो मैं जी हाँ कितने आना है, और टोरंटो जी. They will say as if Toronto is a next door place. But my wife didn't want to go. She said, no, we don't want to go. I don't want to go because whatever reasons, maybe she was wiser than me. And she said very good thing to me. That time I didn't realize. So I had 2 children, my 2 boys. तो शी सर के क्लियर अब तो बच्चों के पढ़ने का टाइम है, हमारे पढ़ने का टाइम नहीं है. बिकॉज इफ़ यू गो टू यूएसए यू हैव टू डू योर एग्जाम्स अगेन एंड रेजिडेंसी अगेन. सो एज यूजुअल लेडीज आर मोर वाइज इन जनरल. हालांकि हम ऑफिशियली रिकग्नाइज नहीं करते, बट आई थिंक मोस्ट ऑफ द टाइम्स फीमेल्स आर मोर वाइज, मोर ग्राउंडेड देन मैन. वी फ्लाई, बट आई थिंक दे ऑलवेज एडवाइज यू द राइट वे. दैट्स माई एक्सपीरियंस ऑफ लाइफ. So then I said, क्या करें? I was depressed. तो I said, no, I can't leave this lady because मैंने अपने बाप के खिलाफ शादी करी थी, घर से मेरे को निकाल दिया गया था. मैंने कहा नहीं, इसको नहीं छोड़ सकते. So I settled कि मैं दिल्ली में काम करूँगा. गंगाराम में थी मेरी वाइफ, तो गंगाराम offered me a job for 50,000 rupees per month. Practice was allowed. So they didn't have a cath lab. I didn't like the place. So anyway, to cut the story short, आई सर्च बत्रा में गया, वहाँ भी बात नहीं बनी. तो बत्रा वालों ने मेरे से पहला क्वेश्चन पूछा कि डॉक्टर साहब आप पेशेंट कितने लेके आओगे. मैंने कहा यार बड़े बेवकूफ़ आदमी हैं, पहले दिन मेरे से ये पूछ रहे हैं पेशेंट कितने लेके आऊँगा. सो आई टोल्ड माई फादर इन लॉ वाज विद मी बिकॉज ही वाज फ्रॉम जम्मू. सो आई डोंट वांट टू जॉइन दिस यूजलेस प्लेस. मेरे पहले दिन ही पूछ रहे हैं पेशेंट कितने लेके आओगे. सो देन आई अल्टीमेटली जॉइंड एस्कॉट हार्ट इंस्टीट्यूट ऑन ए सैलरी ऑफ 7,500. leaving 50,000 rupees, which was being offered to me in Gangaram. And if I have to tell you my 2 best decisions of life, one was to marry Neelam Clare against the wishes of my father. He wanted to kill me almost. It's a big story. Maybe कभी अपने दोस्तों में बैठ के दारू पी के मैं सुनाऊंगा because वो कुछ मज़ा ही अलग होता है. लेकिन in this August or kind of meeting, I don't want to go, I can't go, I don't have time to go into details. So that was the best decision, I think, because she is a wonderful lady, she is a capable lady, so I have no regret. और मैं अपने बच्चों को और बाकी के लोगों को बच्चों को एक ही चीज़ कहता हूँ कि अपने माँ बाप की बात कभी ना मानो. ट्रेडिशन ये है कि बच्चे को कहा जाता है कि अपने माँ बाप की बात मानो. तो मैं अपने बच्चों दोनों को कहा when they became 20-25, I said look, I have 2 boys, कि अगर मेरी बात आप सब चीज़ों के लिए मानोगे तो एक चीज़ क्लियर कि आप डफर हो, आप में अपना दिमाग नहीं है. सो मैंने कहा मेरी बात सुनो, लेकिन आप अल्टीमेटली अपना डिसीजन लो, अपना सोच के डिसीजन लो, आपके लिए ठीक है. अगर मैं अपने डैड की बात मानता तो I think my history would have been different, so I didn't agree with him. Later on, he also realized that I was right, but that's a different story. The second decision was leaving 50,000 rupees per month. I joined at Escort for 7,500, which is 1/6 of the salary, एंड आई डोंट नो एनीबॉडी इन मेडिकल प्रोफेशन जो कि 1/6 के जाके सैलरी पे ज्वाइन करे. एंड आई थिंक दैट वाज माय सेकंड बेस्ट डिसीजन ऑफ लाइफ, बिकॉज पीजीए के बाद, यूके के बाद, अगर मेरे को मेरी ज़िंदगी में सबसे बड़ी कंट्रीब्यूशन हुई वो एस्कॉट हार्ट इंस्टीट्यूट थी. somehow the other, I don't know who, whether it is Baba Nanak or Prophet Muhammad or anybody, any superpower in the world. When I went to Escort Heart Institute, I got good vibes of that place. I thought, this is the place where I will learn better. So I was, fortunately, I was not after money, I was after learning. And this is what I tell my children now, that don't run after money. The biggest mistake we do in our life is to run after money. Run after quality, run after credibility. Particularly for doctors, I will say, कि अगर आपने कैपेबिलिटी बना ली है, अगर आपके पास स्किल्स हैं, अगर आप सिंसियर हो मेडिसिन में, पैसा आपके पीछे भागेगा, आपको पैसे पीछे नहीं भागना. And that's what happened to me. Because I had married against the wishes of my father, so I had no money. I started my career minus 10,000 rupees, जो कि मेरा दोस्त एक बनिया है, बनिया always money. So I borrowed from him. I started my career minus 10,000, and today I'm not a poor man. God has been kind to me. So मैं हमेशा यही कहता हूँ कि पैसे के पीछे मत भागो, क्वालिटी बनाओ, आपकी क्रेडिबिलिटी बनाओ. Ultimately, credibility matters in life, nothing else. And I think the most interesting thing in life is कि हम बहुत लोग बेईमानी करते हैं, बहुत लोग झूठ बोलते हैं, लेकिन जो लोग बेईमान हैं वो भी ईमानदार की इज्जत करते हैं. ये दिस इज सरप्राइजिंग थिंग कि बहुत बार मेरे से ऐसा हुआ कि बड़े बड़े इंडस्ट्री वाले हैं, बड़े बड़े रिच अमीर हैं, वो कहेंगे ये हमारा कैशियर है, हमारे साथ 30 साल से, डॉक्टर साहब ये ना बहुत ईमानदार आदमी है, ये कहेंगे. वो खुद बेईमान है, वो खुद बेईमानी करते हैं, लेकिन ईमानदार आदमी की इज्जत है. अल्टीमेटली इज्जत ईमानदार आदमी की है, विच वी हैव टू रियलाइज. सिमिलरली ऑन द सेम ग्राउंड, जो डॉक्टर अच्छा है, जो प्रो पेशेंट है, जिसकी ज़िंदगी का एम है कि मैंने पेशेंट को ठीक करना है, उसकी इज्जत होगी अल्टीमेटली. आप पैसे के पीछे भागेगा जो डॉक्टर, वो 50% में स्टैंड लगाएगा. आप कब सुनते होंगे कार्डियोलॉजिस्ट क्या करते हैं, हाँ, और बिन मतलब के बाईपास करोगे, बिन मतलब के आप दवाइयाँ दोगे, अल्टीमेटली आपकी इज्जत नहीं होगी. लोगों को पता चल जाता. लोग इतने बेवकूफ़ नहीं हैं, हम समझते हैं कि बेवकूफ़ हैं, लेकिन अल्टीमेटली लोगों को पता चल जाता है. सो अल्टीमेटली स्टोरी इज कैपेबल ऑनेस्ट डॉक्टर को ही इज्जत मिलेगी. तो मैं आजकल ये देखता हूँ कि जो मेरी सबसे बड़ी ज़िंदगी की एक दुख की बात है कि जो हमारे रेपुटेशन डॉक्टरों का ओवर द ईयर्स हैज़ गॉन फ्रॉम डाउन 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 डाउन. अब उसके क्या, अब देखो, हमें तो जो ट्रेडिशनली भगवान के नाम से जाना जाता है कि डॉक्टर तो सेकंड टू गॉड हैं, और मेरा ख्याल आप जितने भी सीनियर लोग बैठे हो, जहाँ डॉक्टर प्रकाश भी बैठी हैं, जो कि उन्होंने बहुत ज़िंदगी देखी है, कि इंडिया में बहुत इज्जत थी डॉक्टरों की, लोग बहुत इज्जत करते थे. वो धीरे धीरे, उसके बहुत कारण हैं, उसमें कुछ कारण डॉक्टरों की वजह से हैं, कुछ कारण विदाउट हमारे हाथ में नहीं है. जैसे कंज्यूमर एक्ट आया, सबसे पहले इसको मेडिसिन को जो माना जाता था कि इंसान की सेवा है, उससे दूर ले गया. कंज्यूमर एक्ट आया इंडिया में, और उसके बाद थैंक्स टू प्रेस इन दिस कंट्री कि हमेशा डॉक्टरों के खिलाफ लिखना उनका एक धंधा बन गया है. पर्टिकुलरली प्राइवेट डॉक्टर्स, उनको कोई मौका मिले फ्रंट पेज पे किसी के खिलाफ, अगर कंज्यूमर कोर्ट ने केस दे दिया तो वो फ्रंट पेज पे लगाएंगे कि उनको मज़ा आता है इस चीज़ का. देन अवर पॉलिटिशियंस, उन्होंने बड़ी बर्बादी करी है हमारे प्रोफेशन की. एंड आई डोंट वांट टू नेम एनीबॉडी बट मैनी, उनको लगता है कि जब भी उनको वोटें मिल सकती हैं लोगों की सिंपथी लेने के लिए, डॉक्टरों को वो बदनाम करने में कोई हेजिटेशन नहीं करती. इवन some very senior politician, which I will not name, पब्लिकली बोलेंगे जे ये तो ये गलत काम करते हैं, गरीबों का खून चूसते हैं, फलाना 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 करके वो चीज़ है। सो कुछ हमारे पास भी हमारी गलतियां हैं कि हम अपने प्रोफेशन को जिस तरह से हमने करना चाहिए वो नहीं करते। और दूसरी बात ये भी है कि मैं डॉक्टरों की सेहत के लिए बहुत मतलब कि मेरे को बहुत दुख है। जो मेडिकल प्रोफेशन है अभी, इट्स ए वेरी स्ट्रेसफुल जॉब, वेरी स्ट्रेसफुल जॉब। जो जैसे हालात अपने कंट्री में हैं, तो बहुत डॉक्टर मैं जानता हूँ जो कि अपने बच्चों को डॉक्टर नहीं बनाना चाहते, एंड राइटली सो, बिकॉज दिस इज वेरी वेरी स्ट्रेसफुल प्रोफेशन। 90 देयर हैव बीन सर्वेज बाय द वे, वन सर्वे वाज डन, उसमें 90% डॉक्टरों ने बर्नआउट कहा कि हमारे स्ट्रेस रहती है 90%, एंड 60% डॉक्टर सेड दैट दे हैव ए फियर इन देयर माइंड कि उनको कोई पेशेंट आके अटैक ना करे, उनको फिजिकल हार्म ना करे, या उनको कोर्ट में ना ले जाए, या उनकी नहीं बन जाए। Even the incidence of diabetes, hypertension and obesity is more in doctors. Doctors, I say majority of the doctors, particularly in private medicine, they don't take their khana in time. उनका कोई लंच नहीं, उनका कोई डिनर नहीं, 9 बजे तक, रात को 10 बजे तक प्रैक्टिस करते हैं। एंड इट इज़ डॉक्यूमेंटेड कि डॉक्टरों की लाइफ स्पैन इन इंडिया is 10 years less than the general population, 10 years less. ये लोग नहीं जानते हमारे कंट्री के। जब एक डॉक्टर प्रोसीजर करता है, कोई सर्जरी करता है, जब मैं एंजियोप्लास्टी करता हूँ, पेशेंट तो एक बार मरता है, लेकिन हम रोज़ बार मरते हैं, डेली मरते हैं उसकी स्ट्रेस में। ये हमारे कंट्री के लोग नहीं जानते, ये उनको रियलाइजेशन नहीं है। तो क्या करना चाहिए ऐसी हालात में, क्या करना चाहिए? जो डॉक्टर्स हैं, दे आर नॉट यूनाइटेड इन देमसेल्व्स, इट्स ए सैड स्टोरी। जो डॉक्टरों की बॉडीज़ हैं, EDPA फॉर एग्जांपल, अपनी IMA, कार्डियो सोसाइटी ऑफ इंडिया, दे आर नॉट डूइंग एनफ फॉर द कॉज ऑफ डॉक्टर्स। दे शुड डू मोर फॉर द कॉज ऑफ डॉक्टर्स। वी हैव टू डिवाइज ए मेथडोलॉजी कि डॉक्टरों की बर्नआउट कम हो, उनके नंबर ऑफ आवर्स कम हो। यू नो व्हाट इज द एवरेज वर्किंग आवर्स ऑफ डॉक्टर्स इन इंडिया इन प्राइवेट मेडिसिन? 100 आवर्स। इन मोस्ट ऑफ द डेवलप्ड नेशंस वर्किंग आवर्स आर 35 to 40 आवर्स। 100 आवर्स। अगर 100 आवर्स आपने काम करना है, उसके बाद आपने फ़ोन सुनने हैं लोगों के कि जी मेरे को ये हो गया, जो फलाना हो गया, आपके पास ना तो अपने लिए टाइम है, ना अपनी वाइफ के लिए टाइम है, ना अपने बच्चों के लिए टाइम है। तो व्हाट आर वी आफ्टर? क्या अचीव करना चाहते हैं? क्या हम अल्टीमेटली क्या करोगे? अगर पैसे कमा भी लिए, वो प्लॉट खरीद लिए, या अपने स्टॉक एक्सचेंज में पैसे बना ले, एक दिन आपने मर जाना है। एक दिन मर ही जाना ना। स्टोरी तो ये है कि हमें पता है, देखो सबसे ज़्यादा जो ज़िंदगी की रियलिटी है वो डेथ है, सबने मरना है। जब हमें पता है कि एक दिन मर जाना है, ठीक है, वी नीड सम मनी टू हैव ए रीजनेबली गुड क्वालिटी ऑफ लाइफ। अपने बच्चों को एजुकेशन चाहिए, हमें कुछ घर रहने के लिए चाहिए, चलो कार चाहिए। अब चाहे कार मारुति 800 है, चाहे वो मर्सिडीज़ बेंज है, 4 ही बंदे बैठ सकते हैं ना, कोई ज़्यादा फर्क तो है नहीं। तो मर्सिडीज़ बेंज हम क्यों खरीदते हैं? हम ईगो को सेटिस्फाई कर, लोगों को बताने के लिए कि भाई मैं बड़ा हूँ। So the question is ultimately that the doctors in particular, they should be role models for the society. अब ये कैसे हो सकता है, पर्टिकुलरली प्राइवेट में? देखो चैलेंज प्राइवेट मेडिसिन में ज़्यादा है, सरकार में अलग चीज़ है। आई एम नॉट डिस्कसिंग दोज थिंग्स। सबसे पहले मैं कहूँगा डॉक्टर्स शुड नॉट वर्क अलोन एज सिंगल्स। इट इज़ द बिगेस्ट मिस्टेक विच वी डू। डॉक्टर शुड वर्क एज ए ग्रुप्स। 4 डॉक्टर इकट्ठे हो गए, 5 डॉक्टर इकट्ठे हो गए। अब मैं फॉर एग्जांपल आई हैव मेड ए ग्रुप, मैं कहता हूँ सबको, अपने जो डॉक्टर हैं मेरे साथ, कि भैया 9 से 5 बजे आप चले जाओ, एक बंदा रह जाए उस दिन, बाकी चले जाओ, काम करो अपना। सो इफ़ यू आर वर्किंग इन ग्रुप्स देन इट इज़ मच बेटर। Now, what can be the best scenario for a doctor in private medicine? The best scenario is कि जी आपका अपना हॉस्पिटल है, like Naresh Trihan or Devi Shetty, whatever. But everybody is not Naresh Trihan. Well, I have same qualification or maybe more. I have worked more harder, but I don't have that skills to build a hospital. Everybody cannot build. If you cannot build your own hospital, then the second best is that you work in a group. कि जी हमारा group है, and then you have to respect your group partner. You have to tell that my group, my team members are all respectable, they are all good work. You can decrease your stress, you can decrease working hours, you can take a holiday, 15 दिन जाइए, आके कुल ही काम कर रहे हैं, ये नहीं आपको डर कि मेरा इनकम कम हो जाएगी. So these things, somebody should think. The association, हमारी मीटिंग संडे को होती हैं. अरे भैया, यूरोप में तो संडे में मीटिंग होती कोई नहीं. फ्राइडे 5 PM से लेके मंडे मॉर्निंग तक कोई बंदा अवेलेबल नहीं है यूरोप में और अमेरिका में. Nobody is available by the way. Actually फ्राइडे 5 बजे 4 बजे वो चले जाते हैं. उसके बाद नो पेशेंट कैन कॉल ए डॉक्टर, नो पेशेंट, नो कंपनी वाला कैन कॉल डॉक्टर. हम सैटरडे भी काम करते हैं, हम संडे भी काम करते हैं. दुनिया में सबसे पीछे हैं. फिर भी 7 दिन काम करके भी ना हमारी कोई रिसर्च है, ना हमारा कुछ और है. Then we have to think that we are doing something wrong. So मैं कार्डियोलॉजी में ये मैं बार बार कहता हूँ उनको, भैया चलो एक साल नेशनल कॉन्फ्रेंस है, उसमें संडे काम कर लो, बट ऑन ए रूटीन basis, why you want to waste your Sundays, Saturdays? So a lot of these thinking should be changed. And some, people, thought leaders like you, like, your association, for example, जो leaders हैं, उनकी जो ड्यूटी है to bring these changes, to tell the people. So leader का रोल क्या है? लीडर का रोल ये नहीं कि आप प्रेसिडेंट बन गए 5 साल के लिए या 3 साल के लिए, उसके बाद आपने हैंड ओवर कर दिया. यू हैव टू ब्रिंग चेंज, बट नोबडी इज trying to bring change. IMA, I mean, even KK Agarwal, he was my friend, but I don't think that any significant change was brought during his period, even though he was very active. ना तो कोई रेफरल सिस्टम काम हुआ, ना कोई करप्शन काम हुई, ना कोई डॉक्टरों की इज्जत बढ़ी. फिर हुआ क्या? कुछ भी नहीं हुआ ना, नथिंग. So I think these are worrisome things, and we need to think about these things. Not only कि जाओ अपना पेशेंट देखो, पैसे कमा के घर चले जाओ, दैट इज नॉट एनफ. वी शुड डू मोर. अगर हमने अपनी ज़िंदगी बर्बाद कर दी तो कम से कम फ्यूचर जनरेशन को सुधार देना हो. वी शुड गिव एग्जाम्पल्स. वी शुड, देयर आर मैनी डॉक्टर्स जो डॉक्टर नहीं बनना चाहते आज, क्योंकि वो देखते हैं माँ बाप तो मेरे मिलते ही नहीं सारा दिन. दैट्स रियलिटी. सो आई थिंक वी नीड टू थिंक ए लॉट ऑफ दीज थिंग्स. तो मैं कुछ आपके साथ चीज़ें शेयर करना चाहूँगा जो कि मैंने खुद धक्के खा के ज़िंदगी में सीखी हैं. ना को मेरा गुरु है, ना मेरे को धर्म पे किसी विश्वास है. मैं बड़ा गया, गोल्डन टेम्पल भी गया, मैं तो कैलाश मानसरोवर की यात्रा भी करके आया हूँ पैदल. एवरी रिलीजियस प्लेस, एवरी बिगेस्ट चर्च इन द वर्ल्ड एक्सेप्ट मक्का वेयर आई एम नॉट अलाउड, आई हैव गॉन एवरीवेयर. मेरे को परमात्मा नहीं मिला भाई, मैंने बहुत ढूंढा, मेरे को कुछ नहीं मिला. सो टू माई एनालिसिस, देयर इज सम सुपरनेचुरल पावर इन द वर्ल्ड विच कंट्रोल्स ऑल ऑफ अस. एक हम थोड़ा बीज लगाते हैं, उससे बड़ा पेड़ हो जाता है. जब हम सो रहे हैं रात को, मिलियंस ऑफ रिएक्शन आर अकरिंग इन द बॉडी. सो मेनी मेटाबॉलिज्म गोइंग ऑन. एक ओवम से बच्चा हो जाता है, कोई तो कंट्रोल कर रहा है ना, कोई तो है ना. वो चीज़ क्या है मेरे को नहीं पता, मेरे को मिली नहीं. मैं उसको नेचर कहता हूँ कि नेचर नहीं ये है. मेरा अपना विचार है कि वो जो ये सीक्रेट है नेचर का, ये किसी को नहीं पता चलेगा. ये जो बॉडी है, ये कोई, मेरे पास तो टाइम ना, मेरे पास दिमाग है ना, मेरे पास टाइम है इसको ढूंढने का. लेकिन मेरे मुताबिक है ये पता नहीं चलेगा. कोई मर्जी साइंस आ जाए, ये नेचर को डिस्कवर करने वाला कोई नहीं है. बाकी रही मंदिर गुरुद्वारे की कहानी, ये तो मैन मेड स्टोरी है. दिस इज नॉट अ गॉड, वहाँ गॉड नहीं रहता. ये तो वेल रिलीजन हैज़ 2 एस्पेक्ट्स. फर्स्ट ऑफ ऑल इट्स ए मैन मेड स्टोरी, इसमें कोई डाउट नहीं है. बट इट हैज़ 2 एस्पेक्ट. वन इज अ गुड एस्पेक्ट, वन इज अ बैड एस्पेक्ट. गुड एस्पेक्ट क्या है कि इट इज़ ए फेथ फॉर ए कॉमन मैन। कॉमन आदमी का कि जब वो प्रॉब्लम में है वो कहता मेरा परमात्मा, मेरा वाहिगुरु, मेरा राम, मेरा कृष्ण मेरे को बचा लेगा। ये बहुत बड़ा एक बहुत दीवार है अगर आप धर्म को ठीक मानते हो, अगर आपका विश्वास है। और धर्म आपको ये भी बताता है कि आपको ठीक काम करने हैं, आपने चोरियां नहीं करनी, आपने झूठ नहीं बोलना, बड़ा बला बला जो हम सब जानते हैं, लेकिन हम फॉलो तो करते नहीं हैं उनको। मतलब कि 95% ऑफ अस इंक्लूडिंग मी, वी डोंट फॉलो ऑल दोज डिक्टेट्स। पर जो सबसे नेगेटिव एस्पेक्ट है धर्म का, एंड दिस इज ओवर जब से दुनिया बनी है तब से आ रहा है कि दी अमाउंट ऑफ मर्डर्स, अमाउंट ऑफ मैसेकर विच हैज अकर्ड इन द नेम ऑफ द रिलीजन इज अनपैरेलल्ड। किसी फैमन में, किसी बीमारी में इतने लोग नहीं मरे जितना धर्म की लड़ाइयों में मरे हैं। जब इंडिया और पाकिस्तान बना है 1 मिलियन पीपल लॉस्ट देयर लाइफ, 1 मिलियन। एंड देयर आर सो मेनी स्टोरीज इन द वर्ल्ड वेयर मिलियंस एंड मिलियंस पीपल आर एरेडिकेटेड जस्ट बिकॉज ऑफ रिलीजन। अब पैलेस्टीन में क्या हो रहा है? क्या झगड़ा क्या है? धर्म का झगड़ा ना, बंदे तो वही हैं। इंडिया पाकिस्तान का है, बांग्लादेश का, सब धर्म का। तो ये धर्म का बहुत बड़ा नेगेटिव एस्पेक्ट है। अब मैं तो ये भी कहता हूँ कि भैया 2 ही तरीके हैं, या तो धर्म को हम छोड़ दें, अथीस्ट बन जाएं, सारे धर्म बराबर हैं, एवरीथिंग इज रैशनलिटी से, या हम एक धर्म के मान जाए। अब मैं तो कहता हूँ अगर दुनिया में इस्लाम वाले कहते हैं भी मैं तो इस्लाम मानने के लिए तैयार हूँ, सारे इस्लाम मान जो भी, फिर लड़ाई ख़त्म कर दो ना कम से कम। लेकिन वो होगा नहीं कभी, दैट्स नॉट गोइंग टू हैपन। सो व्हाट इज नीडेड फॉर ए सेंसिबल एजुकेटेड मैन इज दैट वी नीड टू यूज रैशनैलिटी, एंड द बिगेस्ट थिंग इज दैट वी थिंक रैशनैलिटी, वी रिस्पेक्ट ईच अदर। दैट्स द ओनली वे प्रैक्टिकली विच कैन हैपन। सो I just wanted to share few things with you people। जैसे मैंने कहा कि मैं अपने आप ये कुछ डिक्टेट्स बनाए ज़िंदगी में कि खुश कैसे रहना है, हेल्दी कैसे रहना है। तो व्हाट आर दीज? सो अगर मैं ये पूछूं आपसे किसी से भी, सो अगर मैं आपसे पूछूं माय कोलीग एनीबॉडी, सबसे बड़ा इंसान का दुश्मन क्या है? यस, हाँ जी, ईगो। वेरी गुड। सो एनीवे मेरे मुताबिक सबसे बड़ा दुश्मन इंसान का है फियर। फियर ऑफ डेथ, फियर ऑफ डिजीज़, फियर ऑफ मैं ज़िंदगी में नीचे ना चले जाऊं, पहले तो मैं बहुत अमीर था, लोग क्या कहेंगे। एक इंसान के दिल में फियर है। अब फियर ऑफ पेशेंट अटैकिंग यू फॉर एग्जांपल, फियर के ये केस ना कर दे मेरे पे, अगर ये मर गया क्या होगा। अगर आपने ज़िंदगी को बदलना है तो आपको फियर निकालना पड़ेगा ज़िंदगी से। जिस इंसान का फियर ख़त्म हो गया उसका कोई कुछ नहीं तोड़ सकता। फियर ऑफ डेथ तो वैसे ही जस्टिफाइड नहीं। आई टेल यू वाई, बिकॉज हर धर्म में यही लिखा है कि मौत का दिन भी, जगह भी, टाइम भी फिक्स्ड है। जब हम चेंज नहीं कर सकते उसको, ना तो हम प्रीपोन कर सकते हैं ना हम पोस्टपोन कर सकते हैं। तो मेरा विचार है कि हम ग्रेसफुली एक दिन मरें, ग्रेसफुली मरें, हर रोज़ ना मरें। इंडिया के लोग वो हर रोज़ मरते हैं डर के चक्कर में। तो मैं कहता हूँ कि देयर आर लॉट्स ऑफ पीपल इन दिस कंट्री, इन दिस वर्ल्ड एक्चुअली, they should be defined as living dead. They are living but they are dead people actually, they are not living. So fear of disease is little bit more justified. उसके लिए हम क्या कर सकते हैं? We should have annual checkup, we should follow good quality of life, जो डॉक्टरों की अपनी नहीं by the way, quality of life, डॉक्टरों आप very unhealthy lifestyle, तो we need to change that. And then the second thing is somebody said ego. ईगो बड़ी ख़तरनाक चीज़ है, इंसान को बहुत तंग करती है और इससे कंट्रोल करना काफ़ी मुश्किल है। मैं अगर कहूँ कि मैं डॉक्टर क्लियर, मैं पद्म भूषण, मैं फलाना, मैं धिमका, यू नो, अब यू पीपल आर नॉट बॉदर्ड, यू पीपल हैव नो कंसर्न मैं पद्म भूषण है या नहीं। आपका कंसर्न क्या है कि मैं आपसे बिहेव कैसे करता हूँ। अगर आप मेरे को कोई हेल्प के लिए कहता मैं सुनता हूँ कि नहीं, दैट इज़ व्हाट मैटर्स। कोई भी बंदा बड़ा हो, अपने घर के लिए हो, इट्स यूजलेस टू हैव ईगो, और ईगो इंसान को नुकसान पहुंचाती है, आपकी तरक्की में एक ऑब्स्ट्रक्शन है। तो वन शुड कंट्रोल, इट्स नॉट ईजी, बट आई थिंक वी शुड कंट्रोल इट। थर्डली, एक्सपेक्टेशन आदमी को बर्बाद करती हैं। व्हाट इज़ फ्रस्ट्रेशन? योर एक्सपेक्टेशन माइनस व्हाट यू गेट इन लाइफ, वो फ्रस्ट्रेशन है। तो अगर आप कहोगे जी मेरा बेटा मेरी बात मानने, मेरी बहू मेरी बात मानने, वो बिना पूछे से चले जाती है, फलाना है धिमका है, तो आप फ्रस्ट्रेशन हो जाओगे। तो एक्सपेक्टेशन जितनी भी मिनिमम कर सकते हैं वो बहुत अच्छी चीज़ है। दूसरा जो मेरा अपना ज़िंदगी एक्सपीरियंस है कि 2 वर्ड हैं जो कि बहुत कॉमनली यूज़ करते हैं, एक लव और एक फ्रेंड। बोथ आर टोटली मिसयूज्ड इन दिस वर्ल्ड। प्रैक्टिकली लव भी बहुत कम है और फ्रेंड भी बहुत कम है प्रैक्टिकली। अब दिल्ली में ये है, आप बहुत बार मिलते हैं, ओ ही इज़ ए ग्रेट फ्रेंड, वो थोड़ी देर बंदा आगे चले जाता है, वो कहता है यार ये चोर है, इमीडिएटली, मतलब फ्यू सेकंड के बाद बंदा ये कहता है। तो मैं ये कहता हूँ कि अगर आदमी कोई आपको कहता है लव, आई लव यू, इवन योर वाइफ कहती है लव यू, और हस्बैंड कहता है, ज़रा सोच लो कि वाकई लव है कि नहीं। इट इज़ ए ट्रैप, इट इज़ ए बिगेस्ट ट्रैप इन द वर्ल्ड। आई टेल यू, आई लव यू एंड ही इज़ माई फ्रेंड। मैं कहता हूँ कि फ्रेंड अगर एक भी मिल जाना ज़िंदगी में अच्छा, तो आप बहुत अमीर हो। फ्रेंड क्या है? फ्रेंड है जिसके साथ आप सब दुख सुख शेयर कर सकते हो। फ्रेंड वो है जिसको आप बता सकते हो कि भाई मेरी इरेक्शन नहीं होती भैया, हाँ वो है फ्रेंड, सो दैट यू कैन शेयर। जो कि आपका मजाक ना उड़ाए, आपको ये ना कहे, बल्कि आपकी हेल्प करने की कोशिश करे। सो अगर आपके पास एक फ्रेंड ऐसा है तो आप दुनिया के बहुत अमीर आदमी हो। बाकी फ्रेंड्स बहुत घूमते हैं, वो दे आर गुड फॉर नथिंग, एंड डोंट बी इन दैट ट्रैप एट ऑल। सो वर्क इज़ वर्शिप। आदमी को काम करना चाहिए। जो भी मेरा अपना काम है, डॉक्टर हूँ, कार्डियोलॉजी मैं आनंद से करूँ। बाबा नानक भी यही कह गए, वो ज़्यादा किताबें पढ़ने की ज़रूरत नहीं। उन्होंने कहा जी काम करो, बंट के छको, सारा कुछ माल खुद ही ना खाओ, कुछ दे भी दो बाकी लोगों को, और नाम जपो। नाम जपने का मतलब ये नहीं कि गुरुद्वारे जाओ भाई जी या ग्रंथ पढ़ो। नाम जपने का मतलब है रिमेंबर द क्रिएटर। आप माइंड में 2 मिनट के लिए आप क्रिएटर को याद करो। डेली एक्सरसाइज योगा इज़ ए वेरी गुड थिंग। अगर आपको एक एडिक्शन ज़िंदगी में लगानी है तो आप एक्सरसाइज की, योगा की एडिक्शन लगाओ, रादर दैन अल्कोहल और टोबैको। मैं कहता हूँ मतलब कि 70 मिनट, रूल ऑफ 70। व्हाट इज रूल ऑफ 70? 70 मीन्स 30 मिनट्स फिजिकल एक्सरसाइज, 30 मिनट्स योगा, 10 मिनट शाम बैठ के शांति से आप सोचो आप क्या कर रहे हो, ज़िंदगी में आपका पर्पस क्या है, एंड रिमेंबर द गॉड। उस वक्त सोचो अपने मन में बैठ के मैं क्या कर रहा हूँ। जस्ट गिव दिस 70 मिनट शुड बी योर्स। फ़ोन ना मत लेके जाओ साथ में, और फिर उस वक्त बातें ना करो, मेरा ये हो गया, मेरा फलाना, मेरे ये हो गया। स्पेंड दिस 70 मिनट्स एंड ऑलवेज ट्राई टू हेल्प एनी बॉडी इन दी वर्ल्ड वेयर एवर यू गेट ए चांस। क्योंकि एक चीज़ पक्की है कि किसी की हेल्प करने से आपका नुकसान नहीं हो सकता, ये कभी नहीं हो सकता। सो आई जस्ट गिव यू वन एग्जांपल कि एक यूपी से पेशेंट आया, ज़रा लो इजेक्शन फ्रैक्शन, गरीब सा बंदा था, तो ही नीडेड डबल चेम्बर आईसीडी। तो डबल चेम्बर आईसीडी 8-9 लाख का खर्चा है। तो मेरे को लगा यार इसका कुछ ना कुछ करना चाहिए। सो आई कुड गेट ए फ्री आईसीडी फ्रॉम द कंपनी, और हॉस्पिटल का खर्चा मैंने माफ़ करा दिया। एंड बिलीव मी, हालांकि मैंने ये सोच के नहीं किया था, पर उस बंदे ने मेरे को कम से कम 200 पेशेंट भेजे होंगे ज़िंदगी में तो इनडायरेक्टली उसने मेरा बहुत फ़ायदा किया, मैंने ये सोचा नहीं था। सो हेल्प करने में कभी भी, अच्छा हेल्प डजंट मीन दैट यू नीड मनी, हेल्प इन द एटीट्यूड। अगर बंदा कोई गिरा भी पड़ा है ना, आप उसको खड़ा कर दो एक बार, इट्स ए क्वेश्चन ऑफ एटीट्यूड। पैसे वाले हेल्प नहीं करते भाई दी वे, यू डोंट नीड मनी टू हेल्प अदर, यू नीड एन एटीट्यूड टू हेल्प। जब भी आपको मौका मिले कर सकते हो। और एक चीज़ मैं और कहता हूँ कि आप अपने आप अज्यूम कर लो अज्यूम कर लो, अपने आप को बताओ दैट यू हैव बीन सेंट बाय गॉड टू गिव नॉट टू टेक। जैसे सिखिज्म में ये पढ़ाया जाता है कि आपका हाथ ऐसे नहीं होना चाहिए, ऐसे होना चाहिए। सो इफ़ यू हैव दैट फिलॉसफी कि भाई मैं तो देना चाहता हूँ कुछ लोगों को, मैं लेना नहीं चाहता, इट विल गिव यू रियल इंटरनल happiness. And I have experienced all this. I am not saying just theoretically. चिल टू द मैक्सिमम. जब भी आपको टाइम मिलता है ज़िंदगी में, आप पूरी उसको मस्ती करनी चाहिए. वो मस्ती मीन्स एनीथिंग. दो जा रहा हूँ दो के साथ, अगर आपको दारू पी के खुशी मिलती है, पियो. नो आई मीन इट. अगर आपको, मैं तो ये भी कहता हूँ, अगर आपको चुगली करके खुशी मिलती है, चुगली करो, कोई बात नहीं. करो, ठीक है. दूसरों को क्रिटिसाइज करो, करना आपको खुशी मिलनी चाहिए अल्टीमेटली. सो यू मस्ट चिल, बिकॉज जिस इंसान की ज़िंदगी में कोई स्पाइस नहीं ना मस्ती की, वो बोरिंग लाइफ है. यू मस्ट एंजॉय लाइफ एट एनी कॉस्ट. दिस इज़ ए गुड आइडिया. स्लीप 7 आवर्स ए डे बहुत ज़रूरी है, कि इससे बेटर कोई बॉडी रिपेयर नहीं कर सकता आपकी. चाहे जितने मर्जी विटामिन खा लो, जो 7 घंटे इंसान सोता है, अगर उसकी क्वालिटी ऑफ स्लीप अच्छी है तो बहुत अच्छी बात है. ज़िंदगी में हमेशा पॉजिटिव एटीट्यूड रखो. अगर आप गिर गए, टांग टूट गई, आपकी टिबिया टूट गई, तो परमात्मा का शुक्र करो, यार अच्छा मेरा ब्रेन बच गया. यू नो इट इज़ दैट काइंड ऑफ थिंकिंग. ऑलवेज यू शुड हैव ए पॉजिटिव एटीट्यूड इन लाइफ. एंड पॉजिटिव एटीट्यूड, आपका नुकसान नहीं कभी हो सकता. यू विल बी ऑलवेज बेटर. नाउ इन मनी मैटर्स, I'll finish. In money matters and in assets, always compare with the person who has less than you. क्योंकि अगर if you compare with people who have more, तो दुखी रहोगे ना सारी ज़िंदगी. अगर आपके पास इधर वाला नेबर है, उसके मर्सिडीज है, इधर आपके वो स्कूटर है, स्कूटर वाले की तरफ देखोगे तो आप खुश रहोगे. सिंपल सी बात है. सो लर्न टू फील सॉरी सिंसियरली अगर आपने गलती की है. सिमिलरली लर्न टू पार्डन पीपल. उनको अगर माफ़ी देनी है, फिर दिल से निकाल दो, फिर अपने दिल में मत रखो इस चीज़ के लिए. नाउ लास्ट बट आई थिंक इज़ वेरी इंपॉर्टेंट, जो मैं खुद करता हूँ, रिमेंबर वंस ए डे कि आपने एक दिन मर जाना है. मैं डॉक्टर हूँ, मैं मरने की बात याद करा रहा हूँ आपको. जब मैं मॉर्निंग में सैर करता हूँ, जो साइकिलिंग करता हूँ, मैं आई टेल माई सेल्फ टी एस क्लियर, तूने एक दिन मर जाना है. कोई हो सके आज अच्छा काम कर लेना. इट एटलीस्ट इट हैज़ गिवन मी बेटर पर्सपेक्टिव ऑफ लाइफ. और जो आप हफड़ा दफड़ी में पैसे कमाने के चक्कर में, उससे आपको ठंडी रहेगी थोड़ी सी. इट इज़ इम्पॉर्टेंट दैट वी रिमेंबर अवर डेथ डेली. सो मैंने मतलब कि हेरा फेरियाँ करके पैसे कमाने का कोई फ़ायदा नहीं, क्योंकि सब कुछ यहीं रह जाना. मेरे को ये भी पता है कि जो मुझे सारा बातें करी हैं आज, जो ये आपको सबको पता है, कोई नई बात नहीं मैंने करी. लेकिन फ़र्क क्या है कि प्रैक्टिकली नहीं फॉलो करते लोग, पर मैं फॉलो करता हूँ. एटलीस्ट 95% आई फॉलो करता हूँ. और इसलिए आई रिमेन वेरी हैप्पी, आई एम कंटेंटेड, आई एम रियली अंदर से खुश इंसान हूँ, क्योंकि मेरे को ये चीज़ों में प्रैक्टिकली इंसान करता हूँ. सो विद ऑल दिस, थैंक यू वेरी मच. And I'm sure that I may have bored you some people, but this is what I wanted to share with you, and my own inner feeling and my own experience of life. Thank you very much.
Thank you, Dr. Claire. I think wonderful insights, and I can assure you as an organization, Easily Efficient Association, जो आपने बोला हम लोग उसको follow कर रहे हैं. And I'm proud of association that जो भी बात करी हम लोगों ने, we are doing, and we are very close branch, and we are very committed branch, and we take care of each other. We are friends. We go on outings, and we do picnics and everything on Easily Efficient Association. So we are all happy, and definitely we should follow this thing and definitely encourage these things in our lives also. Thank you, Dr. Claire, for inciting talk. Non-medical sort of, but yes, this is the truth of lives that we should follow. Thank you very much, sir. So we can have a short lunch break and we'll be back in 20 minutes. Thank you.
आपके दर्शन होते हैं?
I would like to call on stage our respected chairpersons, Dr. J.K. Sharma sir, Dr. Lalit sir, and Dr. Pavitra Sahu. Dr. Pavitra Sahu. I would like to call on stage our moderator, Dr. Naresh Agrawal sir.
So it's truly privileged to be here today with all our team for this next session. One of these is a talk on ulcerative colitis. And Dr. Pankaj told me that we have to talk on recent advances only. And there have been paradigm changes. So my best wishes and congratulations to the whole organizing team for this yet another dramatic and successful session of EDPA annual conferences. We will be talking on two topics. One is ulcerative colitis. So in all fields of medicine, MABs, that are biological therapies, have come up like a volcano. And they have brought the paradigm changes in the treatment schedules. And that is also true for ulcerative colitis and IBD. So today we'll be talking only on ulcerative colitis, because covering this topic in 15-20 minutes, both ulcerative colitis and Crohn's disease is not possible. And we have called the pioneer in this field, Dr. Neha Berry from BLK Hospital, who is a leading gastroenterologist and practicing gastroenterologist, who is at the pinnacle of her career, competence and experience. And we'll be sharing her views in her talk on ulcerative colitis. The next will be a group discussion on GERD. So GERD will be a core basic clinical discussion, and this is because GERD also has witnessed paradigm changes in the treatment schedules, which every one of us sees and experiences in their clinics and hospitals. And that's how we'll be taking advantage of experience of our esteemed panelists. So can we start, Dr. Swati? Sir? Anything you want to put in context? Just to spend some time. And in the chairs we have Dr. Lalit, Dr. J.K. Sharma, and Dr. Lalit is a leading physician from East Delhi, and he'll be joined soon by another gastroenterologist in the area, his son. He'll be completing his degree in a year, I think. Yeah,
1
next
year more.
And Dr. Sharma, well, welcome, sir. Dr. Pavitra, he's a senior consultant in Max Hospital, Vaishali, and they'll be chairing the session. Dr. Pavitra, just put in a context for a few words.
So, good afternoon, everyone. The topic is recent advances in ulcerative colitis. So, in medical management of ulcerative colitis, there are some recent advances, multiple new drugs, and some drugs which were earlier not available in India, now it is available in India. So, there are some changes in practice. How we used to practice in ulcerative colitis. Specifically, when we discuss this kind of issue, we will discuss mostly difficult to treat ulcerative colitis patient, not the common variety of ulcerative colitis patient. And we have Dr. Neha Veri, who has tremendous experience in this field. We all will be enlightened by her talk. Okay, so I welcome Dr. Neha Veri to insert the talk.
Thank you so much, and thank you, Dr. Naresh and the East Delhi, to give me the opportunity to be here and discuss an important topic which is on recent advances in the management of ulcerative colitis in the last decade. And I hope post-lunch we are all a little fresh for this topic. So it is a very big topic. There have been a lot of advancements in the last 10 years. It is genuinely impossible to cover all of them. So we will basically be discussing about refractory IBD cases, which are the newer molecules available, and how we can combine the therapies to help patients achieve remission and so far avoid a surgery if possible. So I will be first covering about the differential, how we differentiate it from an acute infectious colitis, how is the epidemiology changing about acute severe ulcerative colitis, the molecules, how we monitor the disease activity, what are the targets that we are focusing on, and what are the alternative treatments which are currently available. So let me start with a case scenario. So I present a 50-year-old male who had joint pain since many years, but to us he presented with pain abdomen along with loose stools, with blood and mucus in the stools, urgency, tenesmus, incontinence, a low-grade fever, an undocumented weight loss. He has received multiple antibiotics, but there has been no relief in his symptoms. And now the total duration is more than 6 weeks. So what do you think in this patient? See, it is clear that this patient has got a chronic diarrhea which is persisting for more than 4 weeks. What does his labs show us? He was having tachycardia and his temperature was slightly on the higher side. His hemoglobin was 10.8. He had a slightly high platelet count of 5.6 lakhs. His CRP was elevated to 122, a high fecal calprotectin, slightly low albumin 3.0, and the stool workup was negative for any microbiological studies. So therefore, with this I conclude that the patient has a chronic diarrhea, which is an inflammatory type because there is pain, fever, blood, and mucus. So how do I differentiate a first episode of ulcerative colitis versus infectious colitis? So before, let's see what is infectious colitis. So in infectious, the patient will have an acute onset of symptoms. There will be profuse diarrhea associated with fever and vomitings, may have some joint pains, but usually not long-standing. The patient will have a normal hemoglobin, a normal platelet count, elevated TLC, normal albumin, elevated calprotectin may be there, and a positive microbiological test in up to 40 to 60% of the cases. But what we found in our patient is a more insidious onset of symptoms. A low-grade fever, bowel movements not profuse, about 6 to 8 movements, no vomitings. He had joint pains for many years. On blood investigations, anemia, thrombocytosis, normal TLC, low albumin, and negative microbiological tests. So with this, I went ahead and did a sigmoidoscopy for this patient, and we can see that there was continuous involvement from the rectum extending up to the cecum, where there is a loss of vascular pattern, there is friability, granularity, there were erosions, and some spontaneous bleeding. So with this, I make a diagnosis of ulcerative colitis and extent E3 disease, severe disease activity, 7/8 scoring, and I admitted this patient as an acute severe ulcerative colitis. I have also taken the biopsies, which when the biopsies came, they show that the patient had evidence of chronic inflammation. So what is the changing epidemiology in the Indian population? Now there is a great shift east. If you see, the incidence of IBD among the Asian countries is practically the highest in India. And across the world, the disease burden of IBD in India is almost now second to US. So therefore, there is a rising incidence, there is a younger age at diagnosis, we are having more cases being diagnosed as mild to moderate disease activity, our registry data is increasing, and now once considered a disease of the West, it has now become also a disease of the East. So when I go ahead, we admitted this patient as an acute severe ulcerative colitis. So how do we manage? Every time baseline investigations, stool microbiology, rule out Clostridium difficile and CMV infection. Assess for any complications of a toxic megacolon or a perforation. Use venous thromboembolism, and then we have already done a sigmoidoscopy and documented colitis. So once the infections have been ruled out, the next step, which we all have been following, is to start the patient on IV corticosteroids. So you give hydrocort to the patient 100 mg 3 to 4 times a day for 3 to 5 days and assess the symptoms and CRP daily. So this is how we have been managing. But now what has changed in the last 10 years is that after you assess the patient on day 3 and you find that he continues to have a stool frequency more than 8, his CRP is high, it means that he has not responded to steroids and now you need to go on a rescue therapy. So what is the rescue therapy available? The rescue therapy is IV cyclosporin, IV infliximab, and now there is emerging data for the use of tofacitinib or upadacitinib for acute severe ulcerative colitis. So start these medicines and again reassess the patient on day 6. If the patient shows response with cyclosporin, then you can shift the patient on thiopurine or vedolizumab for maintenance. If you achieve response with infliximab, continue infliximab, and with tofa, then you continue tofacitinib. But do evaluate patient for any complications, and if he still does not respond, then do take a surgical consult for a possible colectomy in this patient. So what is the evidence? We have a very huge TACOS trial which has been published from DMC Ludhiana in India, which has shown that tofa at a dose of 10 milligram taken thrice a day along with IV steroids has got an 83% response rate, and you can avoid colectomy in the patients. Also, we now have upadacitinib available in our country, and it has shown a promising data with an 83% steroid-free clinical remission and low rates of colectomy. The other advantage is that both Opada and Tofa in some studies have shown benefit as a second rescue therapy, even after infliximab, but more data is required for this. Then, there is some upcoming data that in patients who have low albumin levels at the outset, you can give a first intensified dose of infliximab, that is instead of 300, you give a 600 mg dose, which may be a savior for the patient. So coming back to our case, we diagnosed as acute severe ulcerative colitis, ruled out infection, started IV steroids, but at day 7, the patient still had a high CRP and stool frequency. So we went to a rescue therapy with infliximab at a standard dose. And then within 72 hours, the stool frequency improved, there was no blood, no pain, patient achieved a clinical response, and then I subsequently kept the patient on infliximab at 2, 6 weeks, and then every 8 weeks. So how do we maintain the therapy, and what is the management of moderate to severe ulcerative colitis? So the idea is that we don't stop only at acute colitis, we have to maintain these patients so that we have to prevent relapse. So in the last 10 years, the molecules that have come up are, in anti-TNF, we know already infliximab and adalimumab. The newer drugs are certolizumab or golimumab, but currently we are not using them much in the Indian population. We are mainly concentrated on inflixi and adali. The advantage is that both IV and subcutaneous option is available. So here I show you that in the last 2 years, there is an FDA-approved subcutaneous formulation of infliximab which is available. And they have shown that after achieving a remission, if you shift from IV to subcutaneous formulation, still there is a 96% favorable response. Other thing for anti-TNF is that they have a rapid onset of action. Better with TNF-naive patients, but the problem is of immunogenicity, development of anti-drug antibodies, the infection risk, and usually we combine them with immunomodulators, so that increases the risk of lymphoma in the long term. So the next molecule that came is an anti-integrin, which is an alpha-4 beta-7 integrin, which is a gut-selective drug. So this is also available in IV. The subcutaneous option is currently not in India. It has a low immunogenicity. excellent safety profile, but because it is gut selective, it doesn't act on their extraintestinal manifestations. And the landmark trials have shown almost 40 to 50% remission rates at week 52. The next category of drugs are anti-interleukin 23 by 12 receptor antagonists, and we have ustekinumab, which is available in India. The P19 inhibitor mirikizumab is soon going to be introduced in the Indian market. So these are again an IV preparation, rapid onset of action, both in TNF naive and failure patients you can use, low immunogenicity, excellent safety profile. Particularly, there are hardly any cases of tuberculosis or major infections reported with these medications. So the landmark trials for ustekinumab show very high remission rates. Similarly, mirikizumab, the endoscopic clinical remission rates, much higher when these drugs were used, and these are all NEGM articles. So then we have small molecules introduced. So these are tofacitinib, which is a JAK1-3 inhibitor, upadacitinib, a JAK1 inhibitor, and filgotinib, which is currently not available in India. The advantage is they are oral, rapid onset of action, both TNF failure and naive patients, no immunogenicity, they are effective against other immune-mediated diseases, but the side effects are herpes zoster, cardiovascular risk, and venous thromboembolism. So they need to be used carefully in patients who have other risk factors for thromboembolism, and it is better to vaccinate them for herpes zoster before you start these medications. The landmark trials have shown excellent results, promising results for mucosal healing and rapid onset of action. With upadacitinib, there is benefit even in the TNF failure patients. When they compared tofa and upada, they found that upada was having better outcomes as compared to tofacitinib, but more studies are going to be required for this. And even tofa can be used for maintenance with better outcomes as compared to azathioprine that we have been using for maintenance, with very few side effects and practically no risk of lymphoma. You have other SIP receptor modulators, again in trials, ozanimod and etazimod. I will not discuss about these because they are not available in India at present, but are promising molecules. So how do we place the therapies? First, take an expert opinion for placing of biologicals. There are a lot of biologicals available, but we have to personalize the approach. So early use of advanced therapy or immunomodulator therapy, if you find the patient is deteriorating or not responding to immunomodulators, the drugs recommended are infliximab, vedolizumab, ustekinumab, tofa, upada, and ozanimod. Maintain remission with the same drug. For patients with secondary loss of response to anti-TNF, you can do trough levels and anti-drug antibody levels. And if the trough levels are low, you can increase the dose to again achieve the response. Biosimilars of infliximab, ADA, ustekinumab are available and are considered equivalent and at a lower dose, so probably better for our population. And subcutaneous formulations can also be used as an alternative because they may have a better patient compliance. So next, if after all these medicines you are finding that the patient is still a refractory IBD patient who is not responding to anti-TNF and other drugs, what are the other options that we can give? The option is you can combine the therapy. So you combine different biologicals or combine a biological with a small molecule to achieve an enhanced therapy. You are targeting different inflammatory pathways. So you can achieve response as well as correct the extraintestinal manifestation, and a more sustained response can be achieved. And we have good randomized trials which have shown that even in ulcerative colitis, a combination therapy will give you better remission rates as compared to a single therapy, with fewer side effects, majority side effect being infection, which is controlled. There is hardly any cases of malignancy reported with a combined therapy. So therefore, where required, consider a combined therapy after expert opinion. Coming back to our case, the patient is on infliximab every 8 weeks with azathioprine, now has come for follow-up. How do I monitor? So clinical monitoring is done every 1 to 2 months. Now let's come to the biochemical monitoring. The main biochemical parameter that we have been doing in our practice is ESR and CRP, and then we check for the hemoglobin levels. But what is important and new is the role of fecal calprotectin and intestinal ultrasound. So basically the role of calprotectin, it is a cytosolic protein released from neutrophils, and it is a marker of mucosal inflammation. So it will help you to distinguish IBS from IBD, to monitor the disease activity, to see whether the patient is achieving endoscopic and mucosal remission, and to predict a relapse. So if on follow-up the calprotectin levels have started to rise up, it can predict a relapse. So it means that you can intensify the treatment preemptively to avoid relapse on the basis of fecal calprotectin. And intestinal ultrasound is a point of care test that you can have in your OPD, where you can check bowel thickness, Doppler activity, stratification, all to see whether the patient is achieving remission or not, and whether we need to change the therapy. But why change? What is the target that we are trying to achieve? The target is a symptomatic response in the first 3 months, then a response in the biochemical markers, calprotectin at 6 months, and endoscopic response at 12 months. The target of mucosal healing is a little far-fetched, and at present we are not targeting mucosal healing. So don't increase the medicines and biologicals only to achieve histological healing. Target endoscopic healing. So coming back to the case, he was doing well, but 6 months later he again developed symptoms. We did an infliximab trough levels which were found to be low. So we increased the infliximab dosage to 10 mg per kg, and currently the patient is in clinical remission, and our idea is to follow up for biochemical. So what is new? Just 1 minute. There is a role of fecal microbiota transplantation because we are achieving eubiosis. We want to achieve anti-inflammatory bacteria which can help to achieve mucosal remission. There is a role of CAR T-cell therapy coming in patients with refractory IBD. There is a goal to achieve precision medicine. See, the idea is you identify the biomarkers, see which genes are active in the patients, and give them a more personalized therapy for better results and fewer side effects. There is a role of artificial intelligence coming up, where with the AI, you can check whether the patient is in endoscopic remission or mucosal remission and target your therapy accordingly. So with this, I conclude that now in ulcerative colitis, we have expanded drug classes. We are targeting endoscopic and mucosal healing. There is a role of combination therapy, improved mode of administration. The focus is on microbiome and precision medicine, and there is practically a search for potential functional cure. Thank you.
Can quickly take 2 or 3 questions.
Actually, we as physicians, we have been treating earlier patients of coming to us, mainly acute phase with steroid and later on mesocol. So is there any role of these mesocol drugs still there? And secondly, after this newer treatment modalities, how many patients are going to surgical intervention, like patient non-responder used to have colectomy or all these things, procedures? So as a physician, we are left with only few options, I think. Managing all these drugs and biologicals, and it's not easy for physicians. So what is take home for physician, or how can you manage?
So sir, if I have a patient admitted with acute severe colitis, we stop mesocol during the hospital admission, because there have been some studies where mesocol can paradoxically sometimes increase the stool frequency. So at that time we stop, but once the patient is discharged, the patient is on 5-ASA medications. The current guidelines are also recommending that if the patient is on higher biological therapy, like the patient is on infliximab, immunomodulators, and along with ustekinumab, you can stop 5-ASA therapy. But by and large, for long term in ulcerative colitis, 5-ASAs are the drugs of choice, and they have even been found to be effective in chemo prevention in these patients. So as of now, I do continue 5-ASA in my practice, even if the patient is on biological therapy. And so the second question?
Sir, the proportion.
Tell a bit more about the immunomodulators like tofacitinib, because they're
Yes.
quite easy to get.
Yes.
Orally, cheap, easily available. Just a bit more about it.
So for tofacitinib, sir,
Yeah.
in the acute, sir, subcutaneous infliximab is not for acute stage. So subcutaneous infliximab is only for maintenance of remission. During remission, you have to give, for achieving remission, you have to give an IV formulation. So then daily doses for how many? So it is not a daily dose. In the IV infliximab, we start with 0, 2 weeks, 6 weeks. These are the loading doses. And after that, the maintenance is every 8 weeks. So you have to give 5 mg per kg, which is approximately a 300 mg injection that you have for a 60 kg person to be given every 8 weeks. So, sir, there is both infliximab and there are biosimilars also available. So, if we go for Remicade, which is the original drug, that is going to cost you approximately 30,000 per injection. But if you go for a biosimilar, which is also recommended in our guidelines, that costs approximately 15,000 per injection.
Dr. Neha, excellent talk, excellent talk.
Thank you, sir.
I just want to know that if we start biologicals in some patient like tofacitinib, so for how long patient is in remission? For how long will you continue? Or is there any protocol or guidelines where we can reduce the dose or off?
So that is the thing, that at present we don't have guidelines. The longest follow-up that we have for tofacitinib at present is approximately 3 to 4 years that they have continued. But beyond that, we do not have data for tofacitinib as to how long it should be continued. But in our practice, we usually give it to the patient for 2 years, and after that, we try to get them back on 5 ASAs.
Thank you.
Ma'am,
5 ASA we combine with tofacitinib, but no azathioprine and tofacitinib combination, because that has very high side effects. So aza should not be combined with tofacitinib.
suppose on the very third or fourth day, patient responds to IV steroids. How long to continue and what next after that?
Sir,
Suppose patient continue remission and then there's no need of biologicals. How long to continue with steroids and whether we should shift over to Mizagul or something of that kind?
Yes, sir. So if the patient on day 3 responds to IV steroids, then on day 4 we shift it to oral steroids. So we start with the dose of 0.75 mg per kg body weight, so that is approximately 40 mg. So that 40 mg dose is given for 1 month, and then over the next 2 months you have to taper it and stop it. You do not have to continue steroids beyond 3 months. If beyond 3 months you are finding that the patient has become steroid dependent, the moment you are getting down the dose or the patient relapses after stopping steroids, it means that you have to go on a maintenance therapy with immunomodulators or start biologicals in this patient. 5 ASA is started at discharge along with oral steroids and continued throughout. Sir, enemas are for local therapy. So for patients with proctitis, local therapy is better than oral therapy. But for left-sided colitis and pancolitis, oral therapy is better. Local therapy can give them some relief in the diarrheal frequency. Yes.
Then by doing the fecal calprotectin, it comes to be negative. So can I rule out ulcerative colitis? There is no need of any colonoscopy in this patient? Fecal calprotectin negative in the patient of the suspicion of ulcerative colitis.
Sir, we should not have fecal calprotectin negative in a patient with ulcerative colitis if he has inflammation.
No. Yeah, that's what I'm telling.
Huh.
Patient is having, I am doubt whether ulcerative colitis, should I get the colonoscopy done or should I not get it done? Patient is not cooperating because of colonoscopy, you know, in the clinical practice. So by getting, I get the fecal calprotectin is negative. So can I rule out ulcerative colitis in this patient?
In a patient with GI bleed, sir, I will go ahead with endoscopy and colonoscopy. I will not check for fecal calprotectin in a GI bleed patient. I will check for calprotectin only if there is a patient who comes to me in the clinic and has symptoms which I am confused is IBS or IBD. Or then I will do calprotectin to see whether I need to do colonoscopy in this patient or not.
No,
Then
this comes in a quantitative titration. So either 50, 60, negative, positive report नहीं आती sir इसकी. This is in titers. So there is no diagnostic.
Sir, if the cutoff of fecal calprotectin is 50, but the studies say that if it's more than 100, then you should go for colonoscopy. Sir, to be continued. At the to be continued.
Along with these drugs?
Yeah.
Along with these drugs, yes.
They are
to
the
be
principal
continued.
maintenance medicines. They are the primary maintenance medicine. We
Dr.
can
Neha,
take the last question by...
yes, sir, one question. From the perspective of the gastroenterologist, message for the internal medicine people, unbiased opinion, when should the patient be referred to the gastroenterologist and when the gastroenterologist should refer it back to the primary internal medicine person? Unbiased, please.
Okay, sir. Acute severe ulcerative colitis, refer to gastroenterologist. That is first thing. Second, in your practice, if you have given mesocol and you have given steroids and the patient is still having relapses, refer the patient because it means he needs a higher therapy. If on follow-up you have given mesocol steroids, after 6 months you do a repeat endoscopy and you find that still disease activity more than 4, refer to a gastroenterologist. It means escalation of therapy is required. If you find a lesion, you find a polyp, something dysplastic on your colonoscopy, refer the patient. So that is the thing. Acha, back. Yes.
When the
So
patient
I'm
should be
saying you refer.
referred back to the internal medicine person by the gastroenterologist.
After colonoscopy, sir. Immediately.
So that's a very difficult question, sir. But yes, once the patient, we know that the stools are stable, there is no bleeding, we refer back so that it can be managed on OPD basis.
We have gastroenterology in one area. It's better to give them the case. They will manage better than us, I think. There are lots of people there.
Chalne dijiye, sir. Bilkul, you can decrease the dose.
Thank you.
Sir, I'll discuss with you regarding TOFA after this.
Thank you, Dr.
Thank
Neha,
you.
for incredibly overview of ulcerative colitis. Thank you so much.
I request the dignitaries on the dais to proceed for felicitation. I request Dr. Vimal Nakra sir to proceed for the felicitations. For our panel discussion on GERD, I would like to call on stage Dr. Vibhu Mittal, Dr. Anupam Prakash, Dr. Paras Gangwal, Dr. Naresh Dang, and Dr. Neha Berry. Ma'am, after the felicitation, I think you may come back.
Good afternoon. And this is a clinical discussion, and apart from the discussants and myself, we also invite every one of you to put your comments in between the sessions and ask questions, because there will be no questions after the session. This will be a discussion between all of you and the discussants. And Dr. Neha Berry will be joining after the felicitations. And these are our esteemed discussants. They are all too experienced and at the height of their career and experience. So we would like to take the experience and advantage. And we'll be discussing on GERD because there are a lot of changes and protocols in the treatment of GERD. First, because this is one of the most common conditions that comes to either gastroenterologist or physicians for that matter. And everybody will witness this, that at least 30-40% of their OPD will consist of patients having upper abdominal symptoms or retrosternal symptoms. And not only this, but this leads to such significant complications that can hamper the quality of life of the patient badly. Dr. Neha, please join us. And these will be small heads that will be going over our discussion. Various abdominal symptoms that are aimed in the treatment of GERD and dyspepsia for that matter are discomfort, upper abdomen. The Western literature describes this as discomfort or heaviness, and Indian patients usually tell you that I have a lot of gas or bloating, fullness. This is a terminology that we have to interpret in form of a discomfort or heaviness or fullness after meals. Burning in the epigastric area or retrosternal area, particularly after meals. Nausea, regurgitation. Patient has regurgitation, water brush in the mouth, nausea, vomiting, and frequent wakes up after sleep, heartburn, pain upper abdomen, chest tightness, sometimes mimicking angina, and cough. All of these are usually brought about by 3 diseases. One is dyspepsia, we usually call as functional dyspepsia. One is GERD, and one is peptic ulcer disease. So when we treat our patients of GERD, which this group discussion is aimed at, The first thing that I find relevant is to differentiate between dyspepsia and GERD. So, mind you that we are not discussing dyspepsia in this discussion, we are discussing GERD, and from Dr. Vibhu we would like to know what should we see first, that patient is suffering from dyspepsia or GERD?
So, yes, so it is a clinical discussion.
Yes,
in the OPD, if the patient has symptoms of retroesternal burning, regurgitation and maybe chest pain, non-cardiac chest pain, these are classical symptoms of GERD. While for dyspepsia, it would be upper abdominal discomfort, fullness, post-meal fullness, below your sternum. So that is dyspepsia. But then there is a lot of overlap.
Yes.
How do patient explain it to you? How do you interpret those findings? Roughly 30 to 40% overlap would be there. And if there is a significant neuropsychiatric involvement, there will be chances of combination of these two things.
Yeah, that is true, because dyspepsia, regurgitation and heartburn are two cardinal symptoms that will indicate that the patient may have GERD. And upper abdominal discomfort and heaviness after meals will be usually in dyspepsia, barring there are some alarming symptoms or not, but these are two categories, and we should first, at the first sight, differentiate between the patient's symptoms, that patient is suffering from GERD or not. And reflux, regurgitation and heartburn are two cardinal symptoms. And Dr. Vibhu, what may be the definition of GERD? The ACG has laid definition of GERD, that patient is having clinical definition of GERD.
So the definition-wise GERD is stomach or duodenal contents which are refluxing into the esophagus causing the symptoms. The symptoms can be esophageal or the primary typical symptoms, or it can be an extraesophageal symptoms which is not classical, like laryngeal symptoms, asthma, globus, etc.
Right. So reflux of gastric and duodenal contents in the esophagus, and we would like to share in this hall that we usually call acid reflux, and this is interesting to know that most of the refluxate is non-acid actually. So whatever we are treating patients of GERD, the acid reflux is not the culprit in most of the cases. It is the important part, and PPI are still the preferred treatment for non-acid reflux, but non-acid reflux is more important than acid reflux. So this is reflux as a whole that we are going to treat. So Dr. Anupam, what may be the pathophysiology, that why reflux happens, and what can we aim for our treatment, the corrective factors, anatomical factors?
Well, thank you. As Dr. Vibhu rightly said, the gastroesophageal reflux, so there has to be a reflux, that RGER, gastroesophageal reflux is the key word. And the reflux occurs through the lower esophageal sphincter. So any laxicity of the lower esophageal sphincter, which obviously can be compounded even in normal individuals by a raised intra-abdominal pressure, actually results in reflux. So the gastric contents will reflux back, it is REFLUX, reflux back into the esophagus. That is what is gastroesophageal reflux. So that is what has to be taken care of. So that it could be a lax sphincter, could be a number of reasons, and primarily physiological, it is usually when it is maybe pregnancy or obesity, and pathological, it becomes with mucosal changes, as Dr. Vibhu rightly said, and you need to intervene in those conditions. In fact, nocturnal esophageal reflux is normal in most of us, that occurs, but it is usually asymptomatic. Once it becomes symptomatic, then that definitely it indicates that there is a problem, the gastritis is much worse, the esophagitis is much worse, and we need to take care of it. In fact, even at times dental surgeons will, when expecting the mouth,
dental
they will
caries
say,
and cough,
molars are actually getting eroded. So that is also a sign. So asymptomatic reflux at times will be very common.
So that is true. After differentiating between dyspepsia and GERD, we have to first differentiate between physiological and pathological reflux. Physiological reflux happens in obesity, pregnancy, or some overeating, and pathological is unprovoked and usually happens because of abnormality of LES. So this case, which we are going to take a hypothetical case, which is a middle-aged male patient having reflux symptoms, more so in winters, for last more than 1 month. His weight is 76 with a medium height, and other tests are unremarkable. So Dr. Naresh Dang, sir, what may be the probable diagnosis clinically, and how should we head on?
for the
So
treatment.
this patient has symptoms of epigastric discomfort and, heartburn, burning sensation in the chest. So obviously there is some regurgitation of acid or the gastric contents. And that is the hallmark of GERD basically. Then difficulty in swallowing, that is odinophagia can be there. Sometimes severe esophageal symptom, patients have severe retrosternal burning and the differential diagnosis of angina is there. So sometimes we also do an electrocardiogram to rule out angina in these GERD patients. Then some of them will have, extra esophageal symptoms such as laryngitis, spasm, bronchospasm if they are having excretions and they're, going into the bronchi. So all these things have to be kept in mind. And sometimes chronic cough. I mean, you keep treating with antitussives and other things and patient is not getting relieved. You give him PPIs or other neurogents and the cough disappears. So we have to keep all this in mind.
Yeah, that is true. A lot of patients, you will agree that many patients are referred to a gastroenterologist from pulmonologists. That they are not finding any cause of their cough, particularly dry cough, and in the night hours. Dental caries, laryngitis, hoarseness, particularly teachers, they suffer from reflux-related laryngitis so early because they are already stressed out in their terms of their laryngeal trauma. So, Dr. Paras, you have switched on your mic, sir.
Yes.
So, I'm
ready.
So, after we have a clinical diagnosis in our hands, then what should we suggest that what are the factors that patient should avoid can increase the reflux, although we'll go to the medical treatment? What are the foods?
So already Anupam has highlighted what causes reflux. So we have things like food item, either they relax, they are the relaxants, they relax the lower esophageal sphincters like caffeine and alcohol. They are the relaxants, they relax the lower esophageal sphincters, so the food comes up easily. And then we have foods which are irritants, like spicy food like lemon, and the spices that we eat. They are direct irritant to already ulcerated mucosa. So they belong to two categories, one the relaxants and one the irritants. We have certain medications which are irritant, like biphosphonates that we prescribe. That's why when we pop in them, we say always take empty stomach in standing position so that it just goes in and do not lie down. So those are the categories that we need to understand. Then there are physiological mechanism. That means you are khana khaya or late gaye. Within 3 hours you lie down, the stomach is all full and it burps upwards, which is all anatomy and physiology working. I mean, it's the gravity which is working.
Yes.
And then you have the situations like obesity, pregnancy, your constipation where your intra-abdominal pressure is increased. So these are the things which cause the GERD to happen.
So
and then the new drugs, which we should not forget. The whole conference is about these newer drugs, taking care of your obesities.
Yes.
They are the one important cause that
GI
you are giving GERD to your patients now. Almost 40% have GERD with that.
So anything, either medicine or food substances, which is irritant to stomach mucosa, esophageal mucosa, or relaxant, or inhibition of the gastric motility, will lead to higher reflux. So, Dr. Neha, how can we approach to the diagnosis, and when should we do, and which test should we do in this scenario?
So, sir, in a patient who has typical GRD symptoms of regurgitation and heartburn, I would first go for an empirical PPI trial in these patients. So, you give them a PPI medicine once a day for 3 months and you observe how their symptoms have improved or not. On the other hand, if a patient who has got extra esophageal or atypical GRD symptoms, like they are having coughing or they are having a hoarseness of voice or they have any alarm symptoms, like they have a GI bleed, a weight loss or a persistent pain abdomen or any dysphagia, then you have to directly investigate these patients. So the first choice of test in these patients is what we do as an endoscopy. So on endoscopy, what we want to see is that if the patient has any hiatus hernia and if the patient has any evidence of an esophagitis. So on esophagitis, you can classify it into 4 types of esophagitis. the classification B, C and D is very typical of GRD. So once you have a LA grade B esophagitis B, C and D, you can label them as GRD and then you can start them on PPI therapy, which we can start at a double daily dose. For patients with extra esophageal symptoms, even if endoscopy is normal, then you have to go for reflux testing. So the reflux testing is a 24-hour pH ambulatory testing that we do, where we check for any acid or volume reflux in these patients. So
Right.
this is how I place these two tests. The third is a manometry test. It is not for diagnosis of GRD, but it is to rule out other causes like echalasia or anything which is predisposing to GRD, like a ineffective esophageal motility.
Right, thank you, Dr. Neha. So endoscopy, pH metry and manometry are the mainstay of diagnosis when patient is not responding to PPIs or having alarm symptoms. So Dr. Anupam Prakash, in your practice, when would you like to refer a patient of suspected GRD to a gastroenterologist for endoscopy?
Well, the question has partly been answered by
Yes.
Dr. Neha, and I will just add to it. See, number one, if you have alarm symptoms. Number two, if you have refractory, as she already said, we usually give a trial. And number three, if you are suspecting a coexistent illness.
Yes.
So alarm symptoms, she said, the last talk also by her, if you have a bleeding per rectum, that is one cause. If you have hematemesis melena, or you have weight loss.
Alarm
because
symptoms,
yes, weight loss and anorexia, they are two things which should not be there, that you can suspect malignancy. If you have coexistent disorder, if you say that patient has significant hiatus hernia, because that will also worsen, that is important. And
Refractory symptoms, yes. And one more important is recent onset severe GERD in patients of more than 40 years of age.
Symptoms in a stable patient. Yes.
So, Dr. Vibhu, so in this discussion, this is important to discuss about pH metry, which is now widely becoming more and more available, which is an integral part of treatment of GERD. Dr. Vibhu, just in short about what is pH metry and how does it help?
So again, Dr. Neha talked about it just a minute back. But we had a diagnosis, when we talked about the definition of GERD, we talked about gastric and duodenal contents refluxing back.
Yes.
So pH metry with impedance metry is something which proves this diagnosis, this definition. It has two components. One is the pH, which is monitored in the esophagus.
Acid reflux.
At least for 24 hours.
Yes.
There are now capsules available and you can monitor them for 72 to 96 hours as well. So 24-hour pH is monitored and the absolute esophageal
impedance.
pH of less than 4 percent is important. Acid exposure time of less than 4 is important. Next is with impedance you can also measure the non-acid refluxants. So it's not just the acid but any kind of reflux which can be measured now and is the gold standard of making a diagnosis of
non-acid reflux.
GERD.
So
can
pH
I just
metry,
add on?
can
I just add on? There is always a question whether pH testing should be done on PPI or off PPI.
Yes.
So if you have to make a diagnosis of GRD when patients who do not have any esophagitis or that have extra esophageal symptoms, you do pH studies off PPI.
Off PPI, yes.
So you have to stop PPI for at least 1 week and then do the pH testing. But in a patient with refractory GRD who's already on PPI and still symptomatic, then you have to do pH study on PPI.
And this pH metry will tell you about two important things. One is whether patient is having reflux or not. Second, patient is having acid reflux or non-acid reflux. Third, this will tell you, the software will calculate for you that patient's symptoms are related to reflux or not. Some patients may have symptoms unrelated to reflux and vice versa. So this pH metry will address this issue. So I will just skip the lifestyle changes. Dr. Paras, just a few words about lifestyle changes, because if we skip in presence of you, then that is not.
So the lifestyle changes which are to be recommended to the patient is थोड़ा खाएं, एक साथ ज़्यादा ना खाएं, रात का खाना सोने से 3 घंटे पहले खाएं, रात को सोते वक्त ऐसी करवट में लेटें कि पेट का जो ग्रेटर कर्वेचर है वो नीचे बेड की तरफ आ जाए. That means left lateral,
yeah.
That maths and science needs to be applied to the patient, and then raise the head end of the bed by 7 to 8 inches. 7 to 8 inches would mean 7 to 8 inches. And yes, very important, गंदी आदतें छोड़ दें.
कितने
अल्कोहल, टोबैको छोड़ दें. और जो कॉन्फ्रेंस में वो जो 2 काउंटर होते हैं ना, एक स्टार्टिंग काउंटर और एक फिनिशिंग काउंटर, वहाँ पे थोड़ा रेस्ट्रेन अप्लाई करें. बिकॉज एक जगह अल्कोहल स्पाइसेस बढ़ता है और दूसरी जगह स्वीट कॉर्नर है. सो बोथ दोज कॉर्नर्स आर टू बी टेकन केयर.
डॉक्टर पारस, कितने मील लेने चाहिए पर डे?
कितने मील? वो 3+3, और it depends. If you are OMAD of intermittent fasting, it would be 1 meal a day. It depends what philosophy and what science are you applying. So it has to be calorie appropriate, macronutrient appropriate, micronutrient appropriate, and the number of meals would depend what principles are using. If you're using intermittent fasting, it can be 2 meals a day, it can be 1 meal a day also, but then there are a lot of, it would be part of the next, we already time is up.
So small frequent meals, but calorie restricted, don't take
Calories, yeah. The calorie can be. Yes, sir.
Patient with typical heartburn, with nothing, but associated is got profuse sweating. What do you think first?
Sir, obviously, personally, I would like to rule out cardiac disease, and but there may not be cardiac disease in such symptom because it may be vasovagal also.
It's always a confusing picture.
Yes, sir.
ECG in majority of cases normal.
Yes, sir.
सर गर्ड में आदमी मरेगा नहीं, दिल में मर जाएगा, तो बेटर है ईसीजी करवा लें. कार्डियक वर्कअप हैज टू बी कंप्लीट व्हेन देयर इज प्रोफ्यूज स्वेटिंग. मतलब आदमी की जब जान जाती है तभी प्रोफ्यूज स्वेटिंग होती है. दैट्स द बेसिक प्रिंसिपल.
Observation, admission, property.
Sir, we would like to ask you that what cardiac investigations are appropriate to rule out cardiac disease in such patients? That is for acute
and trending. Most important is trending. It has to be trended. Everything has to be trended in life.
Yes.
Where is it settling?
Yes, right, sir.
I've seen patient normal today, in 24 hours everything comes out with positive.
Yes, sir. That's true, sir. Dr. Paras, one more thing. We are skipping the onset of PPIs and all that. Everybody knows PPI is the mainstay of treatment. How long the PPI can be continued in, and how do you continue for how long in your patients?
So it depends. That's why it's very important. The GERD in your patient is because of his mental illness, or is it because of the irritant food that he takes? Is it because of the relaxants that he takes? Is he
No,
sleep?
we are talking of.
That's what I'm saying. The duration would be decided by certain things. What is the cause of the GERD? So the root cause analysis of
Yes.
GERD has to be done.
Yes.
Once you have done and made a diagnosis of GERD, that means it would be, if pure APD kind of scenario, then it will be 4 to 6 weeks.
Yes.
If it is non-erosive reflux disease, that is NERD, then it is 8 weeks, and then it is on-demand prescription.
SOS.
After 8 weeks, it's on-demand. And if it is a territory which belongs to our gastroenterology colleagues, then it can be lifelong.
Right, sir. Dr. Dang, sir, in short, we are running out of time. Just a short overview about PCABs that are now available.
So PCABs are potassium, and channel.
Potassium
they
channel.
affect hydrogen,
Yes.
potassium ATPase channels. They are PPIs. They have quick onset of action, and they have action for 24 hours. PPIs need acidic medium for action, while PCABs don't need acidic medium. So they will act in all pH. So they are a very good, very effective drug. And when PPIs are not working, then they are the drug which you can try, and they will probably work. And once a day is enough. Vonoprazone 20 or 40 mg. And there is one more salt that has come recently. Yeah, tegoprazole.
So they are better efficacious and can be better compliance to the patient and better for H. pylori eradication. There are now randomized trials that they are better in terms of eradication of H. pylori. So Dr. Neha Beri, we can take the last question because we are skipping some of the slides. The endoscopic treatment, can they obviate the need of ongoing PPI in patients of GERD? That is the main question.
So refractory patients who are PPI dependent and they are not able to stop their PPIs can be considered for endoscopic or surgical options. So which are the endoscopic options? Earlier we used to have RFA strata, we used to have magnetosphincter augmentation. Now what we do is an endoscopic fundoplication with Gerdex, and we can do anti-reflux mucosal ablation where you retrovert, ablate the mucosa, and when there is a fibrosis, then there is helps to decrease the lower esophageal sphincter relaxations and other things. What we are doing mostly in our practice is GERD-X and ARMA. So, but we need to identify our patients. So, patients who have grade A or B esophagitis, small hiatus hernia less than 2 centimeter in size are the candidates for this procedure. Large hiatus hernia, severe esophagitis, consider surgical fundoplication and not endoscopic.
Thank you.
One thing, also don't forget sucralfate and alginates and
collaborative therapies.
They also have a role locally, they do help.
Yeah, Dr. Vibhu, at last, one single most important complication of GERD that you have experienced and what may be the treatment of that?
So strictures,
Strictures
benign
and
strictures are one
Barrett's,
thing, and
yes.
then Barrett's, which
Barrett's,
is a
yes.
pre-malignant condition also, which requires repeated surveillance and maybe treatment with RFA or continued therapy also. Again, you don't talk about stopping PPIs in such situations.
Yes, yes. So Barrett's is pre-neoplastic, that is most important complication. So carry home, PCAPs and PPIs are the front runners, but carefully they should not be prolonged too much because many patients are psychologically dependent on PPIs, and there are now ideas that we can obviate the need of ongoing PPI therapy. Duration usually after the diagnosis and maintenance phase is up to 2 to 3 months. Somatic overlay has to be identified because patient can be switched on to the anti-anxiety or antidepressants. Thank you so much.
Just a small addition about the role of PPI, prolonged PPI, which patients so often take. It's like a and so we push the patients for hypomagnesemia, osteoporosis, CKD. So many things are now well known, established of a long-term use of PPI,
yes,
which unfortunately is not discussed, but I think we should be making patients aware about all this.
Yes.
No, sir. The evidence is not for the CKD. Evidence is not for the dementia. It's only an associative correlation. It's not a causative correlation. One, the only thing which has been documented is B12 deficiency and the magnesium deficiency. It has to be also highlighted that the correlation with dementia and renal dysfunction or the renal disease is not causative. It's more associative.
I'm happy that you have at least counteracted. Someone is listening.
But still, acid suppressive therapy are best minimized.
Yes, but there has to be a warning to the patient that these can lead to these.
So if the patient needs it, like in Barrett's, it would continue. If the patient does not need it, get a pH metry, ensure that the patient needs it, and then only give it.
Yes.
So the root cause analysis: yoga, meditation, pranayam, ahar, vyavahar, suvichar, sunidra, all need to be taken care of.
Next oration by Dr. Paras Gangwal.
I request the dignitaries on the stage to proceed towards the felicitation area. I request Dr. B.K. Tiwari sir for the felicitation. For the next session, I would like to call on stage our respected chairpersons, Dr. Vimal Nakra, Dr. Aman Rohatgi, and Dr. S. Chakravarti. I would like to invite our speaker, Dr. Mohanshi Sahu.
I think we can start with the next session without wasting much time. Dr. Rohatgi has to introduce the...
Thank you. Our next speaker is Dr. Mohanshi Sahu. Dr. Mohanshi Sahu is an endocrinologist at Max Med Center, Panchil, and he has his own clinic, Dr. Sahu's Hormone and Diabetes Center. Over to you, Dr. Mohanshi.
Thank you so much, respected chairpersons. And thank you for the organizers to just plug in this aspect of one molecule with an endless impact. So they're just not leaving any room for any doubt. We are talking about semaglutide, and therefore this my conflict of interest today, not with the contents of the presentation, but my conflicts on the financial aspects. Well, when we are talking about a molecule, we know how all the gut hormones, since we talked about gut, we are now talking about gut hormones. I equally am acknowledging the fact that there has been a kind of a masterclass in obesity, so there has been a lot of talk and data sets presentations related to semaglutide, tirzepatide, the SUSTAIN studies, as well as the SURPASS studies. Why do we have to now re-emphasize on the fact that there's an endless impact? Because of key reasons that A, Ozempic, which is the only injectable semaglutide that is now available for an approval of type 2 diabetes, is now got an approval in India. So that is the entire context of today's presentation. When we talk about diabetes, we need to understand it's certainly not an isolated disease. We are talking about, when we talk about diabetes, even in the context of a normal BMI, we also need to acknowledge the fact about the ectopic fat deposition. I will not be surprised that if roughly around a decade from now, rather than talking about type 2 diabetes, we are talking about an ectopic fat deposition disorders. And this is where the gut hormones really have embarked upon it and impacted upon it a kind of a lot of key clinical data outcomes. When we talk about just a molecule, that is a semaglutide, the fact is we are talking about a gut hormone, and that is a GLP. We understand there's a GLP, there's a lot of talk about a GIP. The basic gut hormone, which typically really leads to a lot of impact upon the pancreatic beta cells, is a glucagon-like peptide. Who would have thought so many years back that an agent which has got the term glucagon embedded into that peptide, there's a pro-glucagon which is actually pro-peptide. Who would have thought that this, at one point of time, we would be talking about a management in the setting of a type 2 diabetes mellitus. But the whole action is what happens when the GLP-1 gets activated in terms of the receptor activation. The overall half-life is of course 7 days, and that is what that has led to a kind of a once weekly daily dosing. And before we talk about anything related to GLP, since we are talking about the molecule, first of all, in terms of the story of the molecule, everything started in 1980s. The entire research aspects of GLP as such as a hormone. And we are talking about from 2025. So look at the journey in which it has really evolved in the landscape. We all understand what is the limitation of GLP-1, and that is a rapid DPP-4 inactivation. There's a degradation. And there's also a small peptide, for the reason of which there is a faster renal clearance. So most of the pharmaceuticals, they have really done this chemical engineering of the semaglutide. How do they do that? First, find out something in which, if you see the lower panel of the semaglutide, just substitute an amino acid to something which is not biodegradable, and therefore it will be really resistant to the DPP-4 degradation. And the second way in which everybody prolongs the half-life, even if you talk about a tirzepatide or a semaglutide, is that add a fatty acid moiety to the peptide. So as an example here, it is a C18 fatty acid. At tirzepatide, it's a C20 fatty acid. And everything is different in terms of conferring the activities, and that's how the overall half-life typically increases to around once in a week, and it's resistant to the DPP-4. That is all called as a peptide engineering. When we also talk about a molecule per se, since the topic is a molecule, and what exactly is the key attributes of the molecule, I mean, yes, of course, for today, we are so very flamboyant, if I may say, of using a semaglutide or a tirzepatide for each of our diabetic and an obesity individuals. But we should not let loose of the fact that there has been a lot of journey of each one, and here what is being showcased is a semaglutide journey. In terms of 2008, when the target was identified, 2015 when the molecule was discovered, almost going to the phase 1, all these studies has been done with the phase 2. When we are talking about just using a semaglutide like 0.25, 0.5 and a 1 milligram, we ought to understand these were the key subsets of the dosages which was used in the setting of the phase 2 clinical trial in terms of the dose finding range studies also. And finally, as we sit here, we can at least boast about the fact that the semaglutide as such as a molecule has got a lot of trial data related to SUSTAIN, where a CV outcome trial data has got superiority in terms of the data set, and including the flow trial, which of course is a part of a GLP-1 that is related to semaglutide, which did talk about that in the setting of an ESRD, in the setting of an eGFR that is up to around 25, with a micro and a macroalbuminuria, so overall major adverse kidney outcome events was favorable. Now, let's dive deeper into the semaglutide as such. I'm sorry for using the Ozempic as the name, because that's the only available brand name out here till the patent expires. Well, when we talk about the robust clinical development, you have the data set related to in comparison to placebo, in comparison to active comparator. We also have data set related to, in the terms of a CV outcome data set, in terms of the flow, as you can go down the slide, it's on the renovascular related landscape. And then there is a stride data set also in the setting of a peripheral artery diseases. That is, you use a semaglutide in the setting of a peripheral artery diseases, the overall claudication distance typically reduces. So the distance actually increases, the time for the kind of a pain to occur, it actually improves upon in terms of uses of semaglutide. So these are the data sets that's available. I'm slipping through the slides just to help us understand that yes, there's a lot of development program that has been done, including the fact, if I can draw your attention to Sustain 7, which would be a bit of a focus of the presentations out here, is that, and this semaglutide, when the journey started, there was no tirzepatide, there was no retatrutide, there was no kind of an amylin related in terms of the so-called to be comparison to be done. So therefore, it was very logical that you find here a semaglutide of a 0.5 and 1 milligram, which are the clinical efficacious dose, which is compared to tulaglutide of 0.75 and a 1.5 milligram, which is again a clinical efficacious doses as well. And before diving deeper into the slide deck, in terms of the data set, the approval as per the prescribing information has been put forward is that Ozempic, that is an injectable semaglutide up to 1 milligram. The differentiation is that, as you all know, Wegovy is the weight lowering dosages. So if you talk about Ozempic, if you talk about injectable semaglutide up to 1 milligram, it has obtained an approval to as an adjunct to diet and exercise, which means even as a first line therapy as well. Now that we can debate at what exactly is the first line therapy, that's a different context. The second is it also has an approval to reduce the risk of a major adverse cardiovascular events. Again, all of us are talking about in the setting of a type 2 diabetes mellitus. And finally, in terms of even in the setting of a type 2 diabetes mellitus, as an approval, as a label approval from an FDA, from DCA, in terms of reduce the risk of a sustained eGFR decline and the end stage kidney diseases. So, is it compelling enough to actually understand of Ozempic or a semaglutide as a first line therapy? Well, first thing first, it is anti-diabetic medications. When we use this kind of a phrase as an anti-hyperglycemic medication, the fact is, the question that comes is that what exactly is a kind of an HbA1c reduction by the numbers? Well, if an HbA1c is more than 9%, it could be even up to 2.5% reduction. That's very robust. So robust that some of the guidelines actually has included the fact that since because of the insulin inertia, before even the insulin, a GLP-1 is a proposed therapy in the setting of a type 2 diabetes management. Okay, now this is what on the very busy slide deck you are seeing that across the sustained studies of semaglutide 0.51 milligram being compared with canagliflozin of an SGLT2 inhibitors, with a kind of a DPP4 inhibitor, with a GLP-1 receptor agonist such as dulaglutide as well as liraglutide. Let's just focus on the middle box. And that is a simple question that what happened on giving a semaglutide versus a dulaglutide of a 1.5 milligram. Dulaglutide, by the way, has got a data set with a rewind trial that is very cardiovascular safe as well, and dulaglutide as a kind of a very efficacious agent. Now here if you see even the HbA1c reduction, just focus on the mid bars. A semaglutide at 1.0 milligram. We are not talking about 1.7 and a 2.4, which are the weight lowering efficacies, which can be given even to patients who are not diabetic. We are talking about semaglutide up to 1 milligram, which is approved for in the setting of diabetes. Even in semaglutide, you have got an HbA1c reduction to the tune of minus 1.8%, and that's very, very potent as compared to insulin. Now we talk about from an overall a very powerful glycemic control, just slipping through the slides very fast. Is there a compelling evidence related to weight loss? The answer is again a yes. And even to compare the weight loss strategies, let me think about what did the pivotal registration trial data did really give us the data set. Again, focus on the mid part of semaglutide versus dulaglutide. Out here you see that dulaglutide 1.5 milligram, if the weight loss was to the mean of around minus 3 kgs, with a 1 milligram it is minus 6.5. Now, I generally, when patients come to me and say that, doctor, what exactly is the weight percentages? So typically, thanks to my nutritionist counselor and a diabetes educator, we have figured it out how to explain, and you can also understand by the mnemonics. It's like that kind of a start from 90, then go to 70, then go to 50, then go to 30. It's like every 20. And what I mean by this is that at least a 5% of weight loss happens in 90% of individuals. At least around 10% of weight loss will happen roughly to around 70% of individuals. This actual data set is 69 point something. At least around 15% of weight loss will happen to 50% of individuals who are taking the semaglutide on the higher dose. And close to around 30% may lose even up to 20% of weight loss. So that's the kind of a way of an explanation. And this is more of a ubiquitous with tirzepatide, of course, because it also acts on the kind of a dual agonism. There's a bit of an extra weight loss which all of us are aware about it. The important question sometimes comes is that if one is losing weight, is there a lot of lean muscle mass loss? Because we have all heard about that Ozempic phases, etc. Well, the fact is that in any weight loss, 3/4 of that weight loss would always be a fat mass weight loss, and 1/4 would be a muscle mass weight loss. That's a well-known thing even in the kind of a dietary intervention trials as well. And therefore, sometimes if there's an overall weight loss, and if the proportion of a fat loss with whatever agent, and this is a data set where semaglutide was compared with SGLT2 inhibitors, it was found that with semaglutide, the overall fat loss is higher as compared to the lean muscle mass loss. And if you see the overall proportion of the percentages of the lean mass, it actually moves up. So therefore, the lean muscle mass loss is, while it is important and therefore the nutritional component is exceptionally important to be discussed about the patient, but it is true for almost every weight loss regimen. It's endorsed by AD as a very high efficacious drug. A final take, apart from talking about a good glycemic power of glycemic control, power of weight loss, the fact is about the cardiorenal protection. And again, this must have been dozens of seminars and presentations. The fact is that semaglutide, both with oral, that is, which is available in India, as well as injectable, with the SOUL trial, as well as the SUSTAIN 6 trial, and this is about the injectable SUSTAIN 6 trial, there was a 26% risk of the 3-point MACE, the CV death, the non-fatal MI, and the non-fatal stroke. And interestingly enough, and this was a kind of a database from the US database, very recently published in the ESST poster in September 2025, where semaglutide for 1 year was compared with versus dulaglutide for 1 year. And let's be mindful of the fact that dulaglutide as such, thanks to the REWIND trial, is a very potent. In fact, tirzepatide also was compared with one of the SURPASS CVOT trial with context with the dulaglutide. So dulaglutide is also benchmark. Interestingly, in comparison with semaglutide versus a dulaglutide, what you find here is that there's a further 23% risk reduction in the 3-point MACE versus dulaglutide in a real-world evidence, and a 26% reduction in the all-cause death versus dulaglutide. It just substantiates that the question that the authors had asked even in the ESSD poster is that, is there actually a class effect or is it something related to a kind of a very specific to semaglutide, only time will tell. The next set related to the renovascular outcomes, the answer is again related to flow trial, not diving deeper into it, but the fact is there are evidences around it. And the entire trial included patients up to an eGFR up to 25. So just let's keep that in mind. Final take about the art of medicine. I just heard Dr. Gangwal speaking that eat less and chota khao or thoda sa lamba dheere dheere chaba karke khao. And these are actually important how to reduce the gastrointestinal side effect. One thing as a caution is that sometimes all those classical prokinetics does not help in the setting of, or in pantoprazole does not help in the setting of a GI disturbances. Most of the adverse event actions are central in origin. So sometimes if you find a patient with semaglutide or any GLP-1 having a kind of an incessant nausea or vomiting, it is ondansetron that typically helps to tide over those things, not the classical pantoprazole. So just again keep that in mind. The second thing is, got a minute. The second thing is in terms of most of the adverse events are mild in nature and very few are severe, but we ought to understand that there's an adverse event. Final important take, because there's a lot of thing going around related to diabetic retinopathy. It's not a GLP-1, it was only seen in SUSTAIN 6 where there was a rapid improvement of the glycemic control. But what is important is to understand about something devastating, and this is true for every GLP-1. There's a concept called as a non-arteritic anterior ischemic optic neuropathy, which is exceptionally rare. Everybody is looking around it. The whole adage right now is that it does not appear to be causative. For that matter, NION can even happen with sildenafil, phosphodiesterase inhibitor. It can happen even with amiodarone as well. So in the setting of type 2 diabetes mellitus, if there is a monoocular loss of vision, immediately stop it, go for a retinal evaluation and don't ever restart it, is always what I say. There is an ongoing trial related to focus RCT. The dosing is very convenient. You start with 0.25 and every 4 weekly increase to 0.5 to 1. If I have to just sum it up, everything thanks to the time is up, that if there's one thing that the GLP-1 as a class have taught us, and which is teaching me, is that make sure that even before starting a GLP-1, just read the last line which I've written it, that please do a retinal screening for everybody. We ought to do it for all our diabetic patients, which we are not doing it. In the setting of a GLP-1, you must do a kind of a retina screening, and just be cautious about any progression of a retinopathy. On that note, thank you very much, sir.
Thank you, Dr. Monashish. So, Wegovy and Ozempic, they both contain semaglutide. Ozempic came out first for the treatment of diabetes in 2017. Ozempic came out, Wegovy came out later in 2021 for weight loss again. So what is the rationale for, once we have Wegovy in the market, what is the rationale for launching Ozempic again when both can do the same things and we have the similar schedule? Is it a kind of a thing that the company is trying to cash on the Ozempic name because the patent goes, this thing goes off patent in March?
Yeah, that's for the company to answer, but all I can also state is that it was more of a kind of a, if to whatever I've understood about it, any approval of a medications at India would be based on whatever trial data you have from an Indian context as well. Interestingly, most of the initial trials of Ozempic, which was in the setting of a type 2 diabetes mellitus, interesting, it was Wegovy, which had a lot of clinical trials in India, which got an early approval. And then it is not so much of a company strategy, I think it is more of a regulatory perspective. And the approval for type 2 diabetes was actually given later. So it's nothing from a company context. As about the company catching up to the Ozempic, which is a term which you have rightly pointed out, has actually essentially put into wildfire into the internet. Maybe yes, I don't know, it's for the company to answer that. Also as a subset to your question as to where to use a Wegovy and where to use an Ozempic, it's the same semaglutide, but let's be mindful about few important aspects, even from our aspect of an approval from a DCGI context. Wegovy as such is approved for obesity. That's where the clinical trial is. In terms of Ozempic, it is diabetes. You have an added benefit, of course, of a weight benefit with the context of Ozempic, everybody understands. For the approval for Ozempic, because the approval for any country would always depend on what are the trial population that you're taken in. Up to 1.0 milligram is what was seen with diabetes, so you got an approval for diabetes. With a Wegovy, which goes up to 1.7 and a 2.4, that is where the approval is in the setting of an obesity, that is a BMI of more than 30, or a BMI which is more than 27 with any other added risk factors, diabetes one of them, hypertension another one, and a dyslipidemia the other one. Yeah. Thank you so much.
So,
thank you for that. That was an amazing talk. I'm a neurologist. I don't understand much. So one question.
Did you say you're a neurologist?
Yeah, I'm a neurologist. So see, the thing is that, we have both semaglutide as tirzepatide, both injectables. So in a given patient who has diabetes and obesity, which is the one your first choice would be? Which of them?
Okay, very absolutely challenging to answer that. I still am unable to figure it out, which is a patient where I can use a glimepiride versus gliclazide, and which is a patient where I can use a linagliptin versus sitagliptin. That doesn't mean that I'm going to dodge this question. Well, the fact is, in terms of a therapy of semaglutide versus a tirzepatide, it's more of an art of medicine, no science out here. I can actually be debated and could be put into a doc out here. The fact with bit of a nausea and vomiting is what I have found with semaglutide. A bit of a diarrhea is what I found with tirzepatide, slightly on the more side. So I would look around the gastrointestinal aspects of the patients, and that can help me choose a semaglutide versus tirzepatide. Secondly, in terms of if it is just an obesity per se, ma'am, I know it's very difficult to answer that. You are just, because there's no major comparison between these two which can really help us. Whether tirzepatide, yes, the only thing which can now help me is certainly a kind of a commercial advantage, because the prices have slashed down of semaglutide, yes. With tirzepatide, because the patent is also off-coming, right? So since the prices are less, probably the biasness would be the semaglutide, you got a huge pool. But if you talk about just a weight advantage, without any doubt, because it's a dual agonism, 5 years from down the lane, you would be talking about triple agonism, right? So the more the agonism, the more would be the weight loss. But the fact is that also find it out that who are the patients who can tolerate it. Also to help even substantiate that answer, ma'am, there are patients of mine, very handful few, who did not tolerate neither a tirzepatide or a semaglutide, but very peculiarly and very surprising, they actually tolerated the oral semaglutide. Right? So, ma'am, I still am unable to figure it out that who are the patients. We are still into the kind of a roadmap of these kind of lessons. Thank you.
So, as you said, it's primarily an anti-hyperglycemic agent, as you also said the same thing. So, if a patient, as per Endocrine Society guidelines also, if a person do not respond to less than 5% of the weight loss doesn't happen in 3 months' time, you may think of other other methods. So now the question is, you are using it as primarily anti-hyperglycemic hyperglycemic agent, why you will not continue using it just for controlling blood sugar?
Without any doubt. So the entire concept of a responder versus non-responder with the context of a weight management.
Yes.
Now, in terms of a weight management, you've got a semaglutide and tirzepatide. The overall message out here from a guidelines and the philosophy is that if you don't have attained a 5% of weight
5%
loss
weight loss
over a period of around 3 to 6 months, please stop that medicine and think about the other alternatives. Like I've given an example that there was a patient who was just not losing anything, only to find out that she had an obstructive sleep apnea, and once you treated it, actually the GLP-1 receptor typically helped it. The question that you're rightfully asking is that if it is for a diabetes, I would not be looking for the weight management per se only. The weight management is an additive advantage.
Yes.
If it happens, great. If it does not happen, you just continue with the kind of as an anti-hyperglycemic. It's a very potent anti-hyperglycemic agent. So just always keep that in mind.
Another simple point, most of the patients usually say after 5 days they just regain the same appetite. Should we reduce not as per the half-life, but should we reduce the duration to 5 days rather than giving injection on 7th day?
No, typically, again, these are also where everybody is asking about that who are the responders and non-responders. So people who have got a kind of a regain of an appetite within the 3 days typically would not respond to these medications so very voraciously as compared to people who have a suppressed appetite for around 7 days. So point taken, sir. These are biomarkers for who are the responders or who are the non-responders.
Thank you very much. Thank you very much, Dr. Manashish, for giving excellent overview. Is there any questions? No? Thank you. Thank you very much. Thanks to you.
I request the dignitaries on the dais to proceed towards the felicitation area, and I request Dr. S.K. Gupta sir for the felicitation. I would now like to call upon stage our chairpersons for the next session, Dr. Ruby Bansal and Dr. Anirudh Lochan, and I would like to request our speaker, Dr. Arjun Khanna, to be on the stage, please.
Thank you, Dr. Sameer. And without any further delay, I would introduce, if at all he needs an introduction, a towering figure in EDPA, Dr. Arjun Khanna, a personal friend and the head of department of pulmonary medicine at Amrita Institute of Medical Sciences, Faridabad. I guess that should do it.
Yeah, that's enough. Yeah. Thanks, Anirudh. Hello, ma'am. And hello, everyone. And thank you, EDPA, for this opportunity. I always look forward to being amongst people from EDPA. It's always like coming back home. Very interestingly, I'll be talking about a new antibiotic, which is nephithromycin, and how it is changing what we do in the respiratory circles is what very briefly I'll talk about. So whenever a pulmonologist or a physician sees a patient with a lower respiratory tract infection, how are they supposed to treat it? There are two kinds of bugs that would cause any lower respiratory tract infection. It would be a typical bug. A typical bug is classically strep pneumoniae, H. influenzae, Moraxella. And then you can have an infection with an atypical bug. This atypical bug can be mycoplasma, chlamydia, or sometimes it's non-bacterial. It's one of the viruses that is causing it. So when you want to treat a typical bug, you would have drugs like cephalosporins, oral cephalosporins. You would have drugs like amoxiclav that would cover this. And if it is an atypical bug, for example, chlamydia, mycoplasma, you would have drugs like macrolides, azithromycin or clarithromycin or doxycycline, which would be covering this. Now, most of the times, the treatment for lower respiratory tract infections is empirical. We are not able to find out what the causative organism is. And very often, if you look at the guidelines, the Indian Chest Society guidelines for management of lower respiratory tract infections, especially for patients who are admitted, you give them drugs which combine both typical and atypical organisms. If you look at what causes lower respiratory tract infections in India, there is very interesting data, and this is data from JAMA, wherein this specifically looks at the Asian context. They say that in Asia, majority of the infections or respiratory tract infections are still due to strep pneumoniae. And this strep pneumoniae, what that graph is trying to show you over there, it's a slightly busy slide. Unfortunately, 65% of all strep pneumoniae in India is now resistant to azithromycin. Post-COVID, we have data from my institute, wherein in our institute, 92% of all strep pneumoniae is now resistant to azithromycin. Similar problem with amoxiclav, 46% resistance to streptomycin, to azithromycin. Indian data, the resistance is more than 78%. If you look at the other atypical organisms, for example, something like chlamydia or mycoplasma, drugs like co-amoxiclav, oral cephalosporins are not going to be effective in these patients. So you will have to treat these patients with either doxycycline or one of the macrolides. Now, this is a very simple table which is trying to look at the common antibiotics that we use in a lower respiratory tract infection and what is the rational advantage and disadvantage of using these antibiotics. Now, if you look at a drug like clarithromycin or azithromycin, does it cover MDR strep pneumoniae? It does not. And remember, 92% of strep pneumoniae from Delhi NCR is now MDR. It does not respond to azithro or clarithro. It does cover atypical organisms. It is okay for both pediatric and geriatric populations. However, you need to be careful about hearing illness, sensorineural hearing loss, and QTC interval prolongation in patients who have cardiac issues, especially with clarithromycin. Both clarithromycin and azithromycin have a very good lung concentration, which is really good. And one added advantage of these two antibiotics is that they have an anti-inflammatory activity. Unfortunately, azithromycin is the one that has been used left, right, and center, and as I said before, doesn't really work for most of the strep pneumoniae that we have in and around Delhi NCR. Oral cephalosporins, the biggest problem would be that it does not cover bugs which are atypical, for example, mycoplasma and chlamydia. Post Kumbh Mela, we had this outbreak of mycoplasma, and I remember at that time, as a part of thesis of one of my fellows, we gave them, we did a pan PCR for all patients who were coming with either upper or lower respiratory tract infections who had visited the Kumbh Mela, and our center data showed that 78% of all admissions or OPD visits were due to mycoplasma. Further analysis of this data showed us that majority of these patients in the primary care setting were treated like drugs like amoxiclav, where of course it is not going to be effective. So because atypical infections are so common, mycoplasma, chlamydia, just because we don't check for them, very often we miss out these bugs as the cause of lower respiratory tract infection. Also, amoxiclav and oral cephalosporins are associated with GI disturbances, and we all see that in our OPD practice. Drugs like levoflox, moxifloxacin for respiratory tract infections is a very, very Western concept of treating chest infections. Please do not use levoflox, moxiflox, ciproflox for treatment of chest infections in our country. They are a drug to be used for treatment of tuberculosis, drug-resistant tuberculosis. When you give levofloxacin, even a single dose of levofloxacin for respiratory tract infection can make the sputum of an AFB positive patient negative for AFB for the subsequent 7 days, and even if the patient has tuberculosis, you are going to miss out the infection. So don't treat any respiratory tract infections in India with levoflox or moxiflox, no matter how convenient it is. And there is now convincing data to show us that when you use fluoroquinolones as one of the treatments or co-treatment in patients with admitted pneumonias, the mortality tends to be higher. Doxycycline is one of my favorite drugs in treating these infections. Why? Because this covers both typical and atypical bugs. It is kind of safe, but one of the biggest problems with doxycycline is it has a lot of GI intolerance. And many people would come back to you on the third or fourth day saying that this was, what you have given us with this drug, we were better with the pneumonia. So though it does work well, it is inexpensive, there are side effects, you cannot use it in children, that is another big problem. So what is this nephromycin or antibiotic that we are talking about? Azithromycin, clarithromycin are not something new, they have been here for decades together. And both azithromycin and clarithromycin, they basically bind to one ribosomal site of the organism or whatever bacteria they are about to kill. Over a period of time, the first drug that was developed was azithromycin, and bugs, they are important, they are intelligent. These bugs, they developed what was known as the ERM gene or the gene. What does the gene do? Gene does not let, the antibiotic like azithromycin bind to this ribosomal site. So they did some kind of a tweaking. They came up with a drug called clarithromycin. So clarithromycin binds towards another ribosome. So over a period of time, clarithromycin worked really well. It does work well. But now we have an upsurge of bugs which are even resistant to clarithromycin. So what is nephromycin? Nephromycin is a make in India drug by Wokhard. The drug discovery, the pathway of this drug has been so impressive. I was fortunate enough to be a part of seeing how this drug was developed, a part of some of the trials. And the way it has been developed has been so robust, and one of the advantages of this drug is that it binds to 2 ribosomal sites and not 1 ribosomal site. So if we use it rationally, probably for the next 2 or 3 decades, the drug should be susceptible to majority of the respiratory tract causing infection causing bugs. This is another very important slide because this is showing a very important fact. Between the capillary and the alveolus inside the lung, there is something known as the epithelial lining fluid, and the concentration of McNAF or nephithromycin in this ELF is around 69%. The ELF is in direct concentration with the alveolar macrophages, and alveolar macrophages are the cells that are going to go inside the alveolus and going to kill the bug. The concentration of nephithromycin inside the alveolus is 2635 times. You know, it is highly concentrated over there. The similar data with azithromycin is hardly 20 times. So such high concentration in the ELF means it is very highly concentrated in the alveolar macrophages, and that is why if you look at the killing potency, you know, the red there is nephithromycin, and the small bar, the blue bar over there is azithromycin. The killing effect, the bactericidal effect of nephithromycin becomes exceedingly high. Also, because it remains in the ELF for a very long time, the post efficacy of the drug is very, very long. There is something known as an antibiotic memory, which means when the patient has been treated with a particular antibiotic, how long will the antibiotic stay in the circulation of that patient and keep taking care of the infection. The antibiotic remains in the circulation for around 28 days, and this is highest for any of the antibiotics that is seen in the respiratory tract. Multiple data, it has been supported now with multiple studies. It has been shown that it is potent against most of the azithro, clarithro, roxithromycin, amoxiclav, and levofloxacin resistant pneumococci. Patients who have azithromycin resistant pneumococci, 99.9% of them are sensitive to McNAF or nephithromycin. It is one of the antibiotics with the longest post-antibiotic effect, which is to the tune of 4 weeks. So the drug is going to be effective even 4 weeks after the 3-day course has been stopped. And the biggest advantage of this drug is because it elevates, it achieves such high levels in the ELF, you only need to give it for 3 days. Majority of the other antibiotics, for example, if it's another respiratory tract infection, a simple respiratory tract infection where the patient has been admitted to the hospital, you need to give the antibiotic for at least 7 days. If the patient comes to you with sepsis or septic shock, then you need to increase the duration of the antibiotic to 10 to 12 days. With McNAF or nephithromycin, this cuts down effectively to 3 days of antibiotic therapy. Almost no drug-drug interactions with the important drugs that are given to these patients in the ICU setting or the OPD settings. Almost nil GI intolerance, and none of the patients, there is not much data to show us that patients have discontinued this antibiotic due to diarrhea, vomiting, or other common GI side effects that we encounter with other antibiotics. Cardiosafe, hepatosafe, multiple studies have shown us this. And if you look at the drug delivery pattern, if you look at the drug discovery pattern and the way it has been published in literature, I won't go through the details, but different phases, like any other drug, the way a drug evolution takes place, in phase 1, they tried to look at what was the dose of this, and they tried to compare it with other antibiotics, and they found out that the 3-day 800 mg dose was equivalent to 5 days of 800 mg every day. So they cut it down to 3 days. So now this drug is available in India. We need to give it at 800 milligrams once a day for 3 days. The phase 2 trial again was in comparison with moxifloxacin, and the phase 3 trial, which is one of the most important trials of McNAF, where a 3-day course of McNAF was compared to 7 days of moxifloxacin. It was found out that it was non-inferior, because these trials cannot be superiority trials. You need to first start with a non-inferiority trial. Was non-inferior to moxifloxacin. 7 days in treatment of respiratory tract infections, and this got published in the Lancet Regional Health Southeast Asia very, very recently. So this again, makes us very proud in the sense that this is one of the few antibiotics which has been developed in India, and this is one of the few publications that have ever been accepted in Lancet Regional Health from a drug discovery group from India, and that is something that reinforces our faith in this particular antibiotic. Again, this is from the same, it will be a repetition, so I won't do. So how do you use this antibiotic? This antibiotic can be used either in the OPD settings or in the IPD settings. If it is a low risk kind of a patient, but If the patient has other issues, for example, it is someone who has a patch on the chest X-ray. The patient tells me on history that there is a lot of GERD histories there, the patient has a lot of acidity, GI issues. Rather than starting this patient on a 7-day course of doxycycline, which is going to cause more trouble, I would be happier starting this patient on a 3-day course of nephithromycin. Azithromycin, clarithromycin, for most of our patients, we have stopped using in OPD settings because of the simple reason that most of the patients who would come to a tertiary care center or to a good qualified physician would have already taken azithromycin before coming to us. Patients who have other comorbidities, a diabetic patient with pneumonia, someone who is immunocompromised with pneumonia, but the patient is stable enough to be treated in the OPD basis. There is convincing data again from the same paper that I've quoted from Lancet to show that it works in patients in the OPD setting where isolated or single mono-use monotherapy with McNAF or nephithromycin for 3 days was effective in treating these patients. The biggest advantage would be that it covers both typical and atypical bugs, and mycoplasma, chlamydia, strep pneumoniae, moraxella catarrhalis, Haemophilus influenzae, which are the 7 or 8 most important causes of pneumonia or respiratory tract infection, at least in India. The drug, that is data from CMC Vellore, which shows us that it is almost 100% sensitive as of now to these organisms, and that is why we really need to preserve this molecule and not use it left, right, and center. The biggest fear why it has not been introduced as of now or being promoted as of now into general practices because the scare of it being used for viral infections is going to be really high, and you really don't want to miss out or lose out on such a vital antibiotic because of the abuse that is going to happen in India. So you need to make sure that you're treating a patient with a bacterial infection or a pneumonia and not treating a patient of cough and coryza with an antibiotic which has been developed with so much of pain and which has so much of potential. In hospitalized patients, what we are doing in our clinical practices, any sick patient, because this antibiotic is new, probably in the Indian market for the last 4 or 6 months, our group has close to around 300 patients where we have used it in the hospital setting. It is a good antibiotic. I still would not have the heart to use it alone in an admitted patient. So I would use it as a drug which spares a drug like doxycycline, azithromycin or clarithromycin. I would use it with whatever antibiotic I'm using. For example, say I'm using piperacillin tazobactam for one patient who's admitted, and along with that, as per Indian Chest Society guidelines, I'm supposed to add doxycycline or clarithromycin. So I would substitute that with McNAF or nephithromycin. As our experience grows better with this drug, as the trials tell us, as the company claims, maybe as we become wiser with this drug, we will have the heart and the guts to use this drug alone in our admitted patients. But as of now, it is a good antibiotic, it makes sense, it is something which is upcoming, and only time will tell us how good it is. Initial data of whatever we have, it is good, that it supports antibiotic stewardship. That means you need to only give it for 3 days, it's not very prolonged. It is clinically efficacious, ultra short course dose, and reduced antibiotic consumption, minimal resistance, and so I think it's a good antibiotic, it's a vital antibiotic, it is something to look forward to. But my only message would be that let's not misuse or abuse this antibiotic, as is unfortunately done with most of the antibiotics in our country. Thank you so much.
As always, a very well thought and a very well researched talk. Dr. Makkad, you would like to ask a question, I assume.
None, sir. None. So whatever data, zero.
One question at a time, please. Dr. Makkad is asking his question. We will get back to you after that.
Okay.
Sir.
There is, yes, sir. So the way it has been designed, sir, there is no data to show that it causes. So even with azithromycin and clarithromycin, if you look at what causes QTC prolongation, azithromycin almost nil. Due to the molecular structure, it is said that clarithromycin can cause it. But nephithromycin, as of now, not been reported. Safe for cardiac patients, safe for renal patients. It has been tried, although the package insert would tell you that it is safe for patients where the liver enzymes is more than 5 times of normal range. But if you dissect through the data, especially the one that was presented from India in Lancet, it is even safe in patients where the OTPT is more than 10 times normal.
In pregnant patients, pregnancy?
Sir, it is not as of now indicated in pregnant patients.
Any stage?
As of now, there is no data, sir. So we would not want to use it there. So it is available as a strip. It's a blister pack. So there are 6 tablets in it, 400 milligrams, to be given stat, 400 plus 400, 800 milligram stat. It is 500 rupees for one tablet, so 3,000 rupees for 3 days. 6 tablets is 3,000 rupees.
Doctor?
No, sir. As of now, only respiratory tract infections.
I guess we have time for one more question. Dr. Prakash Kera, sir.
It was also stated that 3 days is enough. But where are we today? So what is going to be the status of this salt?
Absolutely, sir. We always evolve with these drugs. So the time would only tell. Whatever data we have as of now tells us that 3 days is good enough. But as you very rightly said, as we evolve more with this drug, we will have that data. I can only say what is present in literature right now.
Even typhoid was 3 days treatment to begin with. Now we know what.
Right, but as Dr. Arjun said, the main challenge after researching such a molecule is to find ways of ensuring that you don't have any misuse. And the armament of antibiotics is fast depleting. This is one new nuke which we have, but only if it's used judiciously. And that's easier said than done.
Add this drug along with the other antibiotics?
So it had, in fact, I could not present. I had to stop for the want of time. There was one case that I was about to show, and this was the case that I was showing. This was one of our diabetic patients with a patch. So initially, when it was launched for the first couple of months, I did not have the heart to give it alone. We was giving it, but as our confidence grew, we were able to give it alone. So in a lot of our patients, we have been able to do it, but I think it is all about clinical judgment. If it is someone with a lot of comorbidities, someone who appears sick, I would probably not do it.
So which antibiotic we can combine it with? Something like
I would combine it with something
coamoxiclav or something?
Probably, sir, but it makes no sense because, you're using a molecule because it is, because the other molecule doesn't work. So combining it with something non-inferior doesn't make any sense at all. So I think the roadblock is in our minds rather than what they claim is that you can use it alone.
Thank you.
Thank you, Dr. Arjun. It was a wonderful presentation, but with the only request we should not use it left and right, and we should preserve this antibiotic for particular reasons and for particular things which is needed. So thank you very much.
Wokhart had come up with the other antibiotic that was levonortifloxacin. So levonortifloxacin, thankfully, they have not advertised too much. The message here is please don't advertise it. Even for patients who have MRSA in our hospitals, who are, who don't respond to anything, 1 day of levonortifloxacin, is a game changer. They're also coming with something known as Zinage, which is probably another, which is going to be another fantastic antibiotic out of India for MDR Pseudomonas klebsiella, where it is pan-resistant. And that is one antibiotic that should be launched by next year. We already have a lot of data on it. And fantastic antibiotics coming from India. So something to look forward to. So levonortifloxacin is for MRSA. But because it is a congener of the fluoroquinolones, it also is effective against gram-negative bugs and also against anaerobic infections. So it works pan. It was defined, it was designed, it was developed for MRSA, but works for everything else.
I think due to paucity of the time, we should close the session. Thank you very much. Thank you.
I request the dignitaries on the dais to proceed for the felicitation. I request Dr. Lalit sir for the felicitation. For the next session, I would like to call on stage our chairpersons, Dr. S.K. Gupta and Dr. Vivek Kumar. I would like to call our speaker, Dr. M.V. Padma Srivastav.
of Neurology at CN Center, AIMS, New Delhi. And she'll be speaking on multiple sclerosis, the evolving landscape of diagnosis and treatment, and what the physician should know. Dr. Padma.
Thank you so much, and it's a great honor to be here. And good evening, so it's pretty late, so I'm going to, it's very difficult to cover in 20 minutes everything what the physicians may need to understand about what's happening in the field of multiple sclerosis. So pardon me if some of the slides would be glazed over. So essentially, when you're looking at multiple sclerosis, you know that it is one of the primary demyelinating pathologies, and it relapses. It leads to disability. And it's no-brainer that we don't want relapses. We don't want a disability to, build up. So described way back, and in fact, what Charcot had described, in fact, this patient was not even MS. But these are the features which sort of, put in those red flags or antenna up that this is the different disease in young people. So wherever there is a plaque, in every which way, there's a protein of symptoms and signs with which a young person with multiple sclerosis can present to you. So in fact, any or all of them, so they're not always in your face, they may never always present with a gross neurological deficit. So one of the messages which goes in is that even a subtle neurological feature in a young person, you probably should not be missing it, even if it is you're over-investigating. Because there is a phase of early inflammation in multiple sclerosis, and there is a switch wherein it goes into inexorable degeneration. And that's exactly the switch we don't want it to happen. So when there is an inflammation going on, we need to tackle there. And that's the reason when you're looking at time is brain, you're looking at stroke, you're looking at epilepsy, but you're also looking at a demyelinating pathology. In every which way here, the neurological damage is not just an inflammation. There is at some point, it's going to be degenerative as well, and we don't want that to happen. So depending upon the way the clinical presentation happens, you have different clinical varieties or subtypes. You have clinically isolated syndromes. No, it's okay, sir. So it's okay. So, and then you have the relapsing remitting. You have a progressive, which could be secondary, or it could be primary progressive. But then there is a clear thought these days that are we artificially sort of differentiating these different subtypes? Maybe it is one spectrum. Something has happened, and depending upon the individual immunity or his immune system or what his immune strategy is, that these subtypes evolve. In fact, it's the heterogeneity of this disease and also heterogeneity in clinical presentation and its pathophysiological mechanisms and how they respond to a particular category of medication that you have this protein presentation of multiple sclerosis. It is one disease, but it is a complete enigma, and Kamakshi will agree with me on this, that every single day we learn something new about this disease. So, but then clearly when you have a presentation which, you have a 40 years old male patient coming in for the first time with an increasing disability, no clearly discernible relapses or attacks happening, then you're suspecting a primary progressive versus a younger patient having multiple attacks of something happening and improving and coming back with problems. Well, that would be a no-brainer for a relapsing remitting. But then it's not always the case as such. So when do you suspect multiple sclerosis? There is a complaint, and they are coming to you with some complaints in forms of acute or subacute onset, and they may resolve by themselves as well, or resolving with acute immune suppressive therapy like steroids. And then you have a neuroimaging, which is the cornerstone, which will actually establish, which probably will also give you a red flag that this could be multiple sclerosis. Not all what white matter pathologies which you see in imaging is MS, but then this red flag would definitely be important, confirmed predominantly by neuroimaging and also supported by the biomarker studies in terms of CSF studies, which essentially are ruling out MS mimics because we also have OCB negative variety of MS. And then there are some evoked potentials. There is some kind of, sort of a gray zone there, some wanted, some don't want it. I don't think OCT is there yet amongst them, as such amongst us, as a definitive mandatory biochemical investigation. So therefore, there are a lot of criteria which have also evolved. McDonald's essentially said, look, we need these relapses dispersed over a period of time. It's come, gone. And also when you do an imaging, there are these plaques which are there at different time points. Some are old, some are new. And then initially, Schumacher said, no better clinical explanation. And as these criteria evolved, they became more partial, they became more sort of, let's rule out MS mimics. And then later on, the people have realized that let's again lump everything back. So initially it evolved, then we split it, and now we're lumping back that it is probably better to overdiagnose than underdiagnose, for the very simple reason that you cannot have a very prolonged onset of disease to treatment onset. That needs to be as short as possible. So imaging, you have different varieties. So you have dissemination of lesions in space. You have some old, some less. You have spinal as well as the, in the brain. And in time, as such, which look old and which are new. So when you have in space, that is, they are there in posterior fossa, they are in the anterior, you also have in the spinal cord, and over a period of time, some are enhancing, some are not. You know that you have this DIS and DET fulfilled to know that this could be primary multiple sclerosis, primary demyelinating pathologies. So in the differential diagnosis, you suspect them, you exclude the non-demyelinating syndromes. So in that, not MS could be the entire spectrum of NMOSD. You have MOGAD, you have one-time, in fact, you have recurrent ADEMS. And also, when you're consistent with MS, I don't think we need to differentiate much about clinically isolated, maybe radiologically isolated, but not definitely CIS, because the kind of disease-modifying therapy would still be the same. And then in treatment, yes, you need to treat relapses, but the most important thing is let not there be any more relapses, or have those relapses very minor in their severity and also spaced out with time. And of course, treatment of symptoms. So, but then the bottom line, as is with across medicine, right drug, right patient at the right time. And that obviously would include precision and personalized medical system. That is true for entire medicine. You would agree with me on that. So, but then there you have patients who come with a highly active disease. So in that, and then which drug to which patient would be driven by the disease, the spectrum, as well as a patient. So that's the reason when you ultimately decide which drug to a patient, it is actually an informed dialogue. So that is the reason we have, in fact, multiple sclerosis clinics now, because these are young patients who need time. It cannot be that you have one epileptic attack, come on, you take this drug and you go. It cannot be over a period of 2 to 3 minutes. In fact, that's the reason in AIMS, we first started the MS clinic, and across now, we do have MS clinics established. There's a drive to have more, because these young people definitely need more time. It's a different system altogether. So when there's also rationale that you do have a spectrum where the MS seems to be much more benign, though I doubt that, and some who are really highly aggressive. Because in these situations, you have young people who are having multiple attacks, they have cumulative deficits, so they would have, say, optic neuritis, or they may just come with myelitis. And when you do an MRI, you'll also have a brainstem pathology, multiple lesions in the spinal cord. They don't respond well. Even with your steroids, they'll be left with a deficit and quickly have another relapse. Now, these are a group of patients where starting very mildly and increasing drugs may not really help. So this highly aggressive variety, in that the pyramid which actually exists, that you start low, if they don't respond, you go to a higher level, may not be there, and you actually flip the pyramid. So you have both these strategies available. You have ones that you start lower, go up. The other is you flip it, start with a very active drug, get the disease under control, and then you de-escalate your disease-modifying therapy, which are essentially those medications which help prevent relapses and accumulate disability. So in the current treatment paradigm, you do have this CIS, which is not very vastly different from an RRMS, but there is a difference between an active and highly active and the progressive onset of multiple sclerosis, wherein amongst the spectrum of the drugs which are available to you, you may need to choose which one first and how to escalate or de-escalate these medications. And it'll be difficult at this point in 20 minutes to actually understand when, how, and whatnot, but that's important to know that there is a huge spectrum of medication in our armamentarium available, which we didn't have. In 93, we just had interferons. But now in 2025 and at the end of 2025, I have in my basket such large number. And we have a level 1, 2, level 3, level 4 available with me. And the essential paradigm here is I'm not letting this young person or not so young person as well. The last one I've treated with ocrelizumab was a 73-year-old who came with the United States. So I would think that these people should not have relapse or the disability should not increase. So, you know, there are these lower efficacy medications. Come to that, I think, I hope that I have that slide up here, which actually would be very low in their side effect profile. So I would like to choose them. They're also probably less cost, and economics is the big elephant in the room. We have to know that, you know, those economics would dictate even our prescriptions. But then you do have these highly effective medical therapies, and in our country at this point of time, barring probably cladribine and some of those, you know, like ponesimod and, you know, some of those other drugs which are besides the one which have saponimod may not be available. They're oral drugs, but other than that, everything else is available now, including ofatumumab and probably even BTKI inhibitors, which are going to come soon. And that's actually the multiple, you know, the portals wherein there is these, I would say, why multiple sclerosis can happen. And because of these portals, why ultimately you have this disease, whether it is astrocyte activation, neuroaxonal degeneration, what came first and what went next is probably a different paradigm. But we can manage inflammation, we can manage demyelination, we can manage excitotoxicity, the energy failure. No wonder you'll have a number of medicines, therefore now, which are topographically positioned in that particular patient. But what we don't know is what is the mechanism most, you know, important in an individual patient. That's where you have precision and personalization. So in a pathophysiology update, we also now know that there is very, you know, there is a very early axonal damage. It's not always demyelination. It's not always that these axons are ripped up of their myelin. There's something else happening out there, and this is basically the tip of the iceberg phenomenon. But the time the patient is presenting to you, a whole lot has already happened, and that's the reason we have to be so very careful that in their EDSS, now EDSS is one, you know, kind of a scoring system which explains the disability. Now, as they actually hit EDSS 3, there's an exponential increase in disability. They'll quickly come down to a wheelchair. And then getting them back on their feet will be very, very tough. So we should not get this EDSS up at all. And so the axonal damage occurs early, we've said that. And the other thing we never even assess in a busy clinic is cognition, their personality, their behavior. We don't have time for that. We only look at motor deficits, sensory deficits, you know, their vision loss, their, you know, balance. But then they're changed people. And the moment they actually walk in, you know they're behaving differently. So the cognitive assessment is part of our disability screening, and please remember that this gets impacted and gets impacted early, and we need to have that. So this is the MS iceberg, and there is a, you know, something called no evidence of disease activity, and that is what, there are other things, like knee pad and knee daddy. Basically, it means that there is no evidence of anything active happening in these people. Whether it is clinical, it's biochemical, it's radio imaging, and NADA is our strategy, our goalpost. Get them quickly to NADA, keep them in that NADA. Okay, I'm leaving. So what we have achieved is that it's never too late to start a DMT, and when and what to start will depend upon the clinical severity with which a patient presents, in which we have the clinical features, we have disability and imaging factored in. And the biochemical parameters would be the CSF OCB positivity. So what are the risk factors for a highly active? We have demographic in terms of males and more than 40 years. Ethnicity, I'm not really bothered. Clinical is severity of relapses, number of relapses, the disability, and the imaging. So it's very easy to, in fact, if you know these, to be able to identify them. And then again, pardon me because I have to really run through because of the interest of time. It's now known that when you actually hit them hard at the very beginning of the disease, you actually try and mitigate the amount of disability they accrue over a period of years. And now we know that there's a role of B cells, it's not always T cells. We have these amazing monoclonal antibodies available now, except ublituximab. I really don't miss that. We have these three big drugs which are there. I think rituximab will also be getting an FDA approval soon. As so far it's off-label, but it's been my go-to drug in a lot of cases because it's cost-effective. But then there are other drugs which have an edge over rituximab because it's chimeric in its thing. But when you're looking at the landscape, 1993, 94, you have interferons, and look at 2016, 18, it's a busy slide, and here I'm still 7, 8 years old, which is an older thing. We've got a whole lot which has happened in this landscape, number of options, but please remember you need to be aware of them and start early, start the right drug to the right patient. That's the most important thing. So we may have a drug which is highly efficacious. Take a minute more. So I'll skip all this. There's a lot been, meta-analysis, and they found that alemtuzumab is way up there, but it's got a lot of, problems in terms of number needed to harm as well. So we're not looking at alemtuzumab. It's my level 3 drug. So I'll skip this too. And let me look at the efficacy risk part of it. High risk, high gain, but high risk is basically the issues like, the stem cell transplant. Believe me, this is not some subcutaneous issue. It is bone marrow transplantation, which is actually approved, and a very few people who actually need to get there. But I think there are guidelines. There are guidelines in pregnancy, in lactation. Let me not get into that as well, because that would take time. Where do I get it? Yes. So the induction and escalation, I've already told you, there are large registries, which is MS-based, there's Danish registry, all of them have said that. But when you looked at a highly effective treatment, they say ocrelizumab. Now, this is a very nice thing. In fact, this is something which you can actually give it a policy maker, that over a period of 10 years, you're on this monoclonal antibody, 90% did not need a walking aid. It's a very powerful message out there, with very few side effects in terms of immune development of malignancies, and even in primary progressive. This is a good slide as a take-home, that in the network meta-analysis, and this is in terms of efficacy, high up is alemtuzumab. It's a level 3 drug. A lot of side effects out there, though it is a finite. It's just 8 injections over a period of 2 years. But then ofatumumab, natalizumab, ocrelizumab, a very high efficacy there. We don't have cladribine. We don't have ozanimod, but fingolimod is here, DMF is here, glatiramir, interferon. Now these guys are much, much lower down. So in terms of efficacy, we have these things which are available with us, and I think we should not shy away from doing the right thing for want of knowledge or for want of a fear that let me not go into a big drug, God knows what will happen. So flip the pyramid when it's necessary. So I think there are a lot of these scoring systems. If one drug fails, know what to do. But I think what needs to be achieved is a recovery of function. There are a lot of trials in that, in terms of axonal plasticity, in terms of remyelination. And these are the new concepts which are coming beyond NADA, NIDADI, in the sense that disability improvement and no further disability. And neuroprotection, we are searching for the holy grail, whether it is stroke or here, and remyelination is still there. Stem cell therapy, please don't get into stem cell therapy because there are definitive criteria for that. There are groups to tell you good or poor prognosis. And I'm sorry I had really rushed through, but I didn't know how to actually encompass the entire landscape in 20 minutes. I apologize for that. Thank you.
Thank you, ma'am, for the excellent talk. Now, in a young patient with a highly active disease, it is said, act fast and act hard. And when you put them on a very highly effective DMTs, what would your target and when will you like to de-escalate?
So that's absolutely essential question, sir. It's very pertinent. So there are two things. One, when do I de-escalate and when do I stop? So the stoppage part is probably now becoming much more clear in terms that there is something called senescence, immune senescence, and usually it is 60 plus. But as I told you, it's a 73-year-old who again became active and I had to put her on ocrelizumab. But broadly, it is 60 plus who's achieved NADA is where you may consider stopping, especially since they have a lot of other comorbidities. They turn diabetic, they're hypertensive and whatnot. But in terms of de-escalation, there are two things. One, young lady who need to have a pregnancy and lactation, who achieved a NADA, I would. Or even sometimes get on to level 1 like interferons or glatiramide, who can continue through pregnancy if they want to, because that's one of the safe periods. But otherwise, NADA, at least NADA 3, if I have achieved, then from level 2, I come down to level 1. Do I go down from level 1? I will not. So in a young patient, even if they've achieved NADA, I would try and convince them that please stay on, because if they relapse badly. So I still don't think that there's a cohort of a very benign MS because we don't test cognition and behavior. Maybe there is, but I think the world is divided on that, and I would rather not get into that because I think it's better to play it safe.
Any question from the audience? Yes.
Now in the world of biologics, you mentioned a lot of biologics, the word is moving towards, disease remission or cure of the disease. And MS is one such debilitating disease where you want a cure and you have these armamentarium of high efficacy drugs, high reward, high risk. Alemtuzumab happens to be one of those drugs where you said it's a finite therapy, you just give it for 2 years and you're done with it. Of course there are side effects. So I think that's one of the drugs that in the world where you're trying to achieve NIDA, why don't we discuss the risks and use that drug as
very pertinent question. In fact, I had one young guy who came and said, let me get a bone marrow transplant and I'm done with it. So the thing with the alemtuzumab, in fact, it came much before all other drugs. And it didn't really test out the time. Because though it's finite, first year 5 injections, second year 3 injections, your monitoring is whole life, including all systems, and then there were people who required to take alemtuzumab subsequently. It's not the expense, but I think it didn't catch on because of the fact that you needed so much of monitoring. And it stays level 3. In fact, cladribine, oral cladribine probably is again an immune reconstitution therapy. In IRTs, you have this, and you have bone marrow transplant. So in fact, when this guy came and said, and I believe they're doing bone marrow transplant right and left and center, I don't know, Kamakshi, you didn't do it, I didn't do that. But then there have been situations where they said we are doing these BMTs, but I don't think that's ethical because there are definitive criteria there and there's a lot of morbidity. I'm not going to subject them. So IRTs have their own issues. So we are searching for we were talking about holy grails, this is another one.
Sure. Thank you.
Any other question?
In spite of so much of progress, all are looking after for decades. But I can, with my own experience with Trinity, a single, say, loss of vision and majority, you cannot predict where they are going to be, even in spite of so much of progress.
Yes, sir. Actually, that's an absolutely wonderful question. For the single attack of optic neuritis, at one point, say, 16-year-old girl, and you just gave steroids and she's back to normal, nothing. But then when you did the relevant neuroimaging, and even in neuroimaging right now, we have those kind of imaging which are actually picking up what can become very active, not just white matter, and not just some black spots. Isn't it, Kamakshi? Now you have neuroimaging criteria, which actually say, now this is a very active disease. Beware. And so with the imaging, and there are a lot of biochemical and the markers which include the NFL and GFAP, they're able to identify an active disease which are not going to remain passive and they would actually creep up. And there is something which comes as a relapse, something which is underneath. So, there is an activity which is beyond what we are actually discerning. So I think Now we are not going to take a single optic neuritis. If there's MR is clean, there's absolutely nothing there. Earlier, in fact, we had trial, ONTT trial and all that, those guys, and they come to ophthalmologists, they stay with ophthalmologists, and they disappear, they vanish. So there may be still people in that. But at this point of time, I will not want to take that chance because I would like to, because she's just a 16-year-old, whole life, ahead of us, ahead of her. But it's a very important question, sir.
I think Dr. Padma has done a wonderful job, and she has presented a very vast topic as relevant to the physicians. I think we should give her a big round of applause, and thank you very much.
And I request the chairpersons to remain seated. Thank you, sir, for the next session as well. I would request you on the chair as well, if possible.
Dr. Vivek, I think continue the session. I think on the session is also neurology. So keep on chair for some time. Right?
So I request the next chairpersons, Dr. Rajesh Gupta and Dr. Naveen Atal sir on the stage, please, and the speaker, Dr. Kamakshi Dhamija.
The next talk is, for the next talk, we have Dr. Kamakshi Dhamija. She is DM in Neurology from GB Pant Hospital, and she has postdoctoral fellowship in CNS demyelination from NIMHANS. She is very active in the area of demyelinating disorders. She has several chapters and publications, and she is going to speak on recurrent optic neuritis.
Thank you so much, sir. Good evening, everyone. So, first of all, thanks to the organizing committee of EDPACON for projecting CNS demyelination among us, the physician forum. The most common demyelinating disorder, what we all are aware of, has already been taken up by Padma ma'am. So now I would be talking something about an atypical demyelinating disorder, which is exquisitely steroid dependent. And as the question of optic neuritis has already been raised previously, let us see how difficult it can be to treat an optic neuritis. So I would be taking it through a case. This is a 24-year-old female who has history of recurrent neurological events since last 6 months. So this was somewhere in March 22 that her illness started with tingling and burning paresthesias in soles. And within the next 2 days, there was appearance of motor weakness in both the lower limbs and a sensory level till the mid-chest region. And of course, there was a bladder involvement, and onset to the nadir of weakness was around 1 week. So she presented to a neurological facility after 2 months of the onset of symptoms and had not received any treatment till now. So at 2 months of the ictus, she was hypotonic in the lower limbs, some upper limb involvement, and the sensory level was up to till T4, and this was her MRI, which showed a longitudinally extensive myelitis running starting from the cervicomedullary junction till the conus. So all relevant workup was done, and she was at this point of time, all the vasculitic, everything was ruled out, and she was found to be a weak MOG positive at this point of time. So at the first ictus, now since she had presented to us after 2 months, we gave her IV methylprednisolone for 5 days, there was no recovery, followed by IVIG, followed by injection rituximab, and she was discharged on oral steroids to a rehabilitation facility. Now, clinical follow-up after 2 months, there was no recovery in motor power, and of course she continued to be on steroids with a very gradual taper after 1 month. Now what happened was, after 3.5 months, she presented with a painful loss of vision in left eye, and it corroborated with some dose reduction of steroids a week later. So left eye had no perception of light. Now, at 3.5 months of rituximab, CD19 still being 0, she presented with a relapse. So this time, again, rescue steroids were given. She was started on plasmapheresis, 6 alternate day cycles, and improvement of visual acuity was observed from PL negative to 6/36 status after 6 cycles of Plex. So the thought process was something like that, that rituximab was probably not effective. She was initiated on Azuran, planned to continue monthly maintenance plasmapheresis till Azuran effects it kicks in, and Visalon was continued. Now what happened? Again, within 7 days of stopping plasmapheresis, she continued to be on a good dose of steroids, again presented with a painful right eye vision loss while on steroids. And now this time it was just a perception of light within 2 days. So still figuring out what to do, we proceeded with a rescue cyclophosphamide dose with 3 additional cycles of plasmapheresis. And this time there was some improvement in visual acuity from PL negative status to finger counting at 3 feet. So now probably we had a change in plan. We continued on oral steroids. Steroid taper was planned to be attempted after 2 months. Now while we were still figuring on what to do with Azuran, what to do with cyclophosphamide, the Plex cycles, now again after cessation of plasmapheresis this time, within 5 days she again had a painful loss of vision in right eye. Now we thought let's start her on IVIG and keep her on monthly IVIG along with Azuran. So current status was she continued to be paraplegic and there was no improvement in vision. So now, while we were hoping to stick with the plan, one day she presented with altered sensorium and within 12 hours she crashed. So we don't know what happened to the brain. Probably it was a PML-like picture, but we really don't know what happened. Yeah. So it was just like she landed in emergency night. By the morning we saw she was gone. She was from a very remote area. I think it took around 12 hours to take her to the hospital, and within 12 hours she succumbed.
So biopsy?
The attendants did. So ma'am, that time she is a case from Safdarjung. So biopsy at that point of time was not feasible.
G5 antibody?
So that was 22, year 2020. Wait, you had asked. So 2022, that was still a recent era where G5 could have been done. But probably when I entered that hospital, she was already a follow-up. And within a month, all this happened. So G5 was not tested in her.
So I was thinking about IL-6 and tocilizumab.
Yeah.
In such cases when they don't respond.
Yeah.
And definitely a biopsy when she kept coming with what my
So the key questions here are, what disorders could actually account for such exquisite steroid dependence in a case of CNS demyelinating disorders? Are there some clinical clues to suggest that the lady had MOGAD standing distinctively from other disorders? Or what could be the potential treatment plans for something which is called a refractory MOGAD? Now, MOGAD, among us, a physician forum, probably I would be projecting a disease which comes up with some special phenotypes, with some special treatment protocols, which I think we should be aware of. So now, if a patient of optic neuritis has a rapid relapse upon tapering steroids, there is dramatic responsiveness to steroid treatment, has history of recurrent optic neuritis, especially if it is bilateral or severe, and there are repeated steroid requirements to maintain stability. Probably it is a red flag for classical RRMS. There are some differentials which should be investigated in such a case. Of course, MOGAD tops high in the list. Some presentations of NMO, G5 astrocytopathy is third. Some inflammatory disorders such as clippers, neurosarcoid, and seronegative entities exist. So this is probably a diagnostic workup which should be done in every such case, coming to the mock testing, echoprotein testing, especially looking at the brainstem and a systemic workup. So the key line here is steroid dependence in demyelination suggests antibody-mediated disease or an inflammatory mimic rather than MS. So now, could we be able to find out some clinical clues to suggest that the patient here, what we discussed, had MOGAD? So the classical description of optic neuritis is a unilateral, painful loss of vision which starts and gradually builds up in a matter of 2 to 7 days, and the patient, the classical saying is the patient is also blind and the ophthalmologist is also blind, because most of the cases have a normal appearing optic disc in such a case. Now, we know that we have something which is primary optic neuritis, the MOG group, aquaporin 4 group, or the seronegative entities. Secondary to some systemic disorders, infectious disorders, and paraneoplastic optoneuropathies do exist. Now, this is just a slide of how to differentiate among the common causes of optic neuritis. Now, typically in MS, the initial visual acuity is mild to moderately impaired. Recovery is typically favorable, and as I told, optic nerve head is usually normal. Aquaporin and MOG, they are the causative agents for a severe optic neuritis at the onset. Often the visual acuity is severely impaired in aquaporin. It's a risk for poor recovery, and if we do an fundoscopy, we find usually severe edema with hemorrhages. However, they're less common as compared to MOGAD. MOGAD has a typically a swollen optic disc, edematous, hemorrhages. And also in MOG, we have severe impairment of acuity at the onset. However, the saying is, MOG usually melts with steroids and the recovery is favorable. It is not the case. It is like this, but it is not a dictum. We have seen like the case which I explained, and also we know that by experience, even MOG patients have an odds of poor recovery, and this fact is not always true for every MOG patient. So the clinical clues to MOG optic neuritis is, the optic neuritis is usually bilateral. There is a high ON frequency and a recurrent ON frequency, something like cryon disorders, which probably we used to talk more about in pre-MOG area, and a severe visual deficit or a blindness in acute ON also favors MOG. So this is a diagrammatic presentation. So what the three entities look like. NMO usually has a tendency to involve the posterior optic nerve and the chiasmal region. MOG usually has a long segment optic neuritis involvement, however, it is more anterior. And MS is a partial, short segment optic nerve lesions. So here also we can see this is an MS typical ON MRI. More often unilateral short segment lesions across the optic nerve. This is an aquaporin 4 disease. Long segment, more than half, posterior, frequent chiasmal involvement is seen here. And this is MOG, bilateral, bulky right optic nerve with contrast enhancement, and something which is called a perineuritis is evident here, both in the number 2 and 3 scans. So particularly in our case, the relapse, there's also one important point to learn here. The relapse occurred within effective period of the rituximab, especially after tapering steroids, and multiple flare-ups were seen after withdrawal of acute management strategies. Now coming on to what could be the treatment plans for this patient. So we know. So now I think everyone would agree with me. MOG is exclusively steroid sensitive, and whatever immunomodulators we have been using, they have just served as a surrogate for steroids. The only point here is steroids are Ramban for MOG. But steroid sparing agents, whatever we have been using in combinations or as a substitute for steroids, usually do not work very well as head-to-head comparing with steroids in MOG cases. So this is just a slide about the commonly used drugs in MOGAD, the Azoran, MMF, rituximab. One thing to note here is rituximab comes down the line. It is not a very good option for patients with MOGAD, and probably immunosuppressants as Azoran and MMF work better than the anti-CD20 agents in MOGAD. Now coming for the options for refractory MOGAD. Probably the best combination which works is monthly IVIG along with MMF or Azoran. Interleukin-6 inhibitors like tocilizumab also have a good evidence for patients with refractory MOGAD. There is some anecdotal evidence for cyclophosphamide and methotrexate as well. And some reports for ofatumab do exist, but they are very anecdotal. So that is what so far no level 1 evidence of treatment efficacy exists. An empirical decision is usually taken based on retrospective analysis and expert opinions, and there are multiple case series showing the efficacy of maintenance monthly IVIG along with some immunosuppressants to deal with such cases. Of course, there is some evidence for interleukin-6 efficacy as well. Not going into the details of this, I would like to highlight two important facts here. Anti-CD20 agents high failure rates are seen in such cases, and probably they should not be the treatment choice when we deal with a MOGAD patient. Now, I will be illustrating all this through a case. So this is a 16-year-old female. December 20, she had ADEM, MOG positive, treated with IVMP and followed by tapering steroids. So now, March 21, she was on Visolone 5 mg alternate day, and she relapsed with the left optic neuritis. This time treated with IV steroids, started on Azuran. Now, while she was on Visolone 20 to 25 mg, again relapsed with the right twin. Given IVMP with flex, initiated on Ritux. Again, when she was on 20-25 mg steroids, again had a left twin. That was 3 months after starting rituximab. So this point of time, she was offered combined immunomodulation with Azuran plus rituximab. Now, when the Visolone was again tapered, 10 to 15 mg, she was already on Azuran. CD19 was 0%, again relapsed. Now, this time started on monthly IVIG, and steroid was tapered to 10 mg daily after initial induction, and rituximab was stopped. Now, due to some, because we know procuring IVIG in a private setup is very difficult. It is challenging for the patients. Because of some logistic reasons, she had a delay of IVIG by 2.5 months, and she relapsed with a right twin this time. Continued on alternate 5 mg Azuran, and just the compliance was ensured, and the plan was continued here. Now, while on maintenance IVIG with full compliance, she again relapsed in July 24 with left twin. This time, she was initiated on monthly tocilizumab as an add-on to IVIG, and no further relapses have been seen. So this lady has just come to me after, I think 1 month before, continues to be on alternate tocilizumab and IVIG, and she has been doing well. Steroids have been tapered off. So, and of course, now we await CAR T cell therapies or stem cell therapies in MOGAD as well. We don't know what the future has to unfold. So the best treatment, as I discussed, remains still steroids, and figuring out how to replace steroids with other agents. So lessons to learn here is, time is tissue in demyelination also. Steroid dependence is a great red flag for MS. Always test for MOGAD. Refractory MOGAD is something which gives us insight into the disease pathogenesis. And of course, we accept that the therapies for the same are limited. Steroids remain probably the most important immunotherapy in MOGAD. But in the first case which I illustrated, not only steroids, this was also plasmapheresis. And some flare-ups secondary to plasmapheresis withdrawal have also been seen in MOGAD. But of course, the literature there is rare. So that is how we watch for. Raise awareness for the CNS demyelinating disorders. Thanks to Dr. Pankaj for allowing us to do this on this forum. Thank you so much.
Actually, I think the first case could have been even lymphoma, Kamakshi. The way they, the last few presentations, because any of these white matter pathologies, especially, they were just responding to steroid.
She
and
was
Ritux came in the middle.
positive in 2 times, like she was tested.
MOGAD, I mean, we know that. I mean, and the long segment myelitis on the on spine, that probably would have thrown the scent off lymphoma too. But we have seen spinal involvement in lymphoma, and the I think seronegative NMOSD, which actually has a worse prognosis compared to MOGAD. So I think what could have been done probably in the other hospital, maybe they could have actually tested for IL-6 levels, and if they're high, just shifted to tocilizumab, or get that biopsy of the lesion done. Third thing is GFAP is still very sort of not very common, but then that astropathy also would have probably shifted the gears. But I would think that a biopsy would have been, whenever something happens in steroid is sensitive and you have large lesions, I think we should do a biopsy to know what it is. And on steroid, even the biopsy is going to get all screwed up there, but then I think it's still an attempt one could have done maybe.
Initially, in the first case, plasmapheresis was not considered. You started IVIG.
So there were some,
later.
So there were some logistic reasons why it was not done. This was a previous case already in follow-up at the center. But later on, after the second relapse, we started her on plasmapheresis. But one notable, the thing was in this case was even we have heard about steroid dependence, responsiveness in MOGAD cases, but plasmapheresis related flare-ups are rare. I have searched the literature, I think, max 2-3 cases with some flare-ups associated with plasmapheresis withdrawal have been seen, but it's not the usual scenario which is seen in such cases. And even if it is taxing for the physicians also. You stop plasmapheresis, again she relapsed. Like that.
It's an interesting case. Any possibility of vasculitic disorder?
Vasculitis.
First one.
So probably one is the systemic vasculitis was already ruled out. Secondly, she tested strongly MOG positive on 2 occasions. So that is why the thought shifted towards something with...
You gave endoxan, you gave all the vasculitis.
Yeah. That's it.
Any questions from the family? Thank you, Dr. Kamakshi, for an excellent talk.
Dignitaries on the stage to proceed for the felicitation. I request our President, Pankaj sir, for the felicitation. For the next session, I would like to call on the chair, Dr. L.K. Jha and Dr. Ashok Kumar. I would like to invite our speaker, Dr. Amitav Yaduvanshi.
Welcome, Dr. Amitav Yaduvanshi. Dr. Amitav is a senior intervention cardiologist and he's a chief cardiologist at the Holy Family. A lot of work in electrophysiology as well as intervention cardiology, and he's done good amount of work on, innovative work on renal denervation as well as ECMO. So I invite on the same topic of renal denervation.
Thank you, Dr. Jha, and thank you, EDPA, for giving me this opportunity. So, renal denervation therapy, what, when and how, this is the topic that I will be speaking on. So we all know that renal denervation is a new therapy that has come up of late as a treatment and management modality for resistant hypertension. But renal denervation per se is not very recent. It's started way back in 2011-12 where it came up with a big way, but then there were certain trials which were not very enthusiastic and the enthusiasm died. But now of late it has regained its reputation and is now part of many guidelines. So why do we talk about resistant hypertension? Because high systolic blood pressure is among the biggest contributor to global risk for death, and so high systolic blood pressure needs to be controlled. However, if you see this graph, the people who are aware of their high blood pressure, almost half of them are aware of their high blood pressure. Almost half of them are treated and almost 1/3 of them are actually controlled. So only 14% of total population of blood pressure hypertensive patients are actually controlled. And it is very important to control because even a 5 millimeters decrease in systolic blood pressure, office systolic blood pressure, causes very significant decrease in various cardiac events like heart failure, ischemic heart disease, cardiovascular death, etc. Reason for not adequate control is because often we require more than 2 or 3 drugs to control blood pressure in an individual, and as the number of pills increases, the chances of non-adherence increases. So we need to have something which is not patient dependent and something which is more reliable. So what is renal denervation? We all know that there is a sympathetic overactivity in many patients, and there is a complex interplay of renal afferents and efferent nerves where the renal afferents cause a change in renal vasculature which decreases renal blood flow. There is increase in renin production and increase in sodium and water reabsorption. And the renal afferent nerves, they increase stimulation of the hypothalamus and they also cause sympathetic overdrive, which again leads to hypertension. And when you do renal denervation, where these efferent and afferent sympathetic nerves are disconnected, there is a interruption of this pathophysiology and blood pressure decreases. So sympathectomy is not something which is very new. It has been there for quite some time, and there were papers from 1940s and 50s where we did not have very effective anti-hypertensive medications. So this was one of the ways of treating very high blood pressure, and it was definitely effective in decreasing the blood pressure, but obviously it had severe side effects. So what is renal denervation? It is a minimally invasive interventional approach to achieve the same thing. It supplies precisely controlled radiofrequency energy to the renal nerves. There is no permanent implant that is left behind, and it is independent of patient adherence. So this is a one-time therapy. You don't need repeated procedures. So patient compliance after the procedure is really not an issue in this, at least for this procedure. So how is it done? So right now there are two FDA approved methodology of doing it. One is the ultrasound based therapy, and other is the radio frequency based therapy. In our country we have Simplicity RF based catheter, spiral catheter, which is a new catheter that is available to us. It comes with its own specialized RF generator, and using this we do the renal denervation. It has been used in more than 25,000 patients globally for treating hypertension. So it is a simple catheter. It is a spiral shaped catheter with 4 electrodes, and it is compatible with the standard armamentarium that you use in our angiography and angioplasty. So 6F guiding catheter and 014 wire, which is available everywhere. So no specialized setup apart from the catheter and the generator is required. A single catheter can be used in arteries ranging from 3 millimeters to 8 millimeters, and since it's a spiral configuration, it does not occlude the vessel, so there is no danger of thrombus formation or ischemia. All the 4 electrodes are independently controlled by the generator, and if there is any drop in it continuously the temperature and impedance is monitored, and any change in the parameters which the machine detects as if out of range, the energy delivery to that particular electrode is interrupted immediately. So the new thing that has come up after the kind of failure of Simplicity 3 trial was they have now realized that most of the nerves, they are closer to the vessels as we go distally. Initially the denervation was tried only in the main vessel. Now the recommendation is to treat all the vessels, including the accessory renal artery if present in any patient. And this was confirmed in this trial, which is the IV trial, where they found that if main stem and the branch both are treated, the reduction in blood pressure is more significant. And it was confirmed by anatomical evidence of RDN efficacy using the stains, as well as the functional evidence of RDN efficacy, where this tyrosine hydrolase staining, which detects living sympathetic axon. So you can see post RDN, these nerves, they were destroyed. the candidates for renal denervation. This is what is called as resistant hypertension. However, there are patients who have uncontrolled hypertension with end organ damage. They are also suitable candidates for RDN. Uncontrolled hypertension and who are non-adherent to medications. There are so many patients who are just not taking their medications regularly. So it becomes an option in these patients also. And patients who are intolerant to medications where you cannot escalate the dose because of certain side effects, they also become candidate for renal denervation. So does renal denervation works? So there have been multitude of trials after the Simplicity Hypertension 3 trial. There have been multiple trials which use the radio ultrasound waves as well as the RF energy waves, and they have found that it is efficacious. So this is the trials where it was systolic ambulatory BP monitoring. So these are sham control trials, and you can see even with the radiance, which is the ultrasound based, and the spiral, which is the RF frequency based, you can see significant decrease in the systolic and diastolic ambulatory blood pressure, as well as systolic and diastolic office blood pressure when you compare it with the sham group. And the long-term efficacy has also been proved. So there are now multiple trials across the board, across the countries, not just single center trials, all across the globe, where the follow-up range from 3 years to 5 years, and they have found that there is a consistent decrease in the blood pressure post-renal denervation. Similarly, in all group of patients, be it diabetic, be it patient with AF, ischemic heart disease, isolated systolic hypertension, prior MI, stroke, all of them, the blood pressure reduction is seen in all subgroups. Now there are data for up to 10 years of follow-up, and it is found that even after 10 years, patients who had undergone renal denervation shows lower blood pressure as compared to the control group. So is renal denervation safe? Well, there is no device or procedure related adverse event in any of the spiral hypertension RCTs. There is 0 renal stent implants reported in more than 700 Simplicity spiral patients in the trials. Kidney functions remain stable, which is seen in the Medtronic GSR registry. So you can see across the board, even patients who are CKD or who are non-CKD, the GFRs remained stable. So it does not have any adverse effect on the GFR. So what is our experience in renal denervation? So there have been now various societies that have approved or recommended renal denervation in various population. So one such patient is a resistant hypertension and non-adherent patient. So this was a 65-year-old female, diabetic hypertensive for last 15 years, had multiple stents placed earlier. She lives with her divorced son who has long shift duties, so there is nobody to really take care of her medications, and she often forgets her medications. She presented to us with accelerated hypertension and transient left-sided weakness, and her brain imaging showed no specific abnormality. She was already on amlodipine twice daily, olmesartan, prazosin, aldactone, metoprolol, and she was started on NTG drip to control her blood pressure. And you can see her blood pressure was very high to start with, and even after NTG drip, it was still continued to be high. So this patient was taken up for the renal denervation. So this is the catheter. So this is the spiral thing, and it takes the shape of the artery. So depending on the diameter of the artery, it will open up till that diameter. And this is the RF generator, and this is the remote. And you can appreciate that there is a continuous monitoring of the parameters. So the temperature and the impedance is monitored. And if at any point of time they find that the impedance, there is some issue with any of the catheter, it gets switched off. So it is very safe and relatively foolproof technology. So this is how it is done. We have to do a renal angiogram aortogram to see that there is no accessory arteries. Then we target all the branches as well as the main. This patient had mild renal artery stenosis, so the idea is to remain away from the stenotes segment. Don't deliver energy in the stenote segment, and this is how it was done. Then this was the left kidney, then the right kidney, again the main branch in the stem. This patient was discharged with reduced medications, and after 6 months she was again admitted with acute coronary syndrome. And however, you can see that the blood pressure is reasonably well controlled, and we were even able to further decrease her blood pressures, and she has now completed almost 9 months of follow-up, and she is doing fine. Then another patient where BP is above target despite maximum therapy. So this was a 77-year-old priest with uncontrolled hypertension, paroxysmal AF, again CAD, TBD, post-PTCA, multiple stents, on multiple antihypertensive medications, came with severe low back pain and giddiness. BP was 180 by 124 on presentation. He has a postural drop of 40 millimeters with symptoms of giddiness. He is on cilnidipine twice daily, telmisartan, chlorthalidone, prazosin, aldactone, dilsem, sulfate reliefs, 180 once a day, and amiodarone 100 milligrams twice a day. So this patient also, similarly, we did the aortogram. We identified the branches, we identified the main vessel, we treated the branches as well as the main vessel. This patient actually had an accessory renal artery also, as you can see. So both the renal arteries were targeted on the right side, and subsequently we were able to decrease his medications. We were able to stop prazosin, which we thought was the primary cause of his postural hypertension, and subsequently he has been maintaining diligent blood pressure records, and the blood pressure is reasonably well controlled in this patient also. Then another patient that we did recently, uncontrolled hypertension, treated secondary causes. So this is very interesting patient. She has an uncontrolled hypertension. Her ejection fraction was 15 to 20%. Angiogram was normal. She had a severe left renal artery stenosis. We did a PTCA to left renal artery in January 24. And in fact, her ejection fraction improved from 15 to 20% to 55%. However, all across, there was gradual escalation of her antihypertensive medications, and her blood pressure remained high despite treating the renal artery stenosis. So this patient, we already had an angiogram earlier, so we did not do the aortogram. And then again, same thing, we took care of the right-sided artery, and this is the stented segment of the left artery. There is no residual stenosis, as you can see. And then we did the same thing, all the branches, making sure that we are away from the stented segment. And this patient had a very dramatic improvement. So you can see so many medicines. She was on Metolard, Dapavan, Secutan, Aldactone, Eslo. All of them had to be stopped. Next day, her blood pressure actually became 96, 99, 92 systolic. And she was discharged only on metoprolol 12.5 milligrams extended release and telmisartan 20 milligrams. And she is also doing well. And now she is on 40 milligrams telmisartan and 25 milligrams metoprolol. So renal denervation is complementary to lifestyle medications, and it is recommended to be done in expert centers. There are ways of identifying patients who may respond better to renal denervation, but again, this is an evolving field. And the population for renal denervation is quite high. So if you see the FDA level or the SKY statement eligibility, almost 25 to 35% of all patients with hypertension are eligible for renal denervation. So with that, I thank you all.
Thank you, sir, for your wonderful presentation regarding renal denervation. Most of the physician doesn't think regarding going for RDN for our patients. I think you have given the very much indication when to seek the help regarding the management in view of RDN. If there are any questions for sir, yes, sir, Dr. Rajiv, sir.
Excellent lecture. I just want to know if a patient is controlled on, say, 4 drugs, antihypertensives. So to reduce the pill burden, can we advise that patient renal denervation?
Yes, actually the trials, although they include so many patients, so there is a reduction of pill burden is not the primary endpoint of the trials. But there definitely there is a reduction in pill burden if you do renal denervation. And in fact, one of the indication, it's a soft indication, is patient preference. So even if the patient is controlled on even two drugs, 3 drugs, and he's a young fellow, he does not want to take medications lifelong. So patient preference, on the basis of patient preference also we can offer renal denervation in these patients.
And what is the cost of this treatment?
The catheter costs around 6.5 lakh rupees and 1 lakh, 1.5 lakhs additional cost.
So total around 8 lakhs.
7.5 to 8 lakh rupees.
Thank you.
Any possibility of primary or secondary,
Yes, secondary hypertension has to be ruled out. So primary aldosterone has to be ruled out. Renal artery stenosis obviously will be ruled out. So
the world literature, primary or secondary failures, immediate
failures, they call it responders. So they say almost 80 to 90% people respond to a varying degree. People who have very high blood pressures to start with, like these patients, unfortunately in India we do it as a last resort therapy. So these are patients who have otherwise not, so we saw dramatic response in that. So the higher the blood pressure to start with, the more dramatic is the response. But in a borderline situation, maybe the response is not. So that's why when you take the overall trial, the reduction is around 8 to 10 millimeters of mercury.
Dr. Makkar, please.
No, I think that answers my question. My question was on failure rates. Is it a 100% effective procedure?
It's not 100% effective, but I would say it is quite effective.
Quite effective.
At least in our experience, we have had 100% success.
Dr. Gupta, please.
Is it a operator-dependent procedure or is it a standard procedure?
Sir, a very good question. Actually, to start with this, when they had that initial first generation spiral, the Simplicity catheter, that time there was a lot of operator dependability, and that was one of the reasons noted of the failure of showing effect in the Simplicity 3 trial, because the catheter required a lot of manipulation and it was definitely operator dependent. But this new iteration of the catheter, it is quite ingenious design, and I don't think too much of learning curve is there in this.
Thank you, sir. Yes.
One of the slides where we have correctly, the ejection fraction improved from say 15-20% to 50%.
Yeah. So that was not post renal denervation. That was post renal artery stenting. That lady had a very low ejection fraction, probably a kind of an hypertensive heart disease. We really don't.
Hypertensive heart disease going to so much.
Sir, we actually did not have any answer to that, but we have seen sometimes these patients, especially young females. She is around 35, 36-year female, and once we cured her renal artery stenosis, her blood pressure for some time did come down, and her ejection fraction improved. But then her ejection fraction is now okay, but her blood pressure again had crept up, so we did the renal denervation.
Thank you. Very unusual.
Yes, sir. Yes, sir.
The procedure is covered in insurance?
Yes, some of the insurance cover. You have to tell them that this is the indication and these are the, so couple of our patients were covered by insurance.
Thank you, sir, for your wonderful presentation. I think with the next speaker is in line, so thank you, sir, for a wonderful presentation, and many more questions can be answered on the floor, sir.
Sure,
thank you, sir.
Thank you. Thank you so much.
Sir, for the felicitation. For the next session, I would like to call on stage our chairpersons, Dr. Viresh Prashant Mehta, Dr. RPS Makkad, and Dr. Amitabh Khanna. I would like to invite our speaker, Dr. Sameer Kuba.
Should I start, sir? Oh, yes. So next we have another eminent speaker, Dr. Sameer Kuba. Everybody knows him, and I know him personally because we've been in college together, and now he's one of the leading cardiologists, not just in Delhi, but in and around Delhi. He's been working for almost, 25 years now, Dr. Sameer? About years, and he's moved on from his interest in interventional cardiology to preventive cardiology. So he's going to talk about his topic. So over to you, Dr. Sameer.
Yeah, so thank you very much, sir. And I think I'm doing both intervention and clinical cardiology and have interest in both of modalities. I think practicing holistic cardiology is more important than anything else. And so the topic for today is managing hyperkalemia or maintaining optimal RAS inhibition, tackling the dilemma of heart failure treatment. I think all of us have seen patients with cardiometabolic disorders, heart failure, kidney disease. We want to give them RAS blockers, but somehow or the other hyperkalemia becomes a problem. It's common. So I'll not go into much details about heart failure guidelines, but just focusing on this fact that these are the 4 pillars of therapy which we all know and are class 1 indication in management of heart failure, especially with reduced ejection fraction. RAS blockers, SGLT2 inhibitors, beta blockers, and the MRAs. And why are we talking about GDMT? Because it is shown to prolong life and improve mortality. So if you give all these 4 drugs, you gain 6 years of life. But the real world scenario is slightly different, and we are challenged by a lot of issues, and many times we are not able to use the all 4 pillars of therapy. And one of the reasons is hyperkalemia. And this is one drug which immediately goes off board the moment hyperkalemia develops. Only 33% of the eligible patients are prescribed MRAs, and they are wonder drugs, great drugs, lot of evidence. But somehow or the other, the moment the potassium goes up, these drugs are off board, and second in line are the RAS blockers, ARNI ACE inhibitors. Now, what is hyperkalemia? A level more than 5 is hyperkalemia, 3.5 to 5 is normal, less than 3.5 is hyperkalemia, and both of them are dangerous. And the moment hyperkalemia happens, we take away these drugs or reduce the dose of these drugs. But the important thing is, if you actually either take away or reduce the dose of these drugs, the mortality goes up. And many times what happens is, once you take away these drugs, reinstitution of these drugs becomes all the more difficult. We know that hypokalemia can be because of many factors like diarrhea, chronic treatment with diuretics, aldosterone production, alkalosis. And hyperkalemia can be because of reduced kidney function, chronic treatment with RAS blockers, and also acidosis. Now, who are the patients who are more prone to hyperkalemia? CKD patients, heart failure patients, dialysis patients, diabetic patients. We were talking about hypertension. Many times resistant hypertension patients need to be prescribed MRAs, and that may be one of the causes of hyperkalemia. The moment your actually EGFR reduces, patients develop heart failure, patients are on RAS blockers. It has been seen over 3.5 lakh patients in the Stockholm study that hyperkalemia actually did go up, and more so with increasing risk of renal failure, and it causes more mortality, about 5 times higher AMI mortality if the potassium is between 5 to 5.5, and more than 5.5 potassium leads to a 12 times higher mortality. And not only mortality, the rehospitalization also increases. So if you have hyperkalemia today, the chances of you having hyperkalemia again are high. And not only rehospitalization, the second or the third episode of hyperkalemia happens at a much shorter interval. So see this study, this is CKD 3 to 4 patients. The first episode of hyperkalemia occurred at about 42 days in 56% of patients, but look at the next episode, 35 days, 59%, 26 days, 61%, and then again 26 days. So what happens is, once you have a hyperkalemia, the chances of having recurrent hyperkalemia are higher, and it happens at progressively lower intervals, and then again chances of getting admitted and treated by the potassium lowering therapies increases. And then again, this is another problem. Most of the times, unless and until you have a severe hyperkalemia, you are not retested again. So mild to moderate hyperkalemia, the retesting rates are around 4% to 5%. But if you have a severe hyperkalemia, still only 50% were retested. So that is also another important thing. And this is data, so it's not something which is made up, and it is very, very common. So now, what do we do when a patient presents with hyperkalemia? IV calcium gluconate, insulin dextrose, beta agonist, and dialysis at times when it is required. We all know that. But the problem with all these therapies is that, except for dialysis, is that they do not actually lower the serum potassium levels. They just cause a membrane stabilization or have a redistribution of potassium from the extracellular to the intercellular space. So they are not proper treatments. Dialysis is the only thing which can do, but sometimes in the dialysate also you can have a high potassium fluid and you can have hyperkalemia. So emergency management strategies are temporary. There are certain agents which can remove the potassium, like diuretics, which we commonly use, but again, the effect is delayed and they are indicated for patients more so in volume expansion, and it depends upon the renal function of the patient, and many times the renal function may actually deteriorate. Dialysis, again, I have already mentioned, and K-bind or calcium or sodium polystyrene sulfonate is the most common drug which we commonly used, but its onset of action is relatively delayed and the effect may last for 4 to 6 hours, then you have to replace it. It has some GI intolerance, some adverse effects in high doses, so there are challenges with this drug also. Also, it causes constipation and certain other things which can be a problem. So it is not appropriate for an acute treatment. It can be given on an OPD basis and then you have to wait for a longer period of time. And wherever possible, you want to avoid dialysis. First and foremost, dialysis is not available at all centers, and these patients are sick patients. They can present at any point of time during the night. They may have associated frailty, etc. So dialysis may not be a very, very feasible option for them at times. And again, you have to put a central venous catheter, and these are also associated with their own sort of complications. So low potassium diet is one thing which is important, but you see the irony. Normally we advise a high potassium diet for hypertension, for prevention of cardiovascular disease, for better cardiovascular health. But the moment hyperkalemia sets in, we want to reduce the potassium. So lowering the potassium in the diet is very frequently explained by us to our patients, but the corollary is that you want to actually keep a decent potassium level for the overall cardiovascular health. And most commonly what happens in a high potassium level is you discontinue the RAS blockers, and that is a problem because discontinuation or reduction in the dose is also associated with higher long-term mortality. Now see, this is the data which actually shows down titration following a hyperkalemia event is very, very common. So mild hyperkalemia, 38% of the patients were either down titrated or discontinued. For moderate to severe hyperkalemia, 47% of the patients discontinued. So I think this is very, very important for us to understand. This slide also shows that not only discontinuation but also down titration is associated with almost as similar risk. 55% increased risk if you discontinue the drugs and 51% increased risk if you down titrate. So both down titration and discontinuation are equivalent. And another problem is once it happens, the reinitiation is also a challenge. So only 10% of the patients will be reinitiated, and this is evidence from the US real world evidence study, almost 25,000 patients. So this is also very common in our practice. And we know that non-compliance is associated with increased mortality, also with increased morbidity, and it is true for all the three drugs, the MRAs, ARNIs, and the SGLT2 inhibitors. So now, what do we do at this point of time? Is there something wherein you don't need to stop or down titrate these drugs and use something which can actually do benefit and maybe give you benefit over a long period of time? So this is a newer molecule which is sodium zirconium cyclosilicate, and this has recently come into the Indian market. It was approved in 2020 in Sweden and it has been used abroad, but this has been launched in India just on 1st December. So this is a molecule which is an inorganic crystalline potassium binder. And what it does is it goes to the gut and it exchanges the hydrogen and sodium for potassium. So it doesn't get systemically absorbed. It is a crystal, as you can see on the left side, and it binds all the potassium that is available and excretes in the feces in exchange for hydrogen and sodium. So this is something which is, and it doesn't actually exchange for water, so it doesn't cause the common side effect of constipation which is seen with the calcium binders like the resins which we commonly use. So the mechanism is highly selective for potassium, also for ammonium, because these two molecules have similar sort of pore size, less so for sodium and other molecules. And this molecule acts all across the intestine, not only in the colon, unlike the resin. So it acts across the whole intestine and results in a relatively early hypokalemic effect. So it's a good emergency drug. And in fact, potassium is exchanged for sodium and hydrogen. Rarely, because of this exchange with sodium and hydrogen, sometimes a rare hypernatremia can happen, but more often than not, it doesn't happen. So what are the clinical trials? This is a harmonized trial and also the extension study. So this harmonized trial was actually done in patients with hyperkalemia across nephrology, cardiology, and general research sites, wherein potassium of more than 5.1 was treated with 10 gram thrice a day dose of this drug for 48 hours. So first 48 hours you have to give it thrice a day, And then it was a 28-day maintenance phase in which the drug was given in an OD dose between 5 to 15 grams. And then after 28 to 29 days, there were two groups which were actually looked into. One was in which after achievement of normokalemia, which is 3.5 to 5 potassium, the patient was continued on this molecule and re-evaluated at 11 months. And there was another group wherein the drug was stopped at the maintenance of normokalemia. And what they actually wanted to look was the acute reduction in the potassium and also the maintenance of normal potassium levels over a period of 11 months. Like I already mentioned that if you stop the drug, usually also the hyperkalemia has a tendency to recur, and many times we may not be able to reinstitute the drug, and at times we may even forget. So they tried to look at the acute effect and also the chronic effect. Patients undergoing dialysis were excluded, patients with severe cardiac arrhythmia were excluded, patients taking treatment with lactulose and certain antibiotics, diabetic ketoacidosis, pseudo-hyperkalemia also were excluded. The most striking point was that the potassium levels started to decrease significantly very, very early within 1 to 2 hours, and the median time for potassium normalization was about 2.5 hours. And by 48 hours, almost 88 to 98% of the patients had achieved a normal potassium level. And then it was made an OD dosing, and then they looked at the primary endpoint. As you can see, the primary endpoint was achieved in almost all patients, potassium levels normalized. And if you look at the right side of the slide, this is the 11-month treated period wherein all the potassium values are in the normal range, and the moment the drug was stopped at 337 days, the potassium levels again started to go up. So a good drug for acute management as well as for chronic therapy. Now this was another trial. This was a RELIZE case study. This was specifically done for heart failure patients with reduced ejection fraction who had hyperkalemia or who were at high risk of developing hyperkalemia. So two category of patients, 336 patients, NYHA class 2 to 4, LV ejection fraction less than 40, who were either on a no or a low dose of mineralocorticoid receptor antagonist spironolactone. So one group had hyperkalemia documented more than 5, eGFR of more than 30. So whenever you have to initiate a MRA, the eGFR has to be more than 30. And then this drug was given on day 1, and the other patient group was normokalemia but who is at a high risk. So again they gave this drug, and then they followed this period over the period of 6 months. And the second cohort, especially look into the second cohort, there are certain patients who may have normokalemia but they are at high risk of developing hyperkalemia, and these are the patients who have a history of hyperkalemia more than 5 potassium within prior 36 months and eGFR of more than 30, or serum potassium somewhere between high normal range 4.5 to 5 and eGFR of 30 to 60 with an age of more than 75. So despite a normal potassium, these patients are at a high risk of developing hyperkalemia, so they were also given this drug and then followed up for a period of 3 to 4 weeks. If the potassium levels didn't rise, then the drug was stopped. And then the specific therapy of ACE inhibitor, ARNI or ARB were given, beta blockers were given unless contraindicated. And as you see, over a period of 6 months, 72% of the patients on this drug actually maintained the potassium level, while only 35% of the placebo did. So there was a 4 times higher chance of maintaining a potassium level or a normal potassium level and also continuing the MRA therapy. So both the continuation of MRA therapy could happen, normokalemia was maintained, and dose reduction was also not required. 49% relative risk reduction in the time to first episode of hyperkalemia when compared to placebo. 63% relative risk reduction in the time to first instance of spironolactone dose decrease or discontinuation due to hyperkalemia with this drug. So you have evidence of acute as well as chronic therapy advantages with this molecule. These are the advantages I'll repeat. So it happens within 1 to 2 hours, and most of the times within 24 to 48 hours you have complete resolution of hyperkalemia, and then you can give a maintenance dose. And then you can maintain it over a period of 11 months. These are some of the studies which showed that not only you could continue the RAS blockers, but you can actually increase the dose of RAS blockers when you are using this drug in addition. It's a safe drug, has certain side effects. I would like you to spend some time on this slide. We must know the advantages, caution and adverse effects. You can have hypokalemia with this molecule because it's a very potent drug, acts at the level of the intestine and has almost 9 times higher binding for potassium when compared to the resins. So it can cause hypokalemia, watch for that. Because it exchanges sodium in addition, it can cause hypernatremia also, although very rare. Diarrhea is more common with this molecule when compared to constipation with the resins. Another advantage of this molecule is that it improves the sodium chloride anion gap. So that is a surrogate marker for acidosis. So it improves metabolic acidosis, which may be an advantage of this drug in renal failure patients who have acidosis. So many times you give them drugs like Nephrosev and other things to increase the bicarbonate level. This drug actually can increase the bicarbonate level and also the ammonogenesis at the level of the kidney. At times, it can cause edema and hypertension because of the sodium exchange, and that was seen in some patients, especially who had a higher level of anti-proBNP. So use it in caution and wisdom with your heart failure and CKD patients and watch for the development of edema. It can reduce the need for emergency dialysis. That is very important. And also the need for a central venous catheter placement in conditions of acute hyperkalemia, especially where dialysis is not available or contraindicated or patient is a very high risk. So that is one other important advantage. 2-hour principle is very, very important, that don't give any drug between 2 hours before and after this molecule, because the gastric absorption and the pH can actually cause drug-drug interaction and delay the absorption of other drugs. So these are some of the differences between these two molecules which I've already mentioned, and in the interest of time I will say that this is a drug which can actually be of great benefit in the times to come. Obviously you need to know the nuances, the adverse effects, the advantages of this drug. Usually well tolerated, and most of the times you can continue the RAS inhibitor blockage with this drug. Offer value for money. There is some data from the US that even if you are able to prevent 1 or 2 episodes of hyperkalemia, you can prevent hospitalizations, you can actually reduce the cost over a period of time. The one sachet of this molecule costs about 600 to 700 rupees in India. But again, we have to see it in the Indian context. The kidney guidelines strongly recommend that you continue the RAS blockers, because the phenomenal advantage the patients are offered by RAS blockers is great, but the moment potassium level rises, you tend to stop it or you need to reduce the dose. That should not happen. And there might be a tendency of using this molecule. This is the, I would say, the usual guideline. Look at the associated drugs which are causing hyperkalemia, stop them, and look at potassium binders and their side effects, and try to use this molecule wherever possible in the right subset of patients. And so to conclude, one of the barriers in achieving optimal GDMT in heart failure is hyperkalemia, which leads to early discontinuation of RAS blockers. MRAs are the first drugs to be taken off. In many cases, these mortality reducing RAS inhibitors like ARNI may also not be reinitiated, and hyperkalemia is often recurrent, becomes a frustrating challenge, and many times you stop these drugs. Traditional potassium lowering therapies for acute like calcium gluconate, beta agonists, your nebulization, and other things, the resins have their own limitations. And balanced potassium diet is something we want. We want a high potassium diet. DASH diet recommends high potassium for prevention of hypertension, cardiovascular disease improvement. But the moment a kidney failure happens, we are forced to reduce the potassium in the diet, which I think is a wrong idea. I think we can have discussion on that. The most advantage, the beautiful advantage of this molecule is it's a very fast acting anti-hyperkalemic agent and a good emergent hyperkalemia reducing drug. Causes less constipation as compared to the resins, usually has an OD dosing as compared to resins which have BD or TID dosing. It can become a therapeutic agent of choice for even prevention of hyperkalemia and CKD. We need to see that. And many patients of diabetes have a type 4 renal tubular acidosis, wherein you have hyperkalemia persistent, you want to use RAS inhibitors and MRA. So maybe using these drugs along with this molecule over a long period of time can become the standard of care in these patients. So thank you very much for your patient hearing, and I'm sorry to have exceeded the time.
Thank you, Dr. In a very short time, you have told us about this new molecule, and it appears to be a very missing molecule. So now the session is open for questions and comments.
Not lead to increase in potassium level. And then if you use this salt and you can give for 11 months, so frequently we should set the potassium level. And I think it is not easy to monitor the potassium level for such patient for a long time. So basic thing responsible can we correct it slightly?
Yeah, that's a very important question, sir. And I think we must look at all causes causing hyperkalemia, NSAID use, diet, and I think in maybe 30 to 40% of the patients, you may be able to find a precipitating cause for hyperkalemia and treat it. But many times we have seen that this hyperkalemia is recurrent, and somebody who develops this keeps on developing it. In those patients, you get frustrated. You can try everything, but still the potassium is high. Like you can combine an ACE inhibitor, ARNI, with an SGLT2 inhibitor. You can use finerenone, as you rightly said, it is better on potassium. But despite that also, many times with the progression of chronic kidney disease, with the dietary patterns which the patient is not able to follow, polypharmacy, still the potassium remains a challenge. So you need to recheck it if it is mild to moderate, maybe 4 to 6 weeks. And the idea of these trials, these are all preliminary trials. I mean, they do not recommend, the guidelines do not recommend that use this drug right, left, and center. They just say that you have a drug now wherein you can try and continue with your effective RAS blockade. See, we see patients, all of us know, the moment hyperkalemia happens, you try once or twice, happens, you stop the MRA. And then the patient comes again, still it is high, you reduce the dose of ARNI or ACE inhibitor. It is common and it is practical. Somebody who is coming to you regularly, is an educated family, is following the diet, they may be very religious and they may be able to control, but still there will be a category of patients who will not be able to achieve normal potassium levels. So this is a available new molecule in the armamentarium of drugs which can be used. Yes, you have to be cautious about edema development, heart failure development, hypernatremia, hypokalemia. There are certain adverse effects also associated with this drug. So once we start using it, we'll come to know more about it. Our nephrology colleagues are using it more commonly than us, and it has become available in India just now, this December. So our experience is still very limited. Once we start to use it more and more, we'll be able to actually, but the data is very promising. And if you are able to prevent a dialysis, if you are able to reduce the potassium level fast within first 24 to 48 hours, you can prevent cardiovascular mortality and other things.
So it is approved for high-risk patient as primary prevention also.
So the guidelines do not approve it. It is just said that the data which I mentioned, the Harmonize and the Realize K, the trials were made in such a fashion that even at patients who are at a high risk of developing hyperkalemia, identify them and maybe try to use this molecule in addition. But in my opinion, I think it should not be the way forward as of now. As of now, restrict its use to patients who are developing hyperkalemia and you are not able to actually control that hyperkalemia, or you are forced to reduce or stop RAS inhibitors, MRA, or the ARNI ACE inhibitors, because nobody wants to stop it. Because we have seen there is enough data now to prove that continuation of RAS blockers improves mortality. So if you are able to use RAS blockers in addition with combination with this and maintain a potassium levels, let us try and do it.
Dr. S.K. Gupta has a question.
Where do you place this molecule vis-a-vis the available agents like calcium polystyrene and all those things? You must have compared the data of the old potassium binders with the new one, and where do you place it? You feel that it is going to replace them, or we still need to have more experience with the drug?
The K-bind and other drugs, sir, which we use, they have a very delayed mechanism of action, and you have to use it twice a day usually. And they have certain side effects like constipation, and also the literature reports certain cases even of intestinal perforation and necrosis. I haven't come across any such side effect with these drugs, but we use it very, very infrequently and maybe for 2-3 days, and then we stop it. Metallic taste is there, patients are not able to tolerate it very well beyond a period of time, and then you stop it, and as I mentioned, some of the patients who have hyperkalemia tendency again develop hyperkalemia. So this molecule is actually safer and faster, better tolerable also, because it doesn't have an exchange with the water, so it doesn't cause constipation also, which is a very common side effect of resins. And another advantage is it's an excellent drug in acute hyperkalemia. Resins will take their time. Suppose somebody comes with a potassium of 6, has ECG changes. You want to do something like a dialysis and things like that to improve the potassium, besides giving calcium gluconate and other things. But if you have this drug on board, within 2 hours the potassium starts to reduce, and by 24 to 48 hours the potassium is normal. So you can avoid a dialysis, you can avoid placement of central venous catheter. I was reviewing the articles, so they said that if you use this drug in comparison to the resins, probably the chances of patient requiring a dialysis reduces, and even if it doesn't require a dialysis, you at times need to place
a CVC catheter, which also has its own complications and other things in non-experienced centers. So it's a costly drug for sure, but it is safer, more effective, and I think it scores over resins in many aspects.
Those you can't afford, we can initiate the drug and continue with the previous old drugs.
Yes, yes, and then you can, maybe you just require it acutely and don't need to require on a regular basis. Acute hyperkalemia, treat it and just stop it, acute renal failure. What I'm talking about a long-term continuation is in those patients who are continuously on RAS blockers, have HFrEF, have CKD, and have this potassium 5.2, 5.3, 5.5, and you are worried. So in those patients, you can continue over a long period of time also, obviously with careful monitoring.
Thank you.
So, Dr. Sameer, any difference in dosing in patients who are on dialysis versus non-dialysis, especially patients who during the dialysis day or when the patient is not on dialysis, any difference in dosing?
Yeah. So actually, the trials excluded patients on dialysis, but if you look at the package insert, it can be given to patients on dialysis, especially on the day when the dialysis is not being done, and maybe you can reduce the dose in those patients. So you have to titrate it. Even 2.5 gram has been used in certain patients. So between 2.5 to 15 grams you can use it, and you can use in dialysis patients also as per the package insert. The trials excluded dialysis patients.
Interesting molecule. Thank you, Dr. Sameer Kubba, for enlightening us. And with this, we conclude the session. And over to Dr. Pankaj.
Last comment, right? How you're comfortable with potassium, the upper limit of potassium in your patients having structural heart disease without ECG change, subtle ECG changes. So how upper limit of potassium you are comfortable with?
Come again, I could not understand.
So what is the upper limit of potassium which you are comfortable with in a patient with structural heart disease with no ECG, subtle ECG findings? That all T waves and all other changes.
See, if you look at the trial, hyperkalemia was defined as potassium more than 5. Yeah. If you look at American and the European guidelines also, there's a difference. Americans tolerate even up to 5.5. It's okay.
Yeah.
Now, for us, I think the practical tip is know your patient very, very well. There are certain patients who will just not follow up with you. So, and there are certain patients who will be religious to follow up. I am okay with a potassium of 5.5 also if there are no ECG changes and the patient is on a regular follow-up. But if it is more than 5.5, we are concerned.
Dr. Jha, your comments, Dr. Alkeja, your comments on that upper limit of potassium, yeah.
And he had a potassium of, again 6.4 he had, and within 24 hours I could see that there was improvement in potassium for that patient specific. But he discontinued after 3 days. We did not continue. I have asked him to come again on Tuesday with a fresh. So
yeah.
We started using just new. How frequently are you monitoring these patients? Day one, it was 6.4. So I called him again the next day. 24 hours and then 48 hours again. So the 24 hours report only was okay. It was just 5. So I've asked him after stop. 3 days has taken now. I've asked him to come on Monday or Tuesday. He'll come with a fresh, without the drug now. Now without the drug. Almost 1.5. Almost 1.5, around 1 plus.
अब वो मैं slides जो दिखाई थी वो मैं जल्दी में पूरा नहीं दिखाया, but the first and the second day dose is 10 grams thrice a day, and after that it is once a day, and the potassium level starts to fall by 0.2 over 1 hour, then 0.4 over next 2 to 3 hours, 0.6, 0.8. By 24 hours, almost 80% of the potassium level, 80% of patients achieve normokalemia, and by 48 hours, 98%, as per the trial. Our experience is very limited. As Dr. Jha said that you monitor the potassium next day and next day. When we use K-bind in OPD basis, we don't ask the potassium to be done the next day because we know that it is not going to fall. But if the patient is admitted with us and we are using K-bind and other things, we do the potassium every day. But herein you can actually do the potassium every day, at least for first and second day, and you have enough data to suggest that the potassium. Yes, there is a risk of hypokalemia, especially. See, it's very, very potent. Its potency in binding potassium is 9 times higher than the resins. So you can understand that the potassium binding efficacy is more, so hypokalemia risk is also there. And the extension of the trials which I am mentioning was those patients who had achieved normokalemia. The potassium was between 3.5 to 5. Still they were continued in one arm of on Localma and the other arm was placebo. So be very careful about potassium, especially in heart failure patients, kidney patients, because hypokalemia can lead to VT and other issues also. So I'm not saying it's a Ramband or a magic drug, but yes, phenomenally, I think the biggest advantage of this drug would be an acute management of a hyperkalemic crisis. You can avoid dialysis, you can give this drug, you can give it TDS for 2 days, 3 days, and then you can monitor your patient. That is one biggest advantage which you cannot have with any other drug. And then you can continue with the RAS drugs. Yes, continuation of the RAS, very fast acting drug. But whenever you're using for a long period of time, you must be cautious and you will come to know certain other adverse effects which are not reported. So, I mean, it's important to have a balanced approach.
So I think it's a very interesting session, and compliments to Dr. Samir, and you've been always been very elusive and very practical things that we have seen. So thank you, Chairperson, for this session, and I request Dr. Lalit to honor our speakers and chairpersons. We can have a group photo first. A group photo. And now I request Poster and Paper Awards. I request Dr. Shubha Lakshmi to announce the awards. Dr. Ashok, you can also join.
So for poster and paper presentation, we have 11 papers and 11 posters in the morning. 2 sessions of poster and 2 sessions of paper presentations were there with various external panelists judging the paper and poster. You want to add something? So for first, I will be announcing the result of poster presentation. Third prize goes to, it was a tie, Dr. Rahul and Dr. Kriti, Dr. Kriti and Dr. Rahul. Third prize for poster presentation.
Dr. Rahul, please come on the stage.
Yeah, please come. Second prize goes to Dr. Neha and third goes to Dr. Shivangi. Dr. Rahul is there. Sir. Yes.
एक ही ट्रॉफी है ना? कौन सी? हाँ कृति हमारी हम ले लेंगे, हम दूसरे दे देंगे। Dr. Shivangi for the second.
Dr. Shivangi is first in poster presentation.
Poster first. Poster first. Poster तो first ही है ना?
हाँ, ये सही है देखो.
बड़ी वाली गाड़ी.
And now moving on to paper presentation. I will be announcing the result. Please come forward for the this thing. So third prize goes to Dr. Kaustubh. Please come. Second, third, na? Second tie, Dr. Lucky and Dr. Vishal. Dr. Lucky is there. ये हैं, ये दोनों साइड कवर कर रहे हैं. Dr. Lucky is here. Dr. Lucky is not there. Dr. Vishal, हाँ सेकेंड ये दो क्या है दो है। ये कौन सा बच गया बेटा ये सेकंड तो दिया है हमने सेकंड वो कौन सा and first prize goes to Dr. Ankit. So now, Neha, हाँ ठीक. So now we have completed the poster and presentation prize. Over to Dr. Pankaj sir.
Dr. Swati. Thank you. Dr. Paras, I think we have concluded. We have done with this conference. So thank you very much, Dr. Swati. To you, Swati.
मैं चेंज करके आपको दे दूँगी.
I thank all the executive members of EDPA, all the delegates who made this conference successful, and all the faculty who took out their time and delivered these wonderful lectures in our annual conference. I also thank all the support staff and the hotel management and all our sponsors for sponsoring our sessions. Thank you all. I also thank all our guiding force, our seniors, and all the past presidents of EDPA. I wish to have many more successful conferences like this. Thank you.
अभी आई है थोड़े लोग रेडी हो रहे हैं थोड़ा एनर्जाइज हो रहे हैं वेलकम भाई वेलकम आओ चलो आओ जंप करें जंप तो जरूरी है ना हाँ बकर हमारा जंप आ जाओ चलो जंप करो आ जाओ जंप जंप आ जाओ घुटने तो टूटे पड़े कैसे आपके कैसे टूट जाएंगे